25% time in range, almost about 6 hours below the target range of 180. 50% time in range, 12 hours below the target of 180 and 70. 75% again, and 100% the whole time, the whole 24 hours you have 170 to 180. And this is the TIR predictor of long-term diabetes complications as far as the DCCT trial is concerned, again published in 2019. And depending on the percentage of time in range, if it is less than 10%, the chances of retinopathy are almost about 58%. And if it is greater than 70%, the time in range 70 to 180, it is less than 5%. So this is another very landmark thing which occurred in the DCC trial and it was published in 2019. This is again a predictor of long-term diabetes complications. Again, in this you can see the microalbuminuria level. If it is less than 10%, the target time in range, then chances of albuminuria are almost about 27%. If it is greater than 70%, only about 3% chances of microalbuminuria. This is again with regard to the diabetic retinopathy, as non-diabetic retinopathy, mild proliferative diabetic retinopathy, moderate NPDR, and vision-threatening DR. So as far as the vision-threatening DR is concerned, if it is less than 51%, the time in range, chances are much more for the development of vision-threatening DR. Again, this is the same thing, prevalence of DR by severity as a function of TIR quartile. And if it is less than 50%, of course, you have got greater chances of development of retinopathy, the vision-threatening diabetic retinopathy. So now patients with similar HbA1c levels could have distinct glucose profiles. For instance, one patient could have long periods of both hyper and hypoglycemia, whereas another could have a stable glucose pattern throughout the day. By contrast, TIR illustrates the time spent in the preferred glucose range, which is an intuitive way of assessing glycemic control, and it provides important information not captured by HbA1c levels. The study suggests that TIR is an intuitive metric of glycemic control for both patients as well as for clinicians. Time in range in relation to all-cause and cardiovascular mortality in patients with type 2 diabetes. This is a prospective cohort study, and TIR was again measured, TIR greater than 85% and less than 50% for groups. And you can very well see that causes of mortality are much less when the TIR is greater than 85%. In conclusion, this study found a strong and graded inverse relationship between TIR and risks of all-cause and CVD mortality among patients with type 2 diabetes. The findings suggest that patients with diabetes could be encouraged to aim for an achievable higher target time in range to reduce the risk of adverse complications. There are time in ranges, and the normal glucose range for individuals with diabetes is usually reported as between 3.9 millimoles per liter to 7.8. Thus, the upper and the lower limits for determining TIR are not very synonymous with normal glucose levels. Rather, the choice of upper and lower glucose thresholds for determining TIR is at least pragmatic. And it is again the time in ranges, very high when it is about 14% and greater than 14 millimoles per liter, and very low, less than 3 millimoles per liter of glucose, 5%. So consensus is that there should be separate targets for individuals with type 1 and type 2. For more patients with TIR greater than 70% with a TBR of less than, target below range should be less than 3.9 or 4%.
Time is up, sir.
Just I am coming to the final slide, sir. So finally, the take-home message could be the TIR control greater than 50%, hypertension control, prevention of abdominal obesity, which is a very important thing, dyslipidemia control, prolonged fasting, as our Rishi Munis used to do during the previous days. Keto diet, again it has to be monitored by a clinician. Avoidance of alcohol, tobacco and drug abuse, regular exercise and yoga, stress management, and drugs like SGLT2, GLP-1 and GIP. So with this I conclude. Thanks for a very patient listening.
Thank you for taming the time frame, sir, and illustrative talk. Now house is open for a few question query from audience. A few.
Three words. Mic का नहीं जरूरत है, रुको ना, हम ऐसे बोलते हैं. We have got 3 words. One is prediction, One is prevention and one is prolongation or progression. So at the moment, with our current knowledge, are we in a position to predict diabetes? Suppose 10 patients come to us, they give you consultation and ask you, what is the chance of my developing diabetes? Are we in a position to predict?
I think we are in a position to predict, sir. We have to follow up the patient. One reading can be very normal, and I have given the A1C. A1C is not a very strong indicator. We have to find out the target in range, and for that, continuous glucose monitoring should be essential. So I think we can predict.
What will be the basis of prediction? Prediction at the moment. कि हमारा ये है, ये मेरा blood sugar है, ये मेरा hypertension है, ये मेरा obesity है, ये मेरा lifestyle है, कितना chance है मेरे diabetes होने का? ये
Sir, that is dependent on individual patient, and you have to follow up the patient for a very long time for that.
Sir, if HbA1c is high and glucose level is low, and if HbA1c is low and glucose level is high, how we can predict the patient is diabetic and how we can treat the patient?
It again depends on individual patients. A1C, I told you, is not a strong indicator. Of course, it is. It can be a future indicator for microvascular complications, for for the retinopathy, for everything. You can have a A1C level, but again, it depends on the individual, because it is not. I have been diabetic for almost 10 years, but I am not taking any drug because I do a lot of exercises. I exercise for almost half an hour every day, religiously. So that is, I mean, and of course you have to provide, I do prolonged fasting. I take only 2 times a meal a day, and my blood sugar levels are normal, and my HbA1c is also about 6.5 to 7.
Time is up.
The best thing is,
Sorry.
for your answer, is continuous glucose monitoring. This is the first
Yeah,
one.
CGM is
and
the
this
most
should to be,
important.
it is very important because the HbA1c is low and the random sugar is high. We have to predict whether it is diabetic or not. As per the WHO guideline, more than 200 random sugar is diabetic, and if the HbA1c low, you have to go for the CGM. This is the way.
HbA1c is not a marker.
Sorry,
It's not a it's not a predictive marker.
we are going to conclude this session successfully. You can have a discussion separately.
Thank you very much.
Just a note that we have the Indian Diabetes Risk Score to calculate the diabetes risk in our patients, those patients who are not having diabetes and have high chances of developing diabetes. I would like to thank the chairpersons and the speakers for an elaborative session and throwing some light on lesser discussed topics in academic forums. Now I request the chairpersons and the speakers to move to the side stage for felicitation. Moving ahead to session 2, I would like to call the moderator, Dr. Neeraj Sinha, who is consultant endocrinologist practicing in Patna. I would also like to call the chairpersons, Dr. Sachendra Chaudhary, Dr. Sanjay Singh, Dr. Mahendra Pratap, and Dr. Anuj Kumar. Sir, over to the chairpersons and the moderators.
Very good morning to all of you. We know that we treat diabetes mellitus in order to prevent the complications of diabetes mellitus. So basically, treatment of diabetes mellitus is a preventive strategy. In this session, we would be focusing more on prevention of diabetes and its complication, and we would also be knowing about different kind of diabetes. So in this session, we will have discussion on prevention of diabetes. We will also discuss the role of fibers. One of the less focused aspect is role of fibers in diabetes mellitus. We would also understand the synergy among the risk factors of diabetes mellitus like hypertension and dyslipidemia. And also we are always confused among the terms type 1, type 2, type 3. So we would have some discussion on type 3C diabetes also. What is it and how its treatment differs from other kind of diabetes mellitus. So I welcome all chairpersons and all speakers for this session. Now over to chairperson. Sir, to start the session.
Now, the first speaker in this session 2 is Dr. Supriyo Mukherjee. He is a versatile speaker. He can speak on any topic, any moment. This time, his topic is risk factor synergy, including hypertension, obesity, lipids, in diabetes, a review. Over to Dr. Supriyo Mukherjee.
Thank you, sir. Thank you for your very kind introduction. Good morning, everybody. Thank you, RSSDI team, for inviting me in this August gathering. My topic, risk factor synergy, diabetes, hypertension, obesity, and lipid. A review. This is basically a review, and I declare that I have no conflict of interest, and these are the references from where I got the slides done, and I made the review. This is the agenda which I am going to present to you. That is cardiovascular burden in type 2 diabetes, cardiometabolic risk factor synergy, why risk multiply, can this synergy be disrupted, lessons from paradigm shifting trials, modern organ protective therapy, from glucose control to phenotype, matched risk detected care, and then the grand summary, therapeutic synergy saves life. So with that, for decades, diabetes care centered on a glucose-first philosophy, as if HbA1c lowering alone would prevent complication. This belief may be influenced probably by the DCCT trial and in type 1 diabetes, where microvascular benefit from intensive glycemia was clear. But if you remember those trials cohort, it was absolutely different. And UKPD established glucose control as a first pillar of diabetes care, and that was, there is no doubt about it. UKPD 35 showed a continuous, long, linear relationship between HbA1c and macrovascular complication risk. But this was not with the macrovascular complication. What we see, that cardiovascular events and mortality remained very high despite good glucose control. And this revealed that why glucose alone was not enough. Other risk factors like blood pressure, lipid, obesity, albuminuria, and smoking also drives the way. So, therefore, improving outcome required addressing multiple cardiometabolic risks together, not glucose alone. This realization set the foundation for the concept of risk factor synergy. This is basically why this matters, because it remains the leading cause of death in type 2 diabetes despite improved HbA1c control. I request you, please, Dr. Vijay, I request you all, please sit down. And then, hypertension, dyslipidemia, central obesity, and insulin resistance do not act independently. They amplify one another pathophysiologically. Then, when one other risk factor worsens, the other accelerates, creating multiplicative cardiometabolic harm rather than additive risk. This explains why these patients may have good glucose, bad outcome. Controlling only glucose leaves large residual CVD burden. Therefore, survival benefit requires treating the whole risk ecosystem, not only HbA1c. The clustering of metabolic risk factor, if you trace it back, it goes down a century ago, beginning with the Kailin description of hypertension, hyperglycemia, and gout in 1923, followed by a vague recognition of central obesity. But the vague detected that a fat distribution, not the fat mass, identified as a pathogenic. However, it was a Raven in 1988 Banting lecture that first unifies this association under insulin resistance, transforming descriptive clustering into a coherent pathophysiological syndrome. This is now, we have to see that with this amount of risk synergy, disrupt this risk synergy. That is the very important part. I have seen there are 4 scientific phases which very clear among them. There is phase 1, that is a path-making seminal trial of steno. I love this trial because it was a trial. It was the first among the trials which changed the paradigm and the perception. The second was organ protective era. There's the SGLT2. Then the obesity, atherosclerosis, GLP. And then phase 4 is phenotype matched combination era. If you see this, it was all started 25 to 30 years ago with a perception, thinking of the clinicians and researchers as well. And then, first among that, the steno trial, which is one of the finest trial ever done in the world, because it included high-risk type 2 diabetes way back in 1992, 93, and with the type 2 patients with a microalbuminuria, used simultaneous target-driven management rather than the glucose control alone. Treated HbA1c, blood pressure, LDL, triglyceride aggressively, added RAS blocker, aspirin, structured lifestyle. What was the result? 50% reduction in cardiovascular events and macrovascular complications. Finally, participants get 8 extra years of life expectancy. An early, broad, and sustained intervention created a durable legacy. Then came advanced study, that is a large DM, and with a glucose arm, blood pressure arm. Outcome showed there's a nephropathy, there was a decrease in nephropathy and major vascular events, particularly with BP strategy, no excess mortality or major safety concern like ACCORD. ACCORD was a trial which wanted to show that HbA1c lowering is a game changer, but it failed. It failed severely because though it achieved decrease in non-fatal MI, but all-cause mortality in the intensive arm was increased, and that trial stopped early. There was a key lesson with that. There's an over-aggressive glucose lowering in uncontrolled long duration of type 2 diabetes was fatal to many people. And without balanced blood pressure, lipid, organ protection can harm patients. It is not the lowest HbA1c that wins, but the right combination of glycemia, blood pressure, lipid, and organ protective therapy. That is the key. And then there's the era that absolutely changed. There's a one perception. There's an extraordinary trial came. That's the EMPOWER trial that changed the perception overnight. That was here in that way. You can see that EMPOWER outcome trial that was one of the SGLT2s delivered major reduction in cardiovascular death, hospitalization, heart failure hospitalization, chronic kidney disease progression with only modest degree of effect. The landmark trial with EMPOWER, Canvas, Declare, like a tandem bullet, demonstrated large reduction in CV death, heart failure, and kidney diseases across multiple high-risk population. Benefit occurred despite only modest reduction in HbA1c and blood pressure. And SGLT2 inhibitor proved to be a disease-modifying therapy, not merely a glucose-lowering agent. Treatment focused shifted to ASCVD for the first time. Heart failure and CKD, primary therapeutic, not secondary concerns. So this was a turning point where diabetes drug began saving lives by protecting the heart and kidney, making the moments when cardiology, nephrology become central to the diabetes management. and this changes cardiologic's mind and perception, because the benefit is present in heart failure with reduced ejection fraction, with heart failure with preserved ejection fraction, and the patient with and without diabetes. It proves SGLT2 inhibitors acts on heart failure biology itself, not just the glucose. I'm sorry. And then SGLT2 and the CKD, it became a new center of gravity for the kidney protection. And the CKD trials, with the Credence, DAPA CKD, EMPA kidney, that reset the standard of the kidney care. So, if you see that the one drug which bursted the synergy, this risk factor synergy with glucose, blood pressure, weight, albuminuria, heart failure, kidney disease, CV death, this is absolutely a paradigm changing drug. And this is a drug with a multiple risk axis. So SGLT2 era transformed diabetes care from treating glycemia to protecting organs and saving lives. And slowly, at the same time, in 2011, 2012, there was a GLP which was coming and putting the strong foothold and in the diabetes armamentarium. You see that a weight, inflammation, and ASCVD moves to the center stage. GLP trials show major reduction in MACE, independent of HbA1c effects, weight loss, appetite, control, endothelial function, and inflammation becomes the therapeutic targets. SELECT trial proved that the cardiovascular protection, even in people without diabetes, and represent a shift from diabetes management to the metabolic disease management. So that's a breakthrough trial, was a leader and sustained, and the harmony, rewind, amplitude, confirming the class effect, consistency across ages, population, and risk profile, and the SELECT and FLOW, that was absolutely a game changer. That proved that a CV benefit exists even without diabetes, and the FLOW, that true kidney protection, not just albuminuria change. This trial reposits incretins as a disease-modifying metabolic drug and relevant for cardiology, nephrology, and obesity medicine, not only for the diabetology itself. So then came tirzepatide, turning weight and glycemia into a single therapeutic axis. SURPASS program, weight loss up to 12 to 15%. And even in non-diabetic patients, there were 15 to 22%, and the largest combined glucose and weight effect seen in any diabetic therapy to date. But yesterday, day before yesterday, there was a slight, there was a just hot off from the oven, that is the news that the tirzepatide did not clearly beat dulaglutide for MACE reduction. That was just published in December 18 NEJM. So, new definition of excellence, new metabolic mandate, there's a 1 minute more. And protect weight, vessel, organ, and brain. Incretin therapies close the loop. Weight and atherosclerosis are now primary treatment target, not secondary outcome. And this is the fourth phase, which we started from very beginning in the 2018 and 19 and 2022, that we started having the combination phenotype matching. The SGLT2 for heart failure and CKD phenotype, GLP for a dual for ASCVD obesity phenotypes, and combination when risk cluster coexist. And from this 25 years of journey of research treatment selection, guided by the risk biology, not glucose number, when we match the drug to the patient's dominant vulnerability, ASCVD, heart failure, CKD, or obesity, we achieve the largest improvement in survival. This is a 10-second phenotype match tool, which I used to do previously, but now it is in like a mental math. You can just use it with that. And finally, the guideline and consensus says very clearly that to initiate SGLT2 without waiting for the metformin failure in the cases of on GLPs with the ASCVD, heart failure, CKD, obesity, and heart failure severe risk. And finally, to cut the long story short, from the 100-year story which I have narrated in 15 minutes, that from Kylan to Raven, what they taught us that the metabolic risk factor acts synergistically. Contemporary outcome trials teaches us that this synergy must be busted, bombed, and disrupted as early as possible, simultaneously and according to the dominant risk factor phenotype. Thank you so very much for the patient hearing.
Thank you, sir. And the second lecture is Type 3 diabetes, the mixed classification epidemic by Dr. Subhash Kumar. Hand over him.
Good morning, everyone. Respected chair, respected teacher, senior colleagues and friends. This is one of the event where we try to uplift the knowledge of the whole state diabetologist, and I wish it is going to be a big help in terms of learning about different aspects of diabetes. We just heard a power-packed lecture from our chairman, Dr. Supriyo Mukherjee, and I can just see the amount of knowledge which he has shared. I wish the whole hall was full with postgraduates and clinicians. Still, we have a lot of work to do today, and my talk is on something which is very nagging for us. Type 3C diabetes एक नया terminology नहीं है, but initial days में it used to be a nightmare for us, क्योंकि इसको कभी हम type 2 समझते थे, कभी type 1 समझते थे, and there are number of different names. If you look at the web or on the PubMed, you can find several data in terms of different aspect of the same element, same name, type 3C diabetes, as a pancreatogenic diabetes. To define it, it's also called pancreatogenic diabetes is a form of diabetes that arises secondary to disease, injury or surgical removal of the exocrine pancreas. So the word exocrine is very important over here. We'll explain you in bit detail, because in this case people will have loss of beta cells, and not only beta cell, also alpha cells. So you have insulin lack as well as glucagon deficiency in the patient, along with exocrine insufficiency. So you have to deal with three different aspects of one disease. These are the different names which you would have heard and on several different topics and given different names, starting from malnutrition related diabetes mellitus, MRDM, protein deficiency pancreatic disease, tropical diabetes, fibrocalculus pancreatic disease, FCPD, and so on. So one entity but with different names. However, the WHO has obsoleted the term, and now only type 3C is a valid term. I just want to remind you at this stage the seminal work from Odisha. We think the research comes from West only, but here also in a small setup, just with the right thinking and right approach, you can have some very important research. And Dr. Mohanty was one from SCB Medical College who described this malnutrition related diabetes mellitus in lean undernourished patient. Later on, now you also know that from the South India, where that tapioca is one of the root where they eat a lot of these roots, and they do have the similar kind of MRDM cases. So he was one of the pioneer in describing this type of diabetes, which is not the term now again we use only the same type 3C diabetes in this case. So prevalence, if you look at almost the international says 9.2, but we do see a lot of cases again here, not very frequent, but we have been struggling with these type of diabetes. And the cause of it can be various. I'll again explain you different causes, all related to pancreatic disease, like chronic pancreatitis, pancreatectomy for different reason, pancreatic cancer, cystic fibrosis related damage, hemochromatosis, fibrocalculus pancreopathy, pancreatic trauma and infection, and so on. If you look at the etiology, which is the commonest one, again, it is the chronic pancreatitis, which we do see in our practice. However, we may see this diabetes in the later phase of the patient's life. Now, the cases of pancreatic cancer, we have also heard from the speaker that we do have a lot of cancers now, and in this pancreatic cancer is also rising up because of the lifestyle factor and other factor. So we have to see the number rising in terms of this. If you want to classify the place of this diabetes in the flow chart by ADA, WHO, it is the other specific type of diabetes where exocrine pancreatic disease is there, which I have explained, other than in the whole gamut of different types of diabetes. So type 3C diabetes is due to disease of exocrine pancreas, as we explained. It is distinct from type 1 and type 2 and often misclassified, as I discussed. So WHO has given this disease due to disease of exocrine pancreas. So destruction of pancreatic tissue lead to loss of beta cell and alpha cell. This causes brittle diabetes. Why I was telling you that it has a nightmare, because a patient will have a severe hypoglycemia in one moment when he has a hyperglycemia. So if you have just titrated the dose a little bit, suppose I can tell you a patient who has a blood glucose of say 400, and you have used hardly 12 or 14 units, and patient will suddenly fall to 90 or 60 because of unopposed action of glucagon, because we have both loss of alpha and beta cell in these cases, and there is a deficiency of pancreatic enzyme. So patient will have malnutrition and undernutrition, so he will be lean and thin. If you look at the CT picture, you can see a lot of calcification in one of the cases, and there is a ductal dilatation of the pancreatic duct. So clinical feature, you have variable glucose level, hypo and hyperglycemia, as I discussed. Malnutrition, steatorrhea, and weight loss is one of the key feature, and deficiency of fat soluble vitamin. So patient will have all those A, D, E, K deficiency, and often coexists with abdominal pain because of pancreatitis or digestive symptom, patient with bloating, and he has a lean body habitus, steatorrhea, and glycemic instability. So Ewald and Bratzel criteria is one of the one which is so far very well accepted, and it has 3 major and minor criteria to diagnose it. There should be evidence of exocrine pancreatic disease, where you have to show etiology of chronic pancreatitis or calcification, pancreectomy or cancer or cystic fibrosis. Abnormal pancreatic imaging should be there, any one of it, and then there should be an absence of autoimmune marker of type 1 diabetes, either GAD or islet cell A2 antibody or zinc transporter 8 antibody present in the patient. And there should be evidence of pancreatic exocrine dysfunction, which shows reduced insulin secretion, low or inappropriate normal C-peptide. So I have been discussing the same point, and minor criteria which he has included is exocrine pancreatic insufficiency, fat soluble vitamin deficiency, impaired pancreatic polypeptide response, lack of metabolic syndrome features, and poor response to oral hypoglycemia. These may be present in these cases. So how do we investigate? We do have to do the pancreatic imaging to find out any pancreatic pathology should be there. Fecal elastase, if 1 less than 200, autoantibody as I described, C-peptide measurement, vitamin D nutritional profile, and OGTT or fasting glucose diagnostic. So normally when you suspect a lean diabetic with you can say very fluctuating levels, and patient will have any pancreatic tissue, then you have to go for these imaging techniques, which we normally don't do in our tier 1 investigation. So how do we manage if we have understood the pathology? We should have insulin on board, because the drugs which are there orally is not very effective in these cases. Pancreatic enzyme replacement therapy is must, because you know that there is both exocrine deficiency also. Nutritional support is there, it should be there in terms of vitamin and fat. Fat should be given religiously. Monitoring of hypoglycemia and treatment of any other underlying pancreatic disease. For hypoglycemia monitoring, again, we can have CGM on board, because these people are the people where you have to have help of CGM to find out the right dose of insulin, and also the right drugs to avoid hypoglycemia. So drugs where we have metformin is useful again, because of its a feature. And then sulfonylurea and secretagogue should be cautiously used, because as I said, there will be a risk of hypoglycemia, so you be careful. And then the GLP-1 receptor agonist, SGLT2 inhibitors have limited evidence. We still don't have enough evidence for use. Insulin, again, I said, is the mainstay of treatment. And then DPP-4 with caution, because of its pancreatic risk again. Pancreatic enzyme replacement therapy, as I discussed, is very important, fat-soluble vitamin, and also monitoring for osteoporosis because of the deficiency of vitamin D. Complications, they are at higher risk for micro and macrovascular because of the high glycemic variability. And also very important is the marker for pancreatic cancer. Sometimes new onset diabetes in an older patient, you should have a cautious. Lean patient, rapid weight loss, fluctuating glycemic control. You should look at risk of cancer in such patient, because 30 to 50% of patients with pancreatic cancer have diabetes, often classified retrospectively as type 3C. Now, since we thought we have a lot of PGs over there, so I got this research gap in therapy, because this is again very less discussed issues, where we can have a research on lack of large randomized control trial on type 3C diabetes. There is an undiagnosed globally, because we always confuse it as type 1 or type 2 sometime. Need for consensus diagnostic criteria, however, I have discussed the most common one. And role of newer drugs is still unclear, because we don't know whether DPP-4 or SGLT2 or GLP-1 is going to help in such cases. What is going to be long-term outcome of these patients on impact of quality of life? So we can have such paper. And to summarize, friends, type 3C diabetes is a distinct entity, and we need to be careful when your mind knows, your eye sees. As an undergraduate, I often miss these cases of type 3C where people used to have, there was a name as a brittle diabetes, or sometime I said there are several names which is there. And we never understood how to manage these cases where patient has frequent hypoglycemia and hyperglycemia. So while we understand the mechanism and pathophysiology, we can have a better outcome. And if we recognize early, we can help them in terms of all other factors, like having the vitamin supplements and other things. Thank you so much.
Thank you, Dr. Subhas, for your distinct talk on type 3 diabetes. And now I call Dr. Abhishek Kumar, who will be speaking on the role of fiber in diabetes and weight management, the facts versus myths. Dr. Abhishek.
Thank you, Chairperson, sir. At the outset, I would like to thank the organizers for this opportunity. And also, since this is a sponsor talk, I thank the Jointest team for giving me this responsibility. Of course, the talk is sponsored, the speaker is not. So I will speak only the fact. So after a information-packed 2 talks, now it is time to be slightly light, because the fibers makes us light. We already know it. So my topic is the role of fiber in diabetes and the weight management. And this is a very burning research topic nowadays, because regularly we are getting different type of papers and research are going across the world on the fibers, gut microbiota, and since both are related somehow. So particularly this gives me some interest to present my thoughts before you. Nothing to say about this. We already know what is happening in our country, and we are at the epicenter of the diabetes and obesity both. We can have the reports of the India, the latest published research, and see what is happening in our country. And in management of both of these, we know that the lifestyle, which includes the nutritional therapy and the physical activity, remains as an anchor entity. And dietary choices impact the blood sugar level, insulin sensitivity, and overall metabolic health, especially in the country like the India, where we take much carbohydrate in our diet. So we will see in the next few slides that what are the dietary factors, how it works, and how much should be taken. So हम देखेंगे ये क्या है, ये कहाँ है, क्यों है, कितना लेना है और कब लेना है. These are the edible parts of the plant or the similar carbohydrates that are resistant to the digestion and absorption in the intestine, whether it is the small or the large intestine. And the major source is the vegetarian diet, that is the whole grains, cereals, nuts, fruits, vegetables, pulses, and the legumes. So what it naturally does, the normal function is it absorbs water in the intestine, swells, increases water content of the feces, soften it, and facilitates the colonic transit. Means this is just a physiological thing that is clearing and nourishing our gut. If we classify it, we found that it has two major groups. One is the soluble fibers, the other is insoluble. Insoluble, the pectins, gums, or the mucilages are there, and few of them, like the gums, lignin, pectins, binds the bile acids, promote their excretion in the feces, and that helps in degradation of cholesterol and reduced level of triglyceride and LDL. And this is a statement I have taken from the K.D. Tripathi Pharmacology. We all have read it. So this is just a simple phenomena by which it acts. The insoluble components does the bulk forming activity. So it causes to increase the volume of the feces and helps in the transit of the gut. The other soluble fibers like the inulin, which is a fructan, it travels undigested to the colon where the bacterial fermentation occurs, and that leads to the formation of the short chain fatty acids. And we all know that these are nutritious for the good bacteria, bifidobacteria or the lactobacteria present in our gut. So these gives the nutritious amount and the immunity to the gut epithelium. The other one, like the wheat dextrine, this helps again in the reduction of the cholesterol, LDL, and the triglyceride volume. So both of these components are necessity for our good immunity, our gut health, and of course these are going to reduce or improve the sugar tolerance of the patient, and it also helps in the weight management. Then what is the physiological effect? We have already talked about the colonic effect, that is the colonic transit. We can have some other interesting thing about these molecules also, because these molecules slows the absorption of the easily absorbable carbohydrates that leads to reduction in the postprandial spikes, and that in turn leads to reduction of the insulin spikes from our body. So both postprandial acute hyperglycemia is prevented or reduced, that leads to reduction in the amount of insulin secretion in our body, and that also helps in maintaining the sugar level. Means in the period in which the patient does not take any food, if the hyperinsulinemia is there, there is chances that the patient may land into the hypoglycemia. Especially the patient, if the patient is having secretogo like the sulfonylurea as a OH. So if the fiber amount is good in our diet, it maintains the blood sugar by decreasing the insulin spike, by decreasing the postprandial glycemia spike, and also by reducing the interictal hypoglycemia. Likewise, it gives the bulk to the our stomach. So increases satiation and reduced energy intake is there. पेट भरा भरा सा लगेगा अगर हम अच्छा खासा फाइबर अपने डाइट में लेते हैं तो. In colonic effect, we have already talked about, it acts as a immunity booster and improves the gut health. Normally, it is needed for prevention of constipation, and of course, this is the first line treatment for the functional constipation. This is the same thing. In the left hand side, we can see the action in the small intestine, where it is increasing the viscosity and decreasing the glucose and the lipid absorption rate from the simple carbohydrates. The bile acid action helps in improving the LDL and the triglyceride level in the large intestine. Again, the fermentation product and the mass effect both acts. The fermentation product produces the short chain fatty acids that help in nutrition of the gut health, improves the bacteria, good bacteria, and also it is a bulk forming agent, so constipation is relieved. So these are the mechanisms or the proposed mechanism by which it helps in the cardiovascular system, diabetes management, or the weight management. The other thing which is also implicated, especially in the weight management, is the gut-brain axis. That is gives the satiety information to the hypothalamus through the CCK GLP-1 axis probably, and it also starts from the mouth. Mouth में ही इतना ज़्यादा जब salivation होगा, जो हमारी common trends थी कि खाना को चबा के खाना चाहिए. This gives both कि अच्छे से चबाओगे, अच्छे से salivation होगा, उसका एक satiety reflex होती है, जो gut brain reflex हम लोग बोलते हैं. So these mechanisms are also involved, especially in the management of the weight or the reduction of weight, if the patient is taking or a normal person is taking good amount of fiber in the diet. If we think from the other side, that what are the conditions which are related with the low fiber in the diet, then the answer comes: the constipation, diabetes, overweight, obesity, hemorrhoids, coronary heart disease, irritable bowel disease, of course, very much related to the low fiber in our diet, diverticulitis, and of course the colorectal cancer. So the reverse is also true. अगर हम ऐसे देखते हैं कि भाई उनकी डाइटरी हैबिट क्या है जिनमें ये सारे डिजीज़ है, तो उसमें हम पाएंगे कि उनके डाइट में फाइबर्स की मात्रा कम होती है. There are ample evidences also, especially from the cohort and the prospective studies, that the increasing fiber in the diet has led to the reduction of the CV risk, which included good control of sugar, slight weight reduction, and reduction in the inflammation. So if you look at the data, that this analysis, it was a systematic review and the meta-analysis of the prospective and the cohort studies that has shown that there is an improvement in the measures of the glycemic control, blood lipids, body weight, and inflammatory markers in these group of patients who has taken more amount of fiber in their diet as compared to the other one. However, in the randomized controlled trials, few studies and few meta-analyses are there. They have not given a clear-cut indication that this much fiber is going to reduce this percentage of cardiovascular, HbA1c improvement or the weight reduction. But if we talk about the Indian data, or rather this is like a consensus report from the diabetologist and the nutritionist from our country. So in our data, our report, our teachers say that a high fiber diet is vital to prevent and manage the type 2 diabetes. An ideal diet for diabetes and associated condition patient would have the high fiber up to the range of 25 to 40 gram per day. And they have compiled that the studies have shown that in diabetes patient, the increase of the intake of the fibers has, especially the soluble fibers, has led to the improvement in the metabolic milieu of that patient. So this is just a review and the meta-analysis, and in this chapter, if you read it, it is like a consensus guideline for our country. So what are the myths and the facts? If we look at the facts, that nothing is myth. Fibers has to be taken in our diet. It has to be present in the adequate amount. It is said since long. So if we say that if it doesn't have any effect on the glycemia, it is not true. That the soluble fibers has shown the improvement in the glucose absorption, lowering the postprandial spikes and reduction of the HbA1c.
Will you please?
All fibers are same? No. Soluble and insoluble have the different phenomena, different mechanism of action. It reduces the inflammation. Yes, it reduces. It helps in the weight control. Answer is yes. It increases the good bacteria or the nourishes the good bacteria in the heart, in the gut. The answer is again yes. It causes bloating, and should we avoid it? Of course, if it is you are taking in the larger amount, it may cause the bloating, but it should not be avoided. Your gut adapts to the adequate dose. It reduction, diabetes risk reduction. Nowadays, the newer concept is coming that a higher fiber is going to give the diabetes risk reduction.
Applaud the Bihar chapter for the exemplary work that they're doing. Dr. Ajay Kumar, Dr. B.K. Singh, Dr. Vijay, Dr. Subhash Kumar, Dr. Supriya Mukherjee, so many people who have been contributing to the success of this chapter. And I wish success to this chapter in the years to come. And I'm sure that will do great exemplary work, which will be sort of leadership for all the other chapters. Coming to my talk here today, I'd like to thank the organizing team for giving me this opportunity. But I thought that I'll speak something about diabetes prevention, which is something we all need to talk about. And over the years, we've been listening to diabetes prevention. So I just pulled out some important information of the last 3 years, which is path-breaking. And that should help us to understand where diabetes prevention is going today. We have seen a number of trials in the past, but now, of course, our understanding about diabetes prevention has taken a sea change, and we need to see this happening. So what is the magnitude of the problem that we look at today when it comes to occurrences of diabetes? And I'm just going to refer to the Diabetes IDF Atlas, which was published last year. 52 million people with diabetes are unaware that they have presence of diabetes. And the last message is, of course, an estimated 635 million between 20 to 79 are living with impaired glucose tolerance, which is 12%. Now, you don't have to look very far, and if you look at the statistics from India, and this was published in the ICMR INDIAB study by Dr. Mohan and his group, we have almost about 247 million people with diabetes or pre-diabetes. And that's almost about 25% of our population, which has some form of dysglycemia. So why are we really looking at only diabetes? Can we go backwards and have presence of pre-diabetes, or even before that, I gave a talk on prevention of prediabetes. So we should be looking at primordial prevention if we really need to. Do you want me to pause for a minute? Till everybody settles down? I'll just pause for a minute. No worries, I understand. So yeah, so I think we should be looking at primordial prevention if we really want to bring the trends of dysglycemia down in this country. Now, look at the ADA criteria for diagnosis of prediabetes. We say 5.7 to 6.4 A1C, or fasting glucose of 100 to 125, or 2R between 140 to 199. But have we ever looked at the conversion rates within the prediabetes? And if you look at the data, anything between 5.5 to 6% had a substantially increased risk of diabetes. That means the 5-year incidence is 9 to 25% within 5.5 to 6%. And if you look at patients between 6 to 6.5%, there's a 20 times higher risk of conversion. So the rates are almost 25% to 50% of conversion, even within the pre-diabetic range that we really talk about. So pre-diabetes is really not an innocuous condition where we take it very lightly, that you have just a mild elevations and we can just advise casually that the patient needs to undergo a lifestyle modification. We need to be aggressive and vigilant in the follow-up, because as much as you can reduce even within the pre-diabetes range towards normalcy, you're going to have a lesser conversion to presence of diabetes. And this data comes from the standards of care that is published in 2026. Now, if you look at the Whitehall study, it's a very interesting study. They looked at the 2-hour post-meal glucose, the fasting glucose, the insulin sensitivity, and the beta cell function. Patients who are going to be destined to develop diabetes for the futures show changes in their insulin sensitivity almost 14 years backwards. And there is a sharp decline in the insulin sensitivity that happens about 5 years before they actually manifest a dysglycemia. Here's your window of opportunity when they show a decline in the sensitivity. So for a point of time, the pancreas compensates by hyperinsulinemia, but you see that the insulin sensitivity remains steady, but you're trying to compensate by secreting more and more insulin. And then, of course, the hyperinsulinemia sets in, and you get an increase in the postprandial glucose and the fasting glucose. Now, here's the interesting study that was published in this year in diabetes. Look at just the fasting and the 2 hours post-meal glucose value. And they looked at the insulin sensitivity and the disposition index, which is a reflection of beta cell function. Now, you're looking at a fasting of less than 90, 2 hours of less than 140. That's the first graph bar you can see here. The second bar, that's termed as low normal fasting glucose. The second is, of course, a high normal fasting glucose. So here you're seeing actually within the normalcy of fasting glucose, the high is, of course, 90 to 99, and the post-meal is less than 140. And then, of course, you got impaired fasting, a combination of impaired fasting and impaired glucose, and newly diagnosed. But look at the right side bar diagrams. You have a drop in the disposition index, there's a islet cell function, even within the high normal fasting glucose values. So people, as I pointed out in the earlier slide, that even in the pre-diabetic range, you have patients who have differentiation. But look at, you're going even before that within the normal glycemic range, where you have high normal fasting glucose and you have a drop in the disposition index. So where is your point of intervention that you really need to look at? So we're now trying to say, this was published just this month in the Lancet, that we need to reclassify diabetes and we need to stage pre-diabetes and type 2 diabetes based on our findings that we see now. So you've got, of course, normal beta cell function and mass, Then you have stage 1 where you have a normal fasting glucose, and the fasting glucose within the normal, you need to look at 1 hour, 2 hour, and you can see the A1C less than 5.7, right? We are now looking at 1 hour as an intermediate hypoglycemia by definition, which is the IDF and which has been endorsed by the RSSDI. And we have shown a strong correlation of 1 hour post-meal glucose value to cardiovascular disease and so many other problems for the future. The stage 2, you may have slow progressors or fast progressors. And stage 2, you have got dysglycemia, where you've got typically like a pre-diabetes fasting glucose between 5.6 to 6.9 millimoles, 2 hours between 7.8 to 11, or a 1 hour 8.6, that's equivalent to 155 milligram percent, or A1C between 5.7 and 6.4. And stage 3 is, of course, overt diabetes. So we now talk that we need to intervene in stage 1, and this is equivalent to what we have for hypertension, like pre-hypertension, and you need to start aggressive lifestyle measures much earlier before they start developing a dysglycemia. So this was a very interesting paper that was published in Diabetology in 23, that where do we start intervening, and is there a cutoff point? So they looked at 4 case scenarios that stop using the term pre-diabetes completely. You're wasting your time and resources, because only about 20% of patients with pre-diabetes will convert to diabetes. So are we really getting more and more aggressive and wasting our time and resources? The second scenario is, of course, that when you use the term pre-diabetes, it sends a sense of urgency to the decision makers, and you start looking at highly intensive, demanding lifestyle-based interventions, and you may bring down the incidence by about 50%. The third case scenario is that lower your diagnostic risk. Just stop using the term pre-diabetes and lower your cutoff points to say who are diabetes, and just have a higher population, because at the end of the day, your intent is to prevent diabetic complications. So that's what your intent is going to be. So just remove pre-diabetes and lower your cutoff points for diagnosis of diabetes. And the last is, of course, you look at that you do a risk-based screening, and probably the patients who identify as high risk, then these are the patients who should be offered a very aggressive interventions, and you're optimizing your resources. GDM remains an opportunity for you, because obviously today, and the landmark work that has been by Dr. Yagnik and Associates, and he published this wonderful paper of early life origins of the epidemic of the double burden of malnutrition, and life can only be understood backwards. And what he says is that fetal under and over nutrition may program the risk for the future diabetes and obesity. He also suggests that from the experiments in the mice that there is a multi-generational undernutrition which increases the susceptibility to obesity even at normal nutrition levels. And BMI can only be interpreted as a composite index of undernutrition and overnutrition. So in his terms, you're shooing away diabetes pandemic by controlling the lifestyle of adults and using biologics, and it's tantamount to closing the door after the horse has bolted. You need to promote adolescent and female health in the reproductive years, which will help the primordial and primary prevention in the future generations. So diabetes prevention, what is a call for action that we need to have? We have a number of trials that you can see over here which have shown clear benefit with lifestyle modification, and you've got a pharmacological intervention trials, and clearly all of these work, and they've shown that lifestyle, diet, exercise, all these work to bring the incidence of conversion from pre-diabetes to diabetes down. We've got long-term studies with the DPP-4 and then the outcome studies, and this is almost 30-year data that we have shown. And what they have really concluded, when you look at over a period of time from the DPP study and the outcomes study, that in 2.8 years, the lifestyle intervention reduced diabetes risk by 58% versus placebo, and metformin reduced risk by 31%. At the end of 15 years, the lifestyle intervention reduced diabetes risk by 27% versus placebo, and metformin reduced risk by 18%. And 28% lower microvascular disease prevalence among participants without diabetes versus those with diabetes. And they have data all the way up to 21 years where they showed lifestyle intervention reduces diabetes risk by 24% versus placebo, metformin by 17%, 81% had a higher nephropathy risk with diabetes versus no diabetes, and 40% had higher odds of retinopathy versus no diabetes. So clearly, the aggressive intervention had data to prove that not only the incidence of diabetes came down, but even the diabetic complications were reduced, and this data is almost up to 30 years of follow-up that is there. So the key components of delivery is who should be the target population, what should be our approach, when should we really go about intervening, and where is the best opportunity to do it. And this is a paper by Dr. Ramchandran that was published last year, and he has got this clearly. Can I just take 3 minutes more to just finish my talk? Yeah. Okay. So these are the strategies that Dr. Ramchandran presented in his paper in Diabetology, that you need to create more awareness. There should be a risk stratification of individual. There should be a planning of program, and there should be an outcome evaluation that you need to do. And he's got all these different tools, but there are obviously challenges in a country like ours and barriers. You can see the individual barriers, the social barriers, and of course urban versus rural and the healthcare support systems that we have over here. The China model that has been most successful is they look at primordial, primary and secondary prevention, and they do a very targeted based screening procedures, and they have shown a great improvement. So if you see the India statistics are going up, but the China statistics are stagnant or in fact on the way down that we see over here. We need to have risk scoring, and this was again a paper that was published by all of us, and I've been an author in this paper, where we do a non-invasive risk score for Asian Indians, and based on the risk score that we've got, we need to decide that what kind of intervention that we need to give our patients. This is a study that was sponsored by the RSSDI, the Indian Prevention of Diabetes study, led by Dr. Madhu, and this is an outcome of yoga and lifestyle, and they've shown clear benefit of yoga in lifestyle interventions. Even in a country like US, there is limited success when it comes to lifestyle. So it's not just we're talking about lifestyle, it's easy. All lifestyle prevention programs show that they tend to fail after a period of time if they are not motivated enough. This was, I'm just going to go through the last part of my slide, that lowering weight has been an important measure that we look at, and we've got all these different trials with different molecules that have shown the benefit. Direct study gave us that we have almost about 80% remission by about 15% of weight loss, and that should be our target goals. We have a number of anti-obesity medications that have been used for weight reduction and prevention, and these are some of the drugs that have been used over here. But I just want to end up by this data was published, in fact, this year itself for tirzepatide for obesity and diabetes prevention. Clearly, you can see that the weight reduction with tirzepatide was good, and almost about to tune of about 18%. But you look at the incidence of type 2 diabetes with the pooled tirzepatide data versus placebo, and you can see here in the last slide over here, the bar diagram, the efficacy. So you're looking at normal glycemia, pre-diabetes and type 2 diabetes. So the efficacy with 15 milligram has clearly scored in bringing down the overall incidence of diabetes towards normoglycemia. So in summary, lifestyle interventions are effective and appropriate. We need to encourage it more. It's difficult to follow. There's a high failure rate. There's a poor weight reduction. Pharmacological interventions in conjunction with lifestyle changes are much more effective in high-risk individuals. Weight loss through intensive lifestyle modification and medications have shown significant benefit in reversal of prediabetes and diabetes, but sustenance of weight loss remains a key issue. And to bring down the burden of diabetes, we need to do mass screenings and increase the awareness of diabetes in the communities. So thank you very much for your patient listening.
Thanks to Dr. Agrawal. And this is the end of the second session. If the management permits, the audience can have 1 or 2 questions for the speakers. If there are no questions from the audience side, this is the end of the second session.
Thank you very much.
Thank you to the speakers and the chairpersons. I request the speakers and the chairpersons to move to the side stage for felicitation. I request our Secretary General of National RSSDI, Dr. Sanjay Agrawal sir, to stay back on the stage. And I invite Dr. Supriya Mukherjee sir, Dr. Shaibal Guha sir and Dr. Vijay Kumar sir to felicitate our Secretary General.
I must compliment Dr. Guha for putting up such a wonderful scientific program. I think it really merits a round of applause for him. Thank you.
Moving ahead to the next session, I would like to call the chairpersons on the stage. None other than the Doyen of Diabetes from Bihar, Dr. Ajay Kumar. I would also like to invite Dr. Ajoy Kumar, sir, on the stage. Over to the chairpersons.
A very good morning. The chairpersons today are Ajay Kumar, Ajoy Kumar and Ajay Kumar Sinha. So there is a riot of Ajays here. This session is sponsored by Zydus. And the story is that the Zydus is the first Indian company which is responsible for bringing an original molecule to treat diabetes and dyslipidemia together, that is saroglitazar. So kudos to Zydus Pharma for this innovation. To set the ball, and the other molecule, imeglimin, although it's a Japanese product, but has been very nicely adopted by Zydus and is something akin to metformin, but not exactly metformin. And we shall be listening to these 2 topics from 2 erudite speakers. And to set the ball rolling, it's my proud privilege to first invite Dr. Santosh Kumar Singh, who is going to talk on imeglimin, powerhouse of type 2 diabetes management. Over to Santosh.
Honorable chairpersons, respected seniors and friends, congratulations to the RSSDI team. And we will be talking about imeglimin. I think all of us are aware about this molecule. And the only thing required is to be more proactive in the use of this molecule, and why we will be discussing those aspects. The pathophysiology summary of type 2 diabetes, intrinsic things, peripheral insulin resistance and beta cell dysfunction, and the crux being the mitochondrial dysfunction. And you can well guess what the molecule will be doing on this pathophysiologic state. This is just in brief a pictorial depiction on the lower end, you can just have a look about the contribution of glucolipotoxicity, the environmental factors including obesity, intrauterine malnutrition, the pollutants, and then we have the conditions like mitochondrial diabetes. Lower down you have other genetic states, and lastly the functional impairment in the mitochondrial function. And hence the importance of intervening at the level of the mitochondria, significance as you can see on the different aspects of insulin secretion and insulin resistance. The need of the hour, we are well aware of the contribution of hepatic glucose production and glucose utilization, and as I said, the intervening aspect of mitochondrial dysfunction. Now, imeglimin was approved in Japan in 2021, the same year as was semaglutide was approved for obesity in 2021, and it is a DCGI approved product in India. Mechanism of action, we can easily correlate. Whenever we talk of diabetes, we talk of the redox state, we talk of the inflammatory cytokines, and the molecule is acting at this part of reducing the oxidant stress, and by that way impacting, as we saw in the previous slide, how it correlates with beta cell dysfunction and aggravation of insulin resistance. And the important aspect is the salvage pathway, whereby we are able to increase the ATP secretion by the NAMT and the NAD pathways. So the advantage of this molecule is the increased elaboration of ATP, and the importance I would just like to correlate when we talk of the effect of exercise and this molecule, it will be additive. When we talk of the interaction of metformin with exercise, it is counterproductive. And this is the mechanistic aspect. The metformin acts to the AMP kinase pathway, which is done by exercise, and this molecule is acting on another pathway, the improving the mitochondrial biogenesis and function, and by that way it can be additive to exercise, and it is one reason why it is scoring over metformin. Now this is the utility part from the phase 1 trial. We are well aware of this, the twice daily dosing, very low protein binding, low hepatic metabolism, no drug interaction, and important again, the no QT prolongation and no effect of food. So these are all advantageous points for this molecule, and this is from our use. Okay, so therapeutic dose 1000 milligram twice daily, half-life 13 hours. Drug interaction we have talked about, metabolic safety, hepatic safety we have talked about, and it can well be used even up to moderate impairment of hepatic dysfunction. No studies in severe hepatic dysfunction. And this should be very clear when we talk of these drugs in moderate and severe hepatic dysfunction, it is the child Pew classification which we talk of, class A, B, C, and that entails bilirubin and ascites and whatsoever. We have 5 points in that. So, and in clinical practice, more than 3-fold elevation of SGPT, this is significant for the use of this molecule. What is important and what is the scoring point over metformin? Look at the renal impairment part. You can use the full dose above 45 ml per minute. It's okay. We can use metformin in that dose. But 15 to 45, you can still use where metformin is a contraindication below 30 ml per minute. So you can well use this molecule in 500 milligram twice daily, and this is the usual dose because this is the dose where we have less of a GI problem compared to the 1000 milligram twice daily dosing. And the advantage is 500 milligram once daily can even be used in patients with the eGFR of less than 15. So remember this slide. eGFR 15 to 45, 500 milligram twice daily. This molecule can still be used with the eGFR of less than 15 ml, 500 milligram once daily. And we have our slides where we can use these molecules even in patients who are undergoing dialysis. The risk of lactic acidosis is lower with metformin. Okay, and we will look at the mechanistics, and you see the complex 1 inhibition which is done by this molecule. You remember that slide we showed the mechanism of action of this, and this is 4-fold greater with metformin versus imeglimin, and this is a partial complex 1 inhibition with imeglimin. So this is the mechanistic way why there is less lactic acidosis with this molecule compared to metformin. These are the three major published phase 3 trials, 1, 2, and 3, and one was as monotherapy, 2 was in as combination therapy, and look at the quantum of HbA1c reduction which was there with DPP-4 inhibitors and pioglitazone to the tune of 0.9%, metformin SGLT2 inhibitors 0.7%. And you have to remember this because we will be comparing the INDITIME study where you will see that we are even scoring over these percentage reductions in our Indian study. And phase 3 was vis-a-vis insulin where there was reduction of 0.6%. So snapshot of systemic reviews and meta-analysis, and you have different studies showing the meta-analysis. Lower down you find a mention of all this, and you will all will agree there cannot be any study where all this was not involved when we talk of pharmacotherapy. So we will go into the details of this study, efficacy and safety of imeglimin. And you see as monotherapy results is, to the tune of 0.9%, and there was no heterogeneity. This is just to denote that there was uniformity in all these studies. But in the randomized trials, there was high heterogeneity, but still you could find a reduction of 0.8%. So to the tune of 0.8 to 0.9% as monotherapy. And even in combination therapy, you have almost 0.8% reduction. So this is the meta-analysis which we have. In the same, you see the amount of HbA1c reduction was least, as I told you, 0.8%, 0.9%, but with GLP-1, it was only 0.12%. And this they have opined that could be due to longer duration of diabetes, and more so, the more potent efficiency of GLP-1 in insulin release the insulin secretion. So by that way, there was blunting of the effect of imeglimin when we were using with GLP-1. But there were definitely, we have these results according to the background patient population, because in this case scenario, you can see there was a reduction of HbA1c when this molecule was used in patients who had uncontrolled glycemia, in patients on liraglutide. And in 3 months' time, there was 1% reduction in HbA1c. And on the left-hand side, you see this, the explanation was, we have 3 mechanisms of insulin secretion. One is by the EPAC and TRP MP2 pathway. The second is GLP-1. So these 2 pathways were there even in the, with the insulin secretion with GLP-1. But the advantage is the third pathway, which there can be increased insulin secretion involving the mitochondria, which again involves the TRP M2 pathway linked with calcium release. Now this is in patients with metformin intolerance, and this was again an Indian study and showing the advantage of this molecule. Now regarding the glycemic variability, this has a scoring point. Nowadays when we talk of molecules, we do talk of glycemic variability, we talk of time in range, and this molecule again has an elegant improvement in time in range when you are using in clinical practice. Now we come to the Indian patients, and this is the INDITIME study, used both as monotherapy, combination therapy, and with even more than 2 drugs. And here the dose was 1000 milligram twice daily, and you can see the quantum. I was just talking about this slide, and this was there even when we were started with gliptins, and the amount of glycemic reduction was in the same tune, 25 milligram percent for fasting, 50 milligram percent with for the postprandial, and this molecule is doing the same. So definitely a very good glycemic benefit over here. And in the combination, as I told you, in that study in Japan, we had 0.9% with DPP-4 and TZDs, and it was 0.8% with SGLT2 inhibitors and metformin. And here everything you see above 1%. So in our country, we are having definitely a better glycemic profile with this molecule in day-to-day practice. In INDITIME study, having the pleiotropic benefits on creatinine, UACR, the liver function profile, and the lipid parameters. Safety, I was talking about the use in metformin intolerant patients, and it is scored. Even you can, and you have this point of its use in patients who are intolerant to metformin. And this is important for us
the imeglimin in type 2 diabetes, expert opinions and consensus in Indian context. And for monotherapy, it can be administered as monotherapy in treatment-naive patients with type 2. Treatment-naive, first-time use, could be considered as monotherapy in patients intolerant to metformin. Very true. It can be considered in the treatment of postprandial hyperglycemia, fasting or postprandial either. Combination therapy, it can be considered as add-on to metformin, sulfonylurea, DPP-4 inhibitors, TZD, as we saw in the Japanese study, considered as an add-on to SGLT2 inhibitors, 0.8% we saw, and in Indian studies more than 1%. It can be used along with insulin as add-on therapy. Definitely it reduces the dose of insulin. And imeglimin 500 milligram once daily can be considered in patients with diabetic kidney disease having eGFR less than 15 ml per minute. Imeglimin add-on can be considered for treating elderly patients. So across the spectrum, even naive patients, advanced kidney disease, moderate hepatic dysfunction, across the spectrum you can use this molecule. Nowadays, no talk can be complete without the mention of CKLM, the cardio, kidney, liver and metabolic syndrome. And here there was a study showing the link of sarcopenia with increased morbidity and mortality, and that was interestingly more in patients with the stage 1 and 2. We are all aware of stage 4, but the mortality was there in stage 1 and 2, and this is the significance of sarcopenia, and we need to counteract this. Dr. Sanjay Agarwal was talking about the prevention of diabetes, and I would give much emphasis on this aspect of improving sarcopenia for the prevention of diabetes and preventing the diabetic complications. So this was a study of imeglimin improving sarcopenia, and irrespective of change in the body weight part, and there was this improvement in the muscle strength. As you can see, quadriceps knee extension strength was increased by 13%. It was only 2.1% in the placebo arm. Now from the cardiovascular point, you have a very nice diagram how this molecule can be helpful. And these are the studies, cardiac and endothelial dysfunction, but this is an experimental study where there was benefit in the cardio and endothelial function. And this was a study where there was improvement, again experimental study, in preserved ejection fraction, and this was through the unfolded protein response. And this is for your knowledge, the importance of the unfolded protein response, and it's linked with the metabolic states including NAFLD progression. Here we have the study in patients with preserved ejection fraction. There was, and this is just to highlight the safety of this molecule in patients with heart failure. So this is not a beneficial study as we have with the SGLT2 inhibitors, GLP-1, but safety as we talk of sitagliptin and linagliptin, which are cardio safe. This molecule also is a cardio safe molecule. From here we go to the kidney. I have told you about the dosing pattern. It can still be used even in eGFR of less than 15 ml in 500 milligram once daily. And this is the TWINKLE study, real world data, and showing the benefit with this molecule in retarding kidney function decline. As I told you, it can well be used in patients undergoing hemodialysis. Now we come to the liver part. Imeglimin liver fibrosis markers, both FIB4 and APRI were favorably impacted with this molecule. This was another study showing the benefit in kidney and liver dysfunction. And in the conclusion, you can see the efficacy of imeglimin for the treatment was found for glycemic control and for improvement in diabetic nephropathy and NAFLD. We looked at the scores, FIB4 and APRI, and this is about the improvement in albuminuria, and this is the, now we come to the metabolic aspects. A minute to go. Body weight and waist circumference, they was favorably impacted. This is vis-a-vis metformin as monotherapy, and these are the other markers of triglyceride and CRP improvement. So we see across the spectrum of CKLM, this molecule is acting with a very good safety profile, and across the spectrum of its use, good efficacy, and lower down the good tolerance part, favoring this molecule in day-to-day practice. So thank you all for the patient hearing.
Thank you, Santosh sir, for your brilliant talk as usual. And the second topic of this session is the role of saroglitazar towards massage marcotherapy. And the speaker is none that Dr. B.K. Singh, over to B.K. Singh. And this molecule is from the basket of Zydus.
Thank you, chairpersons. One, Ajay is missing. And my pranam to all the three, Ajay Kumar, Ajoy Kumar and Ajay Kumar Sinha. So I request all of you to keep a big round of applause to our learned chairperson. This talk is sponsored by Zydus company. Initially, Supriya Mukherjee has given me a very difficult topic of genetics and something else. And then Vijay requested that we are short of money, so you must speak on the sponsored talk, so we can have some contribution to the RSSDI. With this background, now I speak on the slightly, I have changed the topic, the MASLD, saroglitazar, where it stands. So you all know that the MASLD is defined conventionally as the presence of hepatic fat accumulation that affects 5% of the hepatocytes on clinical examinations, or 5.6% of the MRS, that is magnetic resonance spectrography. And it is an independent predictor and possible contributor of the extrahepatic disorder like CVD and CKD. That is a very important point. And taken together, in the majority of patients of MSLD, type 2 diabetes mellitus coexist and interact, leading to the more severe outcome like hepatocellular carcinoma and cardiovascular disease. So what is, initially it was NAFLD, now it is called the MFLD. The etymology of the word NFLD dates back 1980, when Jürgen Ludwig named the disease after a series of 20 patients which presented the histological characters of alcoholic fatty acids with no misuse of alcohol. And later on, Deslam et al. In 2020 proposed a more practical and clinical based approach by renaming it to the MFLD, that is metabolic dysfunction associated steatotic liver disease, thus allowing a distinguished entity separated from the current term of non-alcoholic. And in intestinal expert consensus statement, the diagnosis is based on the presence of steatosis, and it is associated with the three following criteria like BMI status, type 2 diabetes mellitus, and metabolic syndrome. So if you combine together, then it is called the MFLD. We all know the worldwide the MFLD is most common. Prevalence is around 30%, and it parallels with the obesity epidemics. And in most serious cases, individuals are obese. 30 to 40% have type 2 diabetes mellitus, and 30% of dyslipidemia. And similarly, the MSLD is frequent in people with obesity, type 2 diabetes mellitus, and dyslipidemia up to 50%. So MSLD is reported 5 to 9% in lean individual. You all know the pathophysiology in MSLD. The increased fatty acids, increased triglycerides, that is the burden and leaded to the fat deposition in the liver, leading to the fibrosis, hepatocellular carcinoma, and cirrhosis of liver also. There are several genetic factors also involved with the MSLD risk and severity. We will not go in the detail, but the earliest and more widely reported association is the patatin-like phospholipase domain containing 3, and the fat mass and obesity associated gene, that is the FTO gene, were identified to link with the obesity risks and probably for the MSLD as well. Both hyperglycemia and insulin resistance are central to the MSLD pathophysiology, and in MSLD patient, the development of insulin resistance results in the increased adipocyte lipolysis and high circulating free fatty acids, subsequently reduced hepatic glycogen storage, increased gluconeogenesis, pervades in response to the systemic insulin resistance, hyperinsulinemia, leading to augment the de novo lipogenesis pathway. These all lipid profiles, as a consequence of the adipose tissue dysfunction, the adiponectin level decreases and leading to the decrease the free fatty acid oxidation, allowing its influx into the liver as well as stimulating the GNG and de novo lipogenesis. This all excessive oxidation of the free fatty acid produces the ROAS together with the pro-inflammatory state and de novo lipogenesis. This all pathophysiology leads to the lipid accumulation in the liver leading to MSLD. You all know the gut bacteria are also involved in this, and high content of fat and sugar such as fructose represents the starting point in the pathogenic process of obesity, type 2 diabetes mellitus and MSLD. And you all know the data shows that among the patient with MSLD, the firmicutes and bacteroid ratio, that is FBR, decreases as a marker of diabetes leading to the steatosis. So these are the all pathophysiologic condition, pathology process by which the MSLD open, and the diagnosis is, the gold standard diagnosis is the liver biopsy, but it has some potential risk and not commonly been used. But the non-invasive NFS or FIB4 or vibration controlled transient stability VCT is the way by which you can diagnose the MSLD cases. Non-invasive imaging assessment of the MSLD, the FIB score can be used very easily, that is age, AST, ALT and platelets. If it is less than 1.3, it is normal. If it is more than 2.67, it is abnormal. And in between that is the intermittent that can be further been investigated to diagnose the level of fibrosis and other things. Similarly, the NFLD fibrostic score and instant liver fibrosis test may be used as the non-invasive imaging technique to diagnose the MSLD. This is the algorithm to screen patient with type 2 diabetes mellitus for MSLD. Screen the patient with type 2 diabetes mellitus with NFLD, and if there is an increased ALT or suspected NFLD in the US, risk stratification with FIB score or NFS. If there is a low risk, nothing to worry, no advanced fibrosis, lifestyle intervention may be required, and reassess the patient after 2 to 3 years. If there is a patient of in high risk group, the FIB is more than 2.7 or NFS is more than 0.676, then refer to the hepatologist, do the VCTE, that is the fibroscan, and if VCT is less than 7.9, nothing to be worried, no advanced fibrosis. If the VCT is more than 9.8 kilopascal, there will be advanced fibrosis. So start selecting the patient for SCC or consider FDA approval medications once available. Or in indeterminate cases, the patient should be cautious and use MRI or liver biopsy to diagnose further the staging of the fibrosis. To manage the case of MSLD, the lifestyle modification is very important. There is some controversy in the vitamin supplementation, like the vitamin E, and the pharmacological therapy and the surgical treatment for the obesity. These are the 4 parts in the management of this. So like the lifestyle modification, the lifestyle intervention with the diet, exercise and behavioral modification is the initial and most important step in the management of MSLD like type 2 diabetes mellitus. The look ahead and read 2 trials shows beneficial effect of the exercise and weight loss, and the diet 5 to 10% reduction in the body weight can improve hepatic steatosis, lower inflammation, and PUFA rich diet or fish oil supplements may be used as in a diet modifications. Similarly, the physical activities, the inverse correlation between the intensity of physical activity and risk of MSLD, and it will found that the 150 minutes of moderate intensity exercise in a week is very important, and with vigorous exercise 75 minutes per week can lead to prevent advanced fibrosis and MASH. Regarding the vitamin supplement, although epidemiological study confirmed the association between the reduced level of vitamin D3 and the presence of NFLD, there are no clinical data from the large population in support of the benefit. And similarly, current guidelines do not recommend vitamin E as a treatment option for the patient with type 2 diabetes mellitus with NASH because of the lack of supporting data, as well as because of the consensus about the long-term safety due to its high risk of hemorrhagic stroke. In pharmacological therapy, thiazolidinone, this is a wonderful drug, increases insulin sensitivity and increases the plasma adiponate concentration, leading to the decrease of intrahepatic triglycerides and the improvement of the glycemic control. And similarly, the incretins, the liraglutide efficacy and action in NASH, the Gillian study, have demonstrated the liraglutide benefit in resolution of NASH without any worsening of fibrosis versus a placebo. And double-blind placebo-controlled phase 2 trial, which included patients with biopsy-confirmed NASH and liver fibrosis stage F1 to F3, has revealed that 0.4 milligram of semaglutide weekly was associated with 59% of the cases with relation to the MASH versus 70% in the placebo group. So increasing data come from several novel GLP and GLP axis, and tried with a higher rapid dose so significantly decreased level of NASH-related biomarkers. Resmetirom, oral selective thyroid hormone binding receptor beta agonist, effective in the MASH and advanced fibrosis. This has recently been advocated or by the FDA has improved this is an advanced fibrosis cases in resmetirom as effective. It is the only treatment available for the liver fibrosis. Coming to the saraglitazole, the dual PPAR alpha gamma reduces liver fat, liver enzyme, NFLD score, and significantly, and it is the one drug which has been prescribed in Indian subset of the patient and will be recommended by the ICMR in their version. And if you coming to the seraglutide, that is a dual PPAR agonist, is the mechanism of action is the PPAR alpha is found in liver, kidney, heart, and muscle, as is implicated in the uptake and oxidation of fatty acids and lipoprotein mechanism. And PPAR gamma is mainly expressed in the adipose tissue with beneficial effects on glucose homeostasis by increasing insulin sensitivity and glucose disposal, and prevent the loss of beta cell mass in the pancreas. So the saraglitazole is a dual PPAR alpha and gamma agonist, and through activation of this transcriptional factor of the PPAR alpha and gamma, reduces TG predominantly from the PPAR gamma agonism, and reduces insulin resistance and control blood sugar preventively through the PPAR gamma agonist. So it is a dual mode of action, and it's very effective in controlling this liver mortality. So there is evidence the effectiveness of PPAR agonist saraglitazole in non-alcoholic steatohepatitis. Positive data from preclinical and clinical studies, that is a biopsy-driven P3 study from India, and is found that proportional patients with decreased NS at weeks by 2052 years by at least 2 points spread across at least 2 points in NS composition. So steatosis, hepatocellular benign and laboring syndrome with no worsening of the fibrosis. And the study results primary endpoint, the decrease in NFLD activity score by 2 points was observed in 52.3% of patients without worsening of the fibrosis at 52 weeks. So comparing to this placebo to the saraglutide is very effective in this point. And the scientific data from saraglutide in patients with non-alcoholic fatty liver disease and diabetic dyslipidemia, a prospective observational real-world studies was created with the 163 per screen, 17 was included and one completed by 24 centimeters. And we can find it as the seraglutide leads to the significant erosion in transaminases, the liver stiffness measurement, and the control attenuation parameters, that is in the fibroscan method in family patient with diabetic dyslipidemia. So saraglutide mentioned in two major Indian expert consensus for ADD and NFLD, and LAI and 2000 expert group consensus are also recommended. And similarly, our RSSDI 2022 expert consensus has also recommended saraglutide as a treatment of diabetes mellitus with dyslipidemia. And surgical TIGA will not go in detail. If you compare this, the saraglutide score over other treatment like UDCA, OCA, vitamin D, and palaglutanon and SGLT2 inhibitors. So, in Indian subset of patient, up to 22 per study, no any concern had been permitted. So, saraglutide scores over the other molecules. Future treatment, you all know that the probiotics, that is the gut microbiota also small. The ferrinase and FXR agonist is also been mediate anti-inflammatory, anti-fibrillary. Will not go in details. So, conclude it that globally affects almost all a quarter of the population, and saraglutide, which has been the MSL therapy in Indian patients and hypertriglycemia, lean and mildly overpetition, and early MSH without atmospheric. So saraglutide is effective in the controlling the MSLE patients when there is no advanced fibrosis in the liver is there. So it can be used, and it be, in my opinion, and I have been using in the last 2 to 3 years, and it has been found to be effective in the cases of, particularly in the MSLD cases. Thank you very much for your patient hearing.
I would like to thank both the speakers for their excellent presentations. While the audience can get ready with the questions, I will set the ball rolling by asking the first question to Dr. Santosh. Given the fact that you have given excellent data about imeglimin and particularly comparing it with metformin, do you foresee that imeglimin will replace metformin, notwithstanding the fact that imeglimin is a new molecule and metformin has a very long, glorious history?
A molecule which is not approved by FDA, it is never going to replace another molecule. Okay, it's a local molecule, but I always talk about the cardiovascular benefit of metformin, by which way it gained the position of lifestyle modification plus metformin in the management of type 2 diabetes. Even the very subsequent study of metformin and cardiovascular outcome, because you know UKPDS for any approved molecule, it has to be multinational study. It was single center study, minuscule number of patients showing that benefit. Subsequent studies didn't find any benefit with metformin. So I always remember and quote those studies about the non-CV benefit with metformin. Okay, now replacing, if you look at the recommendations by the IDF guideline, you look at the recommendations of the ACE guidelines, there is no hierarchy of use of any molecule. You can use any, starting with metformin, sulfonylurea, whatsoever. Only a red mark is there for weight gain with pioglitazone, weight gain with sulfonylurea. Otherwise, any molecule you can use across the spectrum. Now it depends which molecule you are convinced with. Okay, and as I told you, the advantages of this molecule, it's used across the spectrum, even in places where you cannot think of writing metformin. And with the EGFR of less than 30, you cannot. So this molecule has a place in day-to-day practice. Data definitely will be coming. We have our own Indian data with that HbA1c which we saw. The pleiotropic benefits along the metabolic aspects which we saw with this molecule. So I don't think there is any second thought about using this molecule in my day-to-day practice. Regarding replacement, definitely no. As I told you, if it is not a pan-world molecule, it cannot replace metformin. Okay, but that positioning of metformin at first line, it's not there already by the AS, IDF, or even by the
Thank you,
guidelines.
Santosh. Any question? Yeah, Abhishek. M. Shankar, you can speak loudly. You got this microphone.
Hello. A couple of years ago, it was decided, and it was a very, I will say, over the international market, no metformin, right? And what is the current result? The US FDA recommendation, number one, is almost almost metformin. And everywhere the metformin is there, will be there, and it will stay always. Because we know the effects, we know the side effects, we know our limitations, and we know the limitations of the patient. Now, sir rightly said, this question, that question, EGFR and lot of many things, every drug has got the same problem. And the step-motherly treatment of US FDA approval, hemoglobin, saroglitazar, teneligliptin, I don't know when it will happen. I want comments from Dr. Ajay Kumar, who is an international expert. Only 1 minute, sir. All the three, I just named these molecules.
You see, my contention is very simple. When Santosh has presented data, it clearly shows superiority of hemoglobin over metformin. I don't want to bring politics into this discussion, but the point is why the Western world is so reluctant to try the drugs which have been discovered in the eastern part of the world. If hemoglobin has got, mechanistic superiority, outcome data, everything is so better. Hemoglobin is superior or not? Why are they so reluctant to use a drug which has been developed by the eastern part of the world? That's my question. I will conclude this session if there are no more questions.
Thank you.
Thank you very much.
Thank you.
I thank these speakers for shedding light on two very powerful molecules in the management of diabetes and MASLD, but their wide-scale use is still to see the light of the day. I request the speakers and the chairpersons to move to the side stage for felicitation. I would request Dr. Ajay Kumar to stay back for the next session for moderation. Now let me invite the chairpersons for the next session. Dr. S.D. Singh from Darbhanga, Dr. Bharat Kumar from Darbhanga, Dr. B.C. Jha sir from Patna, and Dr. Binod Dhariwal sir. Over to the chairpersons.
I call Sajad Ashan to give lecture.
Thank you, sir. Thank you. First of all, I extend my warm gratitudes and regards to all the dignitaries of RSSDI for giving me this wonderful invitation to talk on this upcoming molecules, that is the dual and triple agonists. So we are living in a world of incretins right now. We talked about the obesity in the morning, and let's see with the some surrogate outcomes, surrogate data, and with the hard outcomes that what we can bring in new therapies with respect to the dual and triple agonists. So we know that evolution of the incretin therapies in metabolic disease and their expanding roles, and when we have the data of the GLP-1 agonists, because we have the strong data with exenatide, dulaglutide, liraglutide, and that is the rationale to develop some of the dual agonists, and we are going and heading forward to talk about the triple agonist therapy beyond the monotherapy. That is what I'm going to talk. So, but before that, we know to distinguish between the surrogate markers of all these dual and triple agonists, and what are their hard clinical outcomes, and what future directions we can go for these incretin-based therapies for future landscape. So what is surrogate markers? We already know that these short-term metabolic indicators for the efficacy, for timely regulatory approval and clinical decision making. So if you look then cardiometabolic research, A1C is a short-term surrogate marker for long-term diabetes complication. Blood pressure is a strong surrogate marker for future risk of stroke and MI. Of course, LDL is a strong surrogate marker. It's very hard data we have. And we are talking about obesity and weight loss in most of the trials. Either it's a SGLT2 or the GLP-1 agonist. And we are looking for surrogate markers, and we are having some strong surrogate markers with the GLPs. Either it's a dual or triple agonist, and we are looking for hard clinical outcomes. We know that hard clinical outcomes in all the trials, all the CVOT trials, we have CV death, non-fatal MI, and non-fatal stroke, and hospitalization for heart failure data, and as well as the end-stage kidney disease. Why they are truly important? Because they represent the true patient benefit. They are just not biomarker changes. These are required by further regulatory and long-term safety and efficacy of these molecules to be established in the population. So what I'm going to talk about these upcoming dual and triple agonist therapy. We are having already the data of the tirzepatide by all the trials, SURPASS trials, SURMOUNT trials, but the future molecules like the dual agonist, GLP and the glucagon agonist. Upcoming molecule is the survodutide, and retatrutide is a wonderful molecule that will act on all these receptors, GLP, GIP as well as the glucagon agonist. So when you look at the evolution of these incretin therapies, or either what we can say that when we bring in some new therapies, it's just not a revolution, rather it's a stepwise improvement. And we have seen the strong base of the CV benefit of the LEADER trial with the liraglutide, that almost 13% cardiovascular benefit we got. We got the benefit of with the dulaglutide in REWIND trial, but almost 20%. So we have in 2022, GLP and the GIP tirzepatide, we have the data with the SURPASS. SUMMIT is a good trial which is conducted in the heart failure population with obesity, and SURMOUNT trial give the data in the obesity patient. So we have the data. People are working on phase 2 and phase 3 trial with synchronized trial. It's CVOT trial of this survodutide, which is a GLP and the glucagon agonist. And retatrutide is undergoing in phase 3 trial of this TRIUMPH, which is a strong, good CVOT trial with retatrutide. So when you look all the anti-obesity medication, of course the GLP-1 is the basic agonist mechanism that acts by reducing food intake, increasing the satiety, more insulin secretion. But when you add on this GIP or you add on this glucagon agonist, you get some more benefit. And these are the molecules with these particular categories. And one very special molecule which is with amylin agonism, because we know that amylin is co-secreted with the insulin. And when this has been GLP and amylin agonist, there is a wonderful molecule, CagriSema. So these are some new molecules, and we have to look the surrogate markers as well as the hard outcome of all these data. So this is the very good slide by Professor Avdesh sir, and he's not here. He was expected to be here in for one of the talk. So when he has compared in obese, non-diabetic patients as well as in the diabetic patients. So when you see the comparative efficacy or the surrogate markers in terms of obesity, what we see that triple agonist, retatrutide, GLP, GIP and the glucagon has the strongest weight reduction capacity in this obesity. Comparing as to the tirzepatide, of course tirzepatide has an edge over the semaglutide, but when you see the data of oral semaglutide in this some trial like Pioneer Plus that was conducted with 50 milligram, that also shows a strong and robust data of 17% weight reduction. But there is a wonderful discrimination that when you use all these molecules in diabetic population, you get slightly less weight loss as compared to into purely obese patients. But in the same fashion, if you see the data with the tirzepatide and retatrutide, these two molecules are having a strong edge over the other anti-obesity molecules like semaglutide in terms of weight loss in patients with diabetes. So relative efficacy of all the obesity medications, either if you compare with the previous molecule, like we are not using these molecules in the current days, naltrexone, bupropion, but we have used liraglutide, but the molecule which has been approved, it has been approved in the dosage of 3 milligram, which is not available in India, But we have semaglutide, and it has shown a strong efficacy data with 2.4 milligram, and tirzepatide in all series of SURMOUNT trials, it has shown a robust and a strong efficacy in obesity patients. But the similar pattern we got with all anti-obesity molecules with diabetic and non-diabetic patients. They are doing good and well in the obesity patient alone as compared to the obesity with diabetes. So multi-agonistic therapy has all three site of action, GLP, GIP, and glucagon, and because they have a complementary mechanism, add-on mechanism, and they generate synergistic metabolic improvements that was not possible with single pathway activation of GLP, or either GIP or with the glucagon agonist alone. So that is why the combination therapy, right now we are working on many combination therapy, has a strong future for this either in obesity or for some good cardiovascular outcomes. So dual agonist, first I will talk about this tirzepatide because it has a therapeutic good glycemic control data, improve insulin secretory dynamics, and favorable adipocyte metabolic remodeling profile. So let's talk about its surrogate markers. It has a strong and robust A1C reduction data that is up to 2.5% in all the trials, like the SURPASS series of the trial, improved glycemic control, and if you look at the weight loss potential, it's up to 22% with substantial reduction in all obesity-related comorbidities with some good pleiotropic benefits in reduction of systolic blood pressure up to tune of 7 millimeter of mercury, improvement in lipid profile, and wonderful reduction in the waist circumference, what we got the data in the SURMOUNT trial. And it has a wonderful reduction of the liver fat that has been also in subgroup analysis of some series of the SURMOUNT trials. So SURPASS series of trial, which is the overview in diabetic patient, in which particularly SURPASS-2, when it has been compared with the semaglutide, that is, it has a strong A1C reduction 2 to 2.3%, while it was only 8.6% in semaglutide. So it shows a robust and has an edge over the semaglutide in this particular SURPASS-2 trial. And SURMOUNT is the foundation trial in the obese patients in which all the dosage, either it's a 5, 10 or 15 milligram, that has shown an average weight loss of in all the series up to from 16 to 22.5% at 72 weeks. That is a very significant and powerful data in weight reduction with people with obesity and in pre-diabetes. We have one session with the reversal or remission of the diabetes by Dr. Sanjay Agarwal, and he showed that this molecule data has some remission of diabetes also. SURMOUNT-5 is a very good trial which has a direct head-to-head comparison with tirzepatide versus semaglutide, and it has also shown an edge over with this tirzepatide over the semaglutide. Now talk about some hard outcomes, that is cardiovascular outcome of this tirzepatide versus dulaglutide in SURPASS CVOT trial. And if you see this, because dulaglutide is already has a strong CVOT trial that was rewind, in which it has shown a 12% or 13% CV benefits. And if you see the comparable data of this tirzepatide, it has shown a non-inferiority data in terms of CVOT outcome as compared to the dulaglutide. So with regard to some surrogate markers also, if you see the changes in the A1C and the weight, tirzepatide as compared to the dulaglutide as showing an edge over the dulaglutide in terms of better A1C reduction and better body weight reduction as compared to the dulaglutide. So if you see the summary of all these SURPASS trial, efficacy data 2.5% A1C reduction, 22% weight loss, which is not possible in any of these previous GLP trials, and the metabolic parameters have been also benefited in terms of the NASH outcome. SUMMIT is a very good trial in people with obesity and heart failure with reserve ejection fraction, in which they have taken NYHA 2 to 4 patients, and that has in primary outcome SUMMIT trial data has also shown 38% benefit in patient of worsening of heart failure and composite CV death outcome. And look at the SUMMIT trial data as compared to the previous trial data of HFpEF with the semaglutide, that is a step 1 and a step 2. What was the difference in the SUMMIT trial data, in which they have taken the patients with obesity with not anti-pro-BNP more than 200. So this was the difference, that in a step HUF-PEF, they have taken the patients with more anti-pro-BNP raised data. But if you see the people with obesity, they don't have most of the time raised anti-pro-BNP. That can be misleading, and they have taken this trial of population, and that has shown also a benefit in terms of tirzepatide with all these summit trial data. So renal outcomes with tirzepatide, if you see the subgroup analysis, SURPASS 4 or pooled SURPASS 1 to 5 analysis, they have shown significant USCR reduction data, and SURPASS CVOT, this has also shown a slowing of the eGFR decline, and TREASURE CKD is evaluating tirzepatide in obesity and diabetic CKD patients, and its completion is expected up to 2026. This also has in synergy group or synergy trial data. This is a phase 2 multicentric trial that has been conducted in tirzepatide with MASH patient, and that also shown an improvement in A1C, liver fat, and dose-dependent histological improvement in MASH resolution and fibrosis, and that shows a promising therapy for advanced liver disease in the future also. Now talk about this GLP and glucagon agonist, that is survodutide. And when you see that when you act on the GLP with glucagon receptor activation, that acts on an adipose tissue, more lipolysis, more reduction in fibrosis and epicardial fat also. And this is the additional mechanism what we get from this by activation of this glucagon receptor agonist. And survodutide for treatment of obesity, this has been undergoing this synchronized trial for future cardiovascular outcomes with once weekly survodutide 6 milligram and once weekly 3.6 milligram. And this primary objective of this synchronized CVOT trial to demonstrate the non-inferiority of survodutide at 3.6 and 6 milligram compared to placebo for this 5-point MACE. So for patients with overweight and obesity and in MASH, this molecule survodutide is undergoing these future trials, synchronized 1, 2, and long-term cardiovascular outcomes. For patients with MASH, this has been undergoing in specific trials of leverage and leverage cirrhosis. In leverage cirrhosis, they have taken the patients, adult patients with MASH and compensated cirrhosis, and in all completed phase 2 trials, this molecule has demonstrated superiority over the placebo with up to 62% of participants. They have achieved histological improvement in MASH without their liver fibrosis worsening. And that is just all because of this. Survodutide has received US FDA fast track and breakthrough therapy designation for future MASH therapy. So now talk about this triple agonist, retatrutide. We know that this has a triple mechanism of action, GLP, GIP, and the glucagon, and it is currently under investigation in phase 3 trials. So if you look at the phase 2 trial data in patients with obesity, up to 24.2% weight loss with a dosage of 12 milligram, and responder rate is more than 15% weight loss in 83%. So in phase 3 trial, this molecule is undergoing in patients with obesity, obstructive sleep apnea, and FDA is filing expected late approval for till end of 2025. So if you see the TRIUMPH series of trials, this has been in future conducted in all the patients with type 2 diabetes with obesity, obstructive sleep apnea, knee osteoarthritis also, and head-to-head comparison with the tirzepatide also. So FDA is expecting approval anticipated till last of the 2026, so we have to wait. But if you see the weight reduction trajectory with this retatrutide, almost 17% weight loss in 24 weeks, and comparative efficacy with all these 3 molecules, retatrutide is getting an edge over these tirzepatide and semaglutide. So established hard outcome has been already been established by leaders, SUSTAIN and SELECT trial with 20% reduction in the MACE. So this is a class effect for future cardioprotective therapeutic therapy, and robust evidence that provides the benchmark against with dual and triple agonists must be evaluated in the future. And we have completed trial with semaglutide, SELECT, STEP HUF-PEF, and STEP HUF-PEF DM. Tirzepatide, we already have the completed trial, but one trial, SURMOUNT MMO, is expecting till 2027. CagriSema redefined trial is ongoing. Orforglipron, which is a non-peptide GLP-1 agonist, Survodutide, we are expecting till in a synchronized CVOT till April 2026, and retatrutide is also ongoing. So we have this strong cardiovascular outcome data with previous GLP and the GIP, but we are expecting the future beneficial results on the basis of these strong surrogate markers, which can lead to some good clinical outcomes with respect to cardiovascular outcome and renal protection and hepatic disease benefit with all these molecules. So with this, I just end here. Thank you everyone for a patient hearing.
So the next speaker is Dr. Ved Prakash, and the topic is child with diabetes. Dr. Ved Prakash.
So, good evening, respected chairpersons and all the delegates and faculty present in the hall. First of all, I am thankful to the RSSDI BIHAR team for this opportunity, and the topic given to me is approach to a case of childhood diabetes. So, so as we all know that the incidence of diabetes in young is also increasing gradually, as the incidence of diabetes is increasing in the older people also. The diabetes in young is a basically heterogeneous disorder in which clinical presentation and disease progression may vary considerably, and the classification of diabetes in young is very important because the treatment depends on the type of diabetes. So in young, the various types of diabetes can be present, like type 1 diabetes, type 2 diabetes, MODY, etc. So treatment overall depends on the type of diabetes. So classification of diabetes in young is very important. So in children and adolescents, there are two major forms. Type 1 diabetes is still the commonest diabetes present in the children, and it comprises almost 80 to 90% of the total cases. But recently, in the last 1 decade or 2 decades, the incidence of type 2 diabetes increases dramatically even in the childhood, and the main reason for this increase in incidence of type 2 diabetes is the increasing incidence of the childhood diabetes, and simultaneous there is increase in the incidence of type 2 diabetes also. So incidence vary in the various geographical areas. So at least 1 in 300 child by the age of 20 years develop diabetes in the Europe and North American countries, but the incidence is lower in elsewhere in the world. And overall, more than 10 lakh cases of childhood diabetes is present, and almost 1 lakh new cases is diagnosed annually worldwide. So the incidence of diabetes in the newborn and infants is very rare. The incidence is 1 in 2,50,000 childbirth in younger than 6 months of age, and in the age group of 9 months to 10 years, almost all cases of the diabetes is mainly due to by type 1 diabetes. So the incidence of type 2 diabetes in young worldwide. So currently, in India, the incidence of type 2 diabetes in children or young type 2 diabetes is 0.9 per 1 lakh population. So the diagnostic criteria for diabetes in children is also similar to the adult, and out of these 4 criteria, if any one criteria is fulfilled, then the child is suffering from the diabetes. So coming to the various types of diabetes present in the childhood, the type 1 diabetes, type 2 diabetes, MODY, and the diseases caused by the exocrine pancreas like pancreatitis, tropical calcific pancreatitis, or any other forms of pancreatitis, endocrinopathies like Cushing syndrome also can cause diabetes in the children, and the various drugs or chemicals which can induce diabetes in children is like glucocorticoids, and some infections like congenital rubella can also cause diabetes, and some genetic syndromes is associated with diabetes in the childhood like Down syndrome, Turner syndrome, etc. So the first case is a 5-year-old child who presented to the emergency department with the complaint of pain abdomen, vomiting, rapid breathing and altered sensorium. And on inquiry, the child has having polyuria, polydipsia and weight loss for the last 3 months, but there is no associated history of fever, cough, etc. There is no family history of diabetes in this case. And on examination, signs of there is signs of marked dehydration is there, and acidotic breathing is present with the fruity odor, and on investigation random blood sugar was 432, and in ABG pH is 7.1 and bicarb is 12, and urine ketones is present in the large amount. So this is a classical case of type 1 diabetes presented in the childhood, and the features of this case is suggestive of the child presented with the diabetic ketoacidosis for the first time. So the most common presenting symptom of type 1 diabetes in childhood is symptoms like the commonest symptom of diabetes like polyuria, polydipsia, polyphagia, unexplained weight loss and fatigue seen in over 85% of the children with newly diagnosed type 1 diabetes. But at the same time 30 to 40% of the children with type 1 diabetes can present for the first time in diabetic ketoacidosis. And in young children may present with enuresis, bedwetting, recurrent infections or irritability instead of classical symptoms. And early identification of type 1 diabetes is very important, because if we diagnose type 1 diabetes early based on the symptoms and other factors, then we can prevent the onset of then we can prevent the development of the diabetic ketoacidosis. So diabetic ketoacidosis is basically characterized by a triad of hyperglycemia, blood glucose more than 250 milligram per deciliter. In ABG, pH should be less than 7.3 and bicarb should be less than 15, and there is increased amount of serum or urine ketones. So these are the classical features of diabetic ketoacidosis. I am not going into details. So for the confirmation of that, if a child presents with decay, then there is no doubt clinical diagnosis is type 1 diabetes by sure. But when there is doubt, then we can go for the islet cell antibodies like anti-GAD65 antibody, anti-IA2 or ICF512 antibody, or anti-zinc transporter antibody for the confirmation of the diagnosis of type 1 diabetes. And one of these antibodies is present in majority of the type 1 diabetes individuals. In some cases, 2 or 3 antibodies can be present, but at least in more than 90% of the cases, at least one antibody is present. So in this case, the treatment, since child presented with diabetic ketoacidosis, so the therapeutic objectives of treatment is, since child is having in the decay, there is marked dehydration, so our first aim should be restoration of circulatory volume and tissue perfusion, and there is a steady but gradual reduction in the plasma glucose should be done, and the other associated electrolyte imbalance should be corrected, and ultimately there is resolution of the ketoacidosis. And if there is any precipitating factor is present, then treatment of precipitating factor is also very important. So this is a classical case of type 1 diabetes. There is no doubt, there is no dilemma in the diagnosis, but there is overlapping cases. There are cases where we cannot be sure that this is a case of type 1 diabetes or type 2 diabetes, or it is a monogenic diabetes. So there is overlap in presentation is present. So about 6% of the individual with young onset type 2 diabetes present initially in the decay. So decay is not decay can be seen even in type 2 diabetes patients in some cases. In today's study, 10% of the individuals considered to have young onset type 2 diabetes have a positive diabetes autoantibody. So autoantibody can be present even in small amounts of type 2 diabetes patients, and roughly 1/3 of young with type 1 diabetes are either overweight or obese. So even in type 1 diabetes cases can be overweight or obese. So there is overlap in the overlap clinically in the type 1, type 2 and MODY. So distinguishing type 1 diabetes from type 2 diabetes in children may not be easy. Obesity in childhood is increasing, so 30% of the newly diagnosed type 1 diabetes patients may be obese, and a significant number of children with type 2 diabetes have ketonuria or ketoacidosis at the time of diagnosis. And a positive family history is not specific to type 2 diabetes. It may be seen in the other forms of diabetes. And based on the insulin or fasting C-peptide level, it is not always helpful to classify diabetes as type 1 or type 2 diabetes in cases of childhood. So for type 2 diabetes, BMI clinically, BMI should be more than 85th percentile, and family history is very important. History of type 2 diabetes is seen in either first or second degree relatives, and some of the races like American Indian, Black, Asians, the type 2 diabetes is very common, and the markers of insulin resistance like acanthosis nigricans, acanthosis nigricans can be present, and some of the associated conditions like polycystic ovary syndrome and a small for gestational age birth history is there, then these points can favor the diagnosis of type 2 diabetes in children. So a diagnostic tool which may be used if diagnostic criteria doesn't give an accurate decision is presence of the insulin autoantibodies. If these antibodies are present, then chances of type 1 diabetes is almost certain. If antibody is negative and there is autosomal dominant family history, then the diagnosis is MODY. And if age is less than 12 months, especially less than 6 months, then diagnosis is the neonatal diabetes mellitus. And if mild hyperglycemia is present and patient is non-obese, then diagnosis most likely is the MODY. And if prolonged honeymoon phase is present and requiring less insulin, that favors MODY. And as some of the associated conditions, such as if deafness is present, optic atrophy is present, or some of the syndromic features are present, then it can favor the mitochondrial diabetes. And genetic testing is the best way to identify the monogenic diabetes or MODY. So diagnosis of new onset diabetes in youth, if HbA1c is more than 6.5, diagnosis is confirmed. If BMI is more than 85th percentile, and if age is more than 10 years or the diabetes is started at the time of puberty, and if there is other signs of metabolic comorbidities is there and diabetic ketoacidosis or cerebral edema is absent, then this most likely this is a case of type 2 diabetes. And if BMI is not in the overweight or obese range, or age is less than 10 years and signs of metabolic comorbidities are absent, and if there is history of diabetic ketoacidosis or cerebral edema, then most likely this is a case of type 1 diabetes. So diagnosis, already I have discussed this. So now coming to the few points about the MODY. In MODY, basically it is an autosomal dominant diabetes present in the childhood or the early adulthood. In clinical features is onset is less than 25 years, and there is a strong family history in the 3 consecutive generations. And if the diabetes is there and onset of diabetes in less than 25 to 30 years, and then it is a case of MODY. There are various types of MODY present, almost 1 to 14 types of is known nowadays, and there is basically in this MODY occur in the mutation in the single gene, and so this is a form of monogenic diabetes. Some of the pancreatic disorders like pancreatitis acute or chronic, pancreatectomy or pancreatic cancer, cystic fibrosis, hemochromatosis, and these are some pancreatic conditions which can result in the damage to the pancreas and ultimately leads to the decrease in insulin secretion and also decrease in the glucagon secretion, and that can leads to the one of the pancreatic form of the diabetes known as the pancreatic diabetes. Usually pancreatic diabetic patients are young, lean, belongs to the low socioeconomic status and presented with the abdominal pain, steatorrhea, and hyperglycemia is usually mild, but it may be severe, and it may respond to the oral hypoglycemic agents, or in some cases, or it may require insulin also, depending on the damage to the pancreas. And in most of the on diabetic ketoacidosis is almost not seen in cases of pancreatic diabetes. And so classical triad already I have discussed. So another form of diabetes is mitochondrial diabetes, and in mitochondrial diabetes basically it transfers from the mother to the child, and usually the child presented with the symptoms of diabetes along with other symptoms like neurological symptoms like progressive bilateral sensorineural hearing loss and other ocular symptoms in form of mild retinopathy. Wolfram syndrome is another diabetes seen in the childhood, and in this also known as Didmot syndrome, in which the components are diabetes insipidus, diabetes mellitus, optic atrophy and sensorineural deafness. So with this, I will end here. Actually, this is a very big topic, so I was concise in presentation.
A very good afternoon to all of you. I greet all my diabetic friends who are here. I think 1/3 of this population must be either a diabetic or a pre-diabetes, right? If somebody who is not a pre-diabetic, then you raise your hand. Only 1, 2, 3, 4, 5, that's all. So see the percentage. So I think my percentage has increased more than 30%. But in general, 1/3 of the adult population, they are either diabetic or pre-diabetic. This is the usual accepted things. And when diabetes and other things go together, then you have all the things in common. Why this topic matters? The topic which has been assigned to me by discussing some rare syndromes. I will just show some of the pictures, not too much. So why the syndromic diabetes? What does this mean? Collectively, if you just find out, these are a very small percentage. Very small percentage. 1 in 1 lakh, something, some very rare diseases, 1 in 5 lakhs. A couple of more rare diseases, the rarest is 1 in 1 million. So why we are discussing all these issues? We are discussing because many of them, with the precision of the treatment, changing the modalities, we can just improve upon the patient's life. We can increase the life of the patient, and previously the things which were not discussed, the neonatal diabetes, and the points were not absolutely pointed very clearly that these are the patients when they have developed diabetes below the age of 6 months, they must be on insulin lifelong therapy. So there are many syndromes which doesn't require insulin, or using insulin deteriorates them. So I will be just pointing some of these things. So collectively significant, I told you, rare syndromes are uncommon individually, but collectively significant in clinical practice, representing a meaningful subset of atypical diabetes care. Our point is early identification. That is very, very important. Targeted therapy, organ surveillance, prognosis clarity, and family counseling. These are some important aspects. Now this classification of rare syndromic diabetes, they can be just grouped under the different headings. The monogenic beta cell disorders includes neonatal diabetes, including MODI, what was just discussed by my friend, my previous speaker. Mitochondrial diabetes, the maternal diabetes which is being transferred into the children, the MELAS and the KSS, maternally inherited diabetes and deafness, the mitochondrial encephalomyelopathy associated with acidosis, lactic acidosis and stroke. This is the MELAS, and the KSS is a subset of similarities, a group like MELAS, so they can go even together and there can be no overlap between these two. Although the KSS, which is called Kant's Sayre syndrome, is a subset of large side of the DNA deletions. Neurodegenerative syndromes like including Wolfram's, Melasson cases also comes in the same category. The ciliopathies, BB syndrome, Alstrom, lipodystrophy syndromes, and severe insulin receptor problems as called receptoropathies. The epidemiological review, neonatal diabetes, I just told you that 1 in 1 lakh to 5 lakh births, lipodystrophy 1 in 4 per million, 1 to 4 per million, and build flexibility is 1% of all diabetes and very rare conditions. Pathophysiological categories, the beta cell dysfunctions leading to the differences in the target genes, and you have to identify the target genes once you have a suspicion. Why do you suspect and what is the basis of suspicion? We will be looking into the next couple of slides. And we lead to a targeted therapy, which I told you earlier. We will revert back to this slide again later on. The use of targeted therapy will be sulfonylurea and insulin if necessary. Mitochondrial failure with genetics or mangamen, no metformin, early insulin, right? Severe insulin resistance, we all know, this can lead to a lipodystrophy, not lipodystrophy, lipodystrophy, INSR mutations, and when the drug is metroleptin or high doses of insulin. Now the drug is very surprisingly, this metroleptin is a very good drug which is used in conditions of lipodystrophy. Unfortunately, you will be surprised to know the cost of the maintenance, because this is a lifelong therapy, and 1 year treatment with metroleptin cost you $1 million. Mind you again, $1 million is the cost of treatment to keep the patient alive for 1 year. So these are the things which are most difficult to handle. Now the cilia deficiency and all that syndrome leading to BB and Alstrom, the strategy is GLP-1, RAs and SGLT2 inhibitors. Neonatal diabetes, what are the red flags? The onset is below 6 months of age. This is very important. The single most critical and clinical criteria distinguishing neonatal from autoimmune type 1 diabetes. Autoimmune does not start below 6 months of age. Neonatal starts below 6 months of age. This is the basic difference between these two. The absence of autoimmunity, intrauterine growth restrictions, and multi-system features. Basically, we have to look into all the genetic components, and the genetic counseling and genetic evaluation becomes more important. So your strong suspicion of diabetes developing below the age of 6 months, the patient must be subjected to very deep evaluation, which is more of an academic interest, and as well as for the maintenance of the patients. That means the kids whom you can change the pattern of the drug or select the drugs, and you can just keep them surviving. Neonatal diabetes, the genes and mechanisms, the potassium channels are very, very important, and they are very not that uncommon as you think of. The potassium channels, ATP channels, you have to find out and identify the genes, and if properly treated, the life can be normal to some extent up to the age of 3rd or 4th decade. If you just leave them, these child, they are going to die around the age of 5 to 8 years. So this is the important aspects, that diagnosing it very properly and in time with a clear mind and a clear laboratory support, then you can improve upon the life conditions. Imprinting abnormalities, then these are all finding of the locus genes and all that. So genetic expressions are very, very important. I'm not going into the details of all these things. Now, why genetic diagnosis is critical? Because it ultimately leads to a very precision therapy, that what drugs to be considered, whether they have to be switched to sulfonylureas or improved outcomes, or the doses of the insulin, particularly in those cases of insulin resistance, very high doses of insulins are recommended. These things are very important. क्या हो गया? ये देखो यार. Can you help me? Neonatal diabetes management logarithm is confirm genetic etiology. Mandatory if diabetes onset is less than 6 months. This is what I have been telling. If potassium channel mutation is found, stop insulin. Stop insulin. Remember this. initiate and up-titrate high dose of sulfonylurea like glimepiride under specialist supervision. If other INS mutation, continue insulin therapy with close monitoring of growth and nutrition. Neurodevelopment, pancreatic function, associated anomalies and family screening are very, very important in those aspects. If mitochondrial dysfunctions are there, typically caused by the specific gene changes in mutations, the inheritance is maternal only and onset is young adult. So this has to be differentiated, as was pointed very well by Dr. Sajjad from this place. Sensory neural deafness is important aspect. Distinct diabetes phenotypes are there, retinopathy and pattern dystrophy. Associated systemic features are there, short stature with cardiomyopathy, renal diseases and myopathy. And ultimately it leads to the death with cardiac problems. So the cardiac failure or the heart failure becomes the most important aspect of death in such conditions, rather than the primarily the insulin problems. Diagnosis and management is, you have to test, you have to first have suspicions and then test with the evaluation of all the chromosomal patterns. And the evaluation is there. Therapeutic directives is avoid metformin in this case, initiate insulin early. Hearing, I told you about the sensory neural deficits are there. Renal functions are very, very important, in which focal glomerular sclerosis has to be found out and the renal deterioration has to be looked for very importantly. Cardiomyopathy and conduction defects can occur, heart failure can occur, different types of conduction defects. ECG and echocardiogram, these things are very important. Neuromuscular assessment for myopathy, fatigue or MELAS like or stroke like events, they are very, very important. So a very young diabetic coming with stroke, a very young diabetic coming with stroke, you must have a suspicion of MELAS, and only then you can evaluate it properly. As far as Wolfram is concerned, we have to look for the WFS1. This gene has to be looked into, which is basically an endoplasmic reticulum transmembrane protein. And the mechanism is chronic ER stress leading to selective cell death. So this becomes important. And one of the findings, what was just narrated by my previous speaker, the DID mode, diabetic insipidus mellitus, optic atrophy and deafness. Early onset diabetes is there, usually presents in childhood. Usual mean age is 6 years, often preceding other neurological features. Prognosis is severe because there is a brainstem and cerebellar atrophy, lead to respiratory failure and dysphagia. High risk of mortality in early adulthood, median age is up to 30 years without supportive care. So here the supportive care becomes much more important. Wolfram syndrome management is tight glycemic control, core therapy is insulin dependent. Medication safety, avoid neurotoxins. Otherwise there will be early paralysis. Research clinical trials are emerging for the ER stress modulators like dantrolene and evaluate with GLP-1 RA for potential neuroprotective effects. So this is has got one aspect of because we are freely now using the GLP-1 RA, and which is available in our country very well, and the drugs, despite lot many queries being raised by only few of the persons, this has got a very good drug and these are in very proper use. So this can be of use in such cases of Wolfram syndromes. The ophthalmic, audiology, renal evaluation and neurological evaluation is mandatory for all such patients, and that is important. Ciliopathy from BBS and Alstrom is primary cilia dysfunction. Defective signaling leads to profound hypothalamic and metabolic dysregulation. Early onset obesity is very important. Severe insulin resistance, dyslipidemia and adolescent diabetes onset. These are the points by which we can point out and look for the evaluation of these ciliopathies. The difference between the Alstrom and BV syndrome is very important. Mutation is the most important aspect is that there is no polydactyly in Alstrom syndrome, while there is a polydactyly is a strong clinical pointer. So this is a simple clinical pointer. Imagine, polydactyly is a very common thing what we can see in practice, right? But in a child, a very small child with polydactyly and problems of diabetes, you kindly suspect Alstrom or Bardet-Biedl syndromes. Ciliopathies, they need aggressive metabolic control, early pharmacotherapy. Insulin initiation is important because this can lead to cardiomyopathy, renal dysfunction, sensory impairment and hepatic health. Lipodystrophy has got two types of divisions, the congenital generalized or the familial partial. So in congenital generalized there is a near total fat absence, while in a familial partial there is selective fat loss in limbs, gluteal region and vascular appearances. So this is the important aspect. So there is no fat in a congenital CGL, and the partial loss of fat with limb atrophy, face and neck fat excesses in a familial partial. Lipodystrophy management is a little difficult aspect. I told you at the beginning, metreleptin is the one which is very important and very effective therapy. But the cost, I told you, daily injection is required. The doses are variable, 11 milligram, 5.3 milligram, 3 milligram. The costs are different, but on an average, I told you the cost per annum is around $1 million. So imagine this one. So the other things, other components of using the insulin and prevent pancreatitis by managing the triglyceride, which should be kept below 500 level. Organ surveillance, hepatic health has been discussed and is very common. Cardiomyopathy, reproductive, PCOS has to be looked into. Renal functions has to be monitored very clearly. Similarly, the insulin receptoropathies, INSR mutations, these are all severe insulin resistance. Clinical phenotypes are different, and phenotype spectrums has divided these two specified components, Donohue syndrome and the Rapson-Mendel-Hall syndrome. The receptoropathy management is extreme insulin therapy, which is very important. High dose insulin, this is first line therapy. Then recombinant IGF-1 mecasaramine that can be used. Or the nutritional optimization. These things are very important. Now when to suspect this syndromic diabetes? Clinical triggers, specific phenotypes that necessitate genetic evaluation. Atypical onset and phenotype, onset below 6 months of age. Lipodystrophy, that means the pattern of the fat distribution you can see. Insulin resistance, if you find out, this is again important. Sensory comorbidities, diabetes with sensory neural deficit, specifies this into Wolfram category, MIDD. Diabetes with optic atrophy, Wolfram syndrome. History and clinical course, family history is important, maternal transmission or consanguinity, complications out of proportion to glycemic history. These things are important. In the last two slides, the phenotypic screening is there almost. We have to screen, as I told you, all the specific points. Exclude autoimmune by the presence of testing for autoantibodies, anti-GAT65, IA2, ZNTB. Absence suggests non-type 1 etiology, because the treatment pattern definitely changes. Phenotype screen is C-peptide evaluation, lipid profile, lipodystrophy presentations, liver renal dysfunctions, neural dysfunctions, sensory neural deficits, and all these things are important. Precision treatment, sulfonylureas, metreleptin, etc. Surveillance, organ specific plans, family cascade screening is very important. Organ screening, as I told you, by depending upon all the different organs, they must be screened at least annually, or if required earlier as well. And the targeted genetics, we have to find out that what best we can do. But we know that all these aspects, we are still very much cornered by the non-availability of majority of the investigations in our place and the majority of the treatment pattern. We have already discussed about the precision therapy by suspecting the different types of diseases, the potassium channel, then high dose of sulfonylureas, ciliopathies, then early GLP-1 RA or SGLT2 inhibitors. For insulin resistance, lipodystrophy, we have told about this. Insulin receptoropathies, this very difficult case to manage. Mitochondrial diseases, then avoid metformin, early insulin, advanced syndromes, insulin dependent is there. Future directions, next generation medicines, we have got not many trials going on, but still we are short of it. Gene therapy is still going on, but we are not sure that how many of us can get it converted into the ground reality within the next couple of years or so. The broad precision is sequencing. Some of the points of sequencing I told you right now, that when to stop insulin, in which condition not to use insulin, and in which condition you can take the help of sulfonylureas or GLP-1 analogs. That is very important. The registries, we are all behind this, particularly when we discuss anything about our Indian context. There was a point of discussion right from the first speaker with Santosh sir, that about metformin and imiglamin, So similar is the position here. It can be just have these registries, only limited registries into the Western worlds, either USA, European countries, but I don't know exactly that if any of the registries are there in India. Maybe Dr. J. Kumar can throw some light onto this. So thank you, friends. Sorry I took 2 minutes extra.
Thank you, Hemshankar. Ladies and gentlemen, now fasten your seat belts for a flight into the future medicine in diabetes. And for this, we have a very erudite speaker, internationally acclaimed endocrinologist from India, Dr. Unni Krishnan. Please come to the dais. Dr. Unni Krishnan is the CEO of Chelaram Diabetes Center in Pune and is doing yeoman's service not only in the field of science of diabetes, but also catering to the social aspects of diabetes practice. Over to Dr. Unni Krishnan. He will be giving you a glimpse into the artificial pancreas, which is, I think, one of the most futuristic topics in diabetes.
Thank you, sir, for the wonderful introduction, and it's a pleasure to be here in this beautiful city. I have been in undivided Bihar for 10 years, from 1970 to 1980, in Bokaro Steel City, where my father used to work. Of course, now that is in Jharkhand. But I'm not a stranger to this part of the country, and I love this area of the country very much. It's a pleasure to be here again. And over to my topic. Now I'm going to talk about artificial pancreas. Where are we? I'm not going to make it high-tech. I'm going to make it very clinical and very practical. So 26% of people with type 1 diabetes only are controlled today. And that is something we have to reflect upon. And we have had artificial insulin delivery system for many years. On the left, you have in the 1970s, you had a biostator, a big machine. You have to carry it on a trolley. In 2013, that was the important, event in 2013, where Medtronic, they launched the 780G pump. Sorry, let me just get the pointer. So 2013, when Medtronic launched the threshold suspend pump. Now that pump, when the blood sugar goes down, it will stop the insulin. So that was the beauty of that pump. Today, we have an artificial pancreas system which we can use, and I will talk about it. Essentially, any artificial insulin system, it will measure the glucose level, decide what to do, deliver the insulin, learn and repeat it. It can be used, especially it has an important use in type 1 diabetes, in pregnancy. Even in type 2 diabetes, it has a use. And in young type 1 diabetes, there is a very, very important use in young type 1 diabetes. So this is a picture of how the insulin pumps have evolved. Now in the x-axis, you have the time. In the y-axis, you have the blood glucose level. And as you can see, this is the normal range. You can put it at 70 to 180. This line gives you the sugar level, and at the bottom you have the insulin delivery. So as you can see, the insulin delivery is up and down and up and down, and when the sugar level goes down, insulin delivery stops, and when the sugar level goes up, insulin delivery comes up. The only problem with the pump today, the artificial pancreas pumps, is that you have to enter the carbohydrate and then give the insulin. So for example, if the patient is taking 50 grams carbohydrate, the patient has to calculate 50 grams carbohydrate के लिए 3 unit insulin की ज़रूरत है, तो चलो 3 unit लिया जाए. So that kind of calculation is needed in today's pumps, and that is why the latest pump is called advanced hybrid closed loop system. I will explain all of these words. It's a pump because it delivers insulin. It is closed loop because it measures the glucose and delivers insulin. It is hybrid because it can't do everything. It can't decide how much the patient is eating because it has no camera. The patient has to enter. So little bit patient has to do, little bit pump will do. So hybrid. And it's advanced because it has two features. It can give an auto basal. Depending on the sugar, it continuously gives basal, and if the sugar goes very high, it can give correction boluses. So it's an advanced form. So this is the latest we have, advanced hybrid closed loop pump. And this is how the present advanced hybrid closed loop pump works. First of all, I have no conflict of interest. There is no support from Medtronics. I am just showing the signs, absolutely no connection or no conflict of interest. Every pump has a transmitter, a sensor which transmits glucose. The pump learns it. You can calibrate it with a glucose meter. You have a mobile app on which the patient can see their reports, adjust the insulin also. Then you have a CareLink server where the caregiver, it could be a patient or a doctor, can see it, and they can also see it in their doctor's chamber or house, or a father sitting in Patna can see his son or daughter in a school in a different city or in college, and they can track their blood glucose levels. So this is how it works. Step 1, the artificial pancreas system which is available in India, it can have a default setting of 100. So you can set, the pump will set the target at 100 and it will try to maintain that target. Second point, every 5 minutes it will keep on giving insulin, basal insulin. Third point, when it reaches 120, the pump will have a correction target. So when it reaches 120, it will deliver more and more and more insulin to keep it down. Finally, these corrections will be delivered every 5 minutes once the maximum basal is reached. Now imagine a child with diabetes. Child is going out with friends. Child doesn't want to eat. Child may be 14 years of age. They want to go out. They go to a mall. They have some pizza. Child is taking it with her friends. She doesn't want to tell the friends that, look, I'm going to inject my insulin. She doesn't want to disclose that. She doesn't want to take the insulin injection in public. She doesn't want to even take the pump out and inject in public. What does she do? So this pump has got an auto correction feature for not every miss bolus, but for an occasional miss bolus, the pump will thoda bahut jugaad karke adjust kar lega. It will do something. To give you an example, now sugar is 109 and then the child is decided to eat and there is a sugar spike, but as you can see, the pump will really increase the insulin, and once the maximum basal rate is reached, as you can see here, pump will give a bolus, one more bolus, two more bolus, till it comes down. So yes, the sugar may reach 200, but if that bolus, the pump had not done the work, it would have reached 400. So instead of the pizza and the ice cream and the chocolate and the pastry pushing it to 400, the pump will thoda bahut adjust karke, it will bring it to 300. Not to be used every time, but the pump will give what is called occasional missed meal bolus. The pump will forgive the patient for that. So first time we have forgiveness to the patient for missing an insulin. So I'll give you a couple of cases, couple of my cases on these sort of pumps. This is a 69-year-old male, my patient since 20 years. He had transplants and the transplant was going on very well and his sugars were controlled. He was on pump and insulin and he had wearing an ordinary pump, the pump with the sensor separate. So he had a transplant, but then the transplant started slowly, the kidney started failing. He's got ischemic heart disease and he's on all the medicines. So he was concerned about the rising creatinine and the team was worried. So he was on an ordinary pump and we transitioned him to the advanced hybrid closed loop therapy. Now this is how the report looks like. See, the sugar was very difficult to control, but he achieved a time in range of 65%, which was very difficult in his case. You will also see that it was earlier 68, 65, but see, there is no hypoglycemia. Before, this B stands for before and A stands for after. And before he had only 1% hypoglycemia and later on he had 0 hypoglycemia. So in type 2 diabetes, the idea is it will keep on giving insulin, controls the sugar without hypoglycemia. And then you can also see the time in range is good and you can see no hypoglycemia. You can see the variability is very minimal. And then you can see that even this gentleman who's 65 plus is using the smart guard algorithm, which will adjust it 91% of time. So 80% and more, if he's using the smart guard, it is good. And he's wearing sensor for 82% of the time. Anything above 80% is good mark. So you should look at whether it is crossing 80%. And he's using technology. And very interesting, you see, he is taking 78 units of insulin and his bolus unit is 43. The rest is basal. Why is that? Now that is because our Indian diet is predominantly carbohydrate rich. And these patients who are carbohydrate rich, they require more and more boluses. This is his report. This is my second patient. Now he's a young type 1 diabetes. He developed retinopathy. He said, Doctor Saab, aap kuch kijiye because my sugar is high. I want to do something. And type 1 diabetes, it works beautifully. You can see there is no variability. The time in range is excellent. You'll get minimum 82% time in range. You can see that he's using sensor 91% of time and smart guard 100% of the time. He's changing the reservoir. He's having, again, he has to bolus because of our Indian diet, but he's entering his carbohydrate and doing a good job. So my topic is type 1 versus type 2. So these are the differences between type 1 and type 2. In type 1, you can get about 80% time in range. In type 2, you may not get that much. In type 1, it is to prevent the fluctuation. In type 2, it is to safely achieve control. In type 1, the insulin dose is dynamic. It is adjusted up and down. In type 2, the dose has to increase because in type 2, there is lots of insulin resistance. And of course, in both, you need carbohydrate counting and training, and there are good results. So this is the data. What is the evidence? This is the evidence. You can see that using this pump will improve the time in range significantly. And also, this is the time in range with standard care, multiple injections. And this is the time in range. Time in range is a percentage that the patient spends with normal glucose. So more time is spent with normal glucose with the post-meal system, and especially in the early morning period, this is seen. So the time in range, there is a massive improvement. And the only problem now with these pumps, this is a problem, you know, patient has to enter the carbohydrate, and then as you can see this rocket on the right, patient has to inject insulin. That's only problem. Otherwise the pump will give, throughout the day it will measure the glucose and give insulin. But the pump doesn't know how much the patient is eating, and the pump cannot give more insulin. How to solve that problem? If you give too much insulin, sugar can come down suddenly. So that is why this will be automated soon, and you have what is called bionic pancreas. This is just going to be approved in the US. What is a bionic pancreas? Today we have a, as I said, advanced hybrid closed loop system. Tomorrow we are going to have a bionic pancreas. Bionic means a robotic. So people can have a bionic arm, a robotic arm, a bionic leg. So this is like a bionic pancreas. Bionic pancreas has got two hormones, both insulin and glucagon. The ordinary pump has one hormone. The ordinary pump requires user input. The bionic pancreas, it aims for a perfect sugar control. That means no problem. Sugar low, I'll bring it up. Sugar high, I'll bring it down. Here, this is a key difference. The bionic pancreas will manage the high with insulin. The ordinary pancreas will manage the high with insulin. The bionic pancreas, if the sugar is high, it will keep on giving insulin. If the sugar is low, it will keep on giving glucagon to bring it up. So sugar high, keep on giving insulin so much that the sugar dramatically falls. When it falls to about normal, it will give glucagon to support it. So the variability is really minimal. I'll finish in 1 minute. So this is the ordinary pump, and as you can see in the bottom, the bionic pump, a straight line, and this is how the machine looks. It delivers both insulin and glucagon, and this is Steve Russell who first discovered it. Increases time in range by another 11%. So friends, this is my last slide. This slide gives you all the information you need. Any pump can sense glucose, give the insulin, act on it, and learn from it. But it is a challenge because the patient needs to learn it. Advanced systems will automate everything, detect good control. For type 1 diabetes, the goal is to prevent fluctuation and give excellent time in range and HbA1c. In type 2 diabetes, it is to increase the insulin till control is reached. The future is not one pump, but two pumps. A same pump will deliver both insulin and glucagon so that the time and range is perfect. Well, friends, they say that, AI is going to take over doctors' lives. I don't think AI will take over any doctor's life, but a good doctor who has AI as a tool is better than a good doctor who doesn't have AI from a tool. And when any technology comes to take over, it's going to take over. We can either accept that it will take over, and we can do nothing about it, or accept that it will take over and embrace it. I think we must embrace this new life which is coming, AI, and the pumps built with AI will change the world. I finished just in time. Once again, Dr. Ajay Kumar and the entire team, thank you for having me here. Real pleasure.
Thank you, Unni, for that excellent presentation. All the four speakers in this session have taken us to a very high pedestal of science. Thank you all very much. If there is any question targeted to any particular speaker, you feel free to so. Yeah. Rajkamal first. Then BK, then Sudhir.
Dr. Unnan Krishnan, I want to tell you one thing, that regarding the carbohydrate intake, you have said because the insulin pump does not recognize what is the amount of the carbohydrate we are taking. So in that case, if we have a planned diet, if we give a diet which is planned, planned. If we plan it and give that diet.
Planned diet, yes. Plant-based diet.
Plant-based. Planned. P-L-A-N-N-E-D. Planned. Planned diet.
Planned diet, yes.
That's how much you have to take the carbohydrate or how much protein or how much anything. That will solve this problem of insulin pump, because you are saying that we do not know what amount the carbohydrate the patient is taking. So if we can do this miracle to the patient, then this pump will also be useful.
3 points, sir.
Yeah.
Just 2-3 points. One is that if you go for a low carb diet, what will happen is, as you correctly said, the pump will do the basal work. The post-meal bolus requirements will come down beautifully. But even then, the patient has to decide while looking at the food how much carb is there and enter the carbs in the pump. Then the pump will calculate based on AI and tell, aapne 50 grams liya hai, you can take 3 unit bolus. That button still has to be pressed by the patient. That will not do automatic. That will come automatic only if the sugar goes to very high level. It will keep on giving a basal and then give bolus. But that little bit, even today patient has to do. But the important thing today, carb counting is not difficult. Our patients just take a photo from the, for example, if they have say puri and say aloo masala, just take a photo, it will give you the number of carbs. They just enter it in the pump and then the pump will tell, ठीक है आप ये खा रहे तो आपको 3 यूनिट लगाना पड़ेगा. That little bit they have to do. But I agree with you that a beautifully planned diet means the basal insulin will go up. You see our patients, the bolus is more. There the basal will be more.
Next, BK.
Thank you.
Excellent presentation,
Thank
Dr.
you, sir.
Unnikrishnan.
Thank you, sir.
And really, we enriched our knowledge. One thing is that what is the cost of therapy? You know, India is a country where 78 to 80% people lives in and this dual bionic pump, having the glucagon and the insulin, both are there. What would be the usual cost per month therapy so that the patient can afford it, or what is the government planning for that?
Quick questions, quick answers, please.
Quick answer,
we are running late.
It is not even approved in the US. It is FDA cleared. It's not FDA approved in the US. We don't know the cost. The challenge is glucagon is not very stable. So insulin will work for 3-4 days, but glucagon has to be changed every 9 hours. So patient has to change it twice a day at least. So that is difficult. So till they come with a stable glucagon, they are experimenting with dasiglucagon. Till it comes, it will take some time. And the answer is we have to make it in India. We cannot depend on future pumps. We have to make in India.
Right, Sudhir.
My question has been partially answered by you. My only query is how effective and how accurate is this ETO app and all in analyzing the carbohydrate content?
These apps are very good, but today patient can easily analyze it using any AI app. And these apps charge a huge amount and they have lot of funding available. So the patient can use it, but once the funding runs out of the company, whether it can sustain, we don't know. They're good, but I don't recommend it. A good dietitian is always better. Thank you.
One quick question to Sajjad. Any comment on SURPASS CVOT outcome?
So, as we have the data of the previous SURPASS and SURMOUNT, so SURPASS CVOT is, as comparing with the dulaglutide, it has shown the non-inferiority as compared to the dulaglutide. Dulaglutide has already shown a 12% CVOT good outcome. So we are expecting in the future triumph also that it will do some better results in terms of CVOT.
So the company was very ambitious that rather than comparing with placebo, they compared with dulaglutide. Unfortunately, it could not demonstrate superiority. So now where do they stand?
So at least they are at par with the dulaglutide. They are in some positive, good position.
So we can extrapolate the result that it is superior to placebo.
Of course.
Right. Thank you so much. With this, we conclude this session. Thanks all the speakers and the audience for excellent participation.
I thank the speakers and the chairpersons for an extensive elaboration of the topics. I would request the speakers and the chairpersons to move to the side stage for felicitation. I would request Dr. A.J. Unnikrishnan sir to come to the main stage for felicitation. To felicitate sir, I would request Dr. Supriyo Mukherjee sir to come on the stage, Dr. Shaibal Guha sir and Dr. Vijay Kumar sir. I have certain announcements to make. The RSSDI Bihar update book is being given to all the delegates and the faculties at stall number 14 on the 7th floor in the exhibition hall area. So please collect your copies. The poster presentation will commence at 2 p.m. in the reception hall area on the ground floor. The PGs are requested to come on time for the PG preliminary round quiz, which is to be held after the free paper session by the PGs in Hall B downstairs at 3 p.m. So we have come to the end of the previous session. Now, for the next session, I would like to invite the chairpersons on stage. Dr. R.P. Srivastav, sir. And Dr. Supriyo Mukherjee, sir. Over to the chairpersons.
Yeah, it's a privilege presiding over the oration, and it's a privilege that has been offered to both of us, Dr. Supriyo and me. I'm thankful to the organizers, the scientific committee members, to have us as chairperson for this Professor H.K. Singh Memorial Oration. So for that, we have an erudite speaker, that's Dr. Santosh Kumar Singh, and he will be talking about from classification to precision therapy in diabetes. हाँ वो तो पहले होना चाहिए ना वो
May I? Supriyo?
Please start, sir.
So, honorable chairpersons, respected seniors, dear friends, with a special reference to Unni, so you are well aware this is oration in honor of H.K. Singh sir. 3rd August 1943, a star was born. You can just well guess from this picture about this star. Sir did his MD in 1973, and I remember these dates. I'm very closely associated with sir. 73 was when I saw Bobby. And in 1982, sir became assistant professor in medicine in NMCH and then came to PMCH. And my journey, sir's journey goes hand in hand. In 1990, when I completed my MD, sir was associate professor of medicine, and important to add, the Department of Endocrine and Diabetes. So sir was the pioneer in establishing the endocrine and diabetes unit, I would say. It was under medicine, but he was the pioneer in establishing that unit of endocrine and diabetes. So 1990, he was associate professor, and then when I came after doing my DM and 1-year residency at BHU in 1998, sir was professor of medicine and endocrine unit. I had a stunt with him as deputed assistant professor in endocrine. So at that time we had this deputation as assistant professor, which lasted for 2 years. I was suddenly said that your deputation is off, and I was back to a PSC at Kalgaon. So I resigned from the job, and from that day, with my wife's backing, I was doing practice. Difficult to make two ends meet, but that was the journey. In 2004, sir was instrumental in holding the 32nd RSSDI meeting in Patna. And on the right hand side, you can guess my guide, my mentor, Professor C.K. Narayan sir. Beside him is Dr. H.K. Singh. In the jacket you can see, anybody can guess where I stand? दोनों दाढ़ी वाले हैं. One is the Al boss in gastro IIMS, and by his side is Santosh Singh. So from here we go to this presentation. My thanks to, I won't give thanks, they are my brothers, and I'm a part of RSSDI. So for this honor, I am privileged to talk on this occasion in honor of H.K. Singh sir. from classification to precision medicine in diabetes. I won't bore you, just be very vigilant on the slides. It has taken much time for me to prepare this, and I am very sure you will really like this presentation. So the first, classification and precision. You see in 400, 500 BC, and Sushruta and Charak's time, you just recognize two types of diabetes, Krish and Sthul, lean diabetic akin to type 1, obese diabetics akin to type 2. And noted that diabetes runs in families, hyperosmolar symptoms. And noted that lean diabetics are difficult to manage, so you can easily correlate type 1, type 2. Okay, so that was it. On the top again, you find a mention of the similar things, lean and obese, in the form of Mager and Grass, put forth by Harley in 1870. Just imagine the dates. Then came this concept of insulin sensitivity and insensitivity put forth by Harold Himsworth in 1936. And the Roman letters of 1 and 2 put forth by Deleuze of France in 1950. But type 1, type 2, it was coined by Philip Hugh Jones in 1955. So that the Arabic term 1 and 2. Then came this classification, 79 and 97. 1997, we are well aware, the ADA classification, type 1, type 2, other specific type, GDM, and then we have the pre-diabetic part. And 79, we have from the NDDG, IDDM, NIDDM, gestational diabetes, MRDM, and other types. And from here, I would deliberately move to this precision medicine, because in my talk, I would be just talking about the precision aspect according to the type of diabetes. So it will go hand in hand, and that's the reason I have put this precision medicine slide, just to emphasize the tripartite alignment between the patient's pathophysiology of diabetes and subsequent alteration of therapy. And it's a long-going process, it's still evolving, and it will make our jobs easier for personalized management of a patient, going from precision to personalized treatment. This is the classification from NDDG and ADA, incorporating both the therapeutic and etiological aspect. And from the therapeutic, you can easily guess, we have IDDM and IDDM. IDDM is the term used to use where insulin is necessary for survival of the patient. In IDDM, these patients can be controlled with OHs. Here, insulin may be required, and that is for glycemic control. So that is the basic difference of IDDM and IDDM. And across the spectrum, you can see the disorders where we link even with type 2 are falling under IDDM. So it was okay till we talked of management of glycemia, which was the initial concept of management. So control glycemia, then came the concept of control glycemia with less hypoglycemia and less of weight gain. But today's practice focuses on the management of glycemia and management of the complications hand in hand. So we need to be very different in our approach now, and that's the reason why we are moving towards precision medicine. I give an example of type 1. So we have this type 1A and 1B, and everybody knows about this. Okay, we have another type 1C. Here you don't have antibodies like type 1B, but the course is very rapid. Lower down, you can just imagine. One of our slides, we were talking about type 1A. It was shown by Ved, and he has emphasized on autoimmunity. But we know type 1 can be there even without autoimmunity. So that is 1B and C. Here you don't have any evidence of autoimmunity. Still you have beta cell destruction. Interesting again, you have the immune checkpoint inhibitors where you don't have the antibodies, but you have immune-mediated destruction of the beta cells. So such an interesting aspect of the subtypes even of type 1 where you are having beta cell destruction. Now the AB classification. You see, and this is very simple. You have the autoantibodies and beta cell function in the form of C-peptide estimation. And A plus, B minus, I won't go into the details of that. That is typical of 1A, autoimmunity, and insulin is the answer. You look at A minus, B minus, you don't have autoantibodies, but the beta cell reserve is very poor. And in this falls type 1 diabetes 1B. You don't have autoantibody markers. And here also falls type 2 diabetes, because we know type 2 diabetes is a spectrum from significant insulin secretory dysfunction to significant insulin resistance. So in this one, you can have significant insulin secretory dysfunction, less of insulin resistance, that will be also falling under this part. And then you have the ketosis-prone atypical diabetes, the flatbush diabetes, which is A minus, B minus. And the last part, typical of type 2, is A negative, good C-peptide response, and here the patient can be treated with OHs. And the entities you can see, type 2 diabetes, MODY, and FCPD. Continuing with type 1. So now we have, from the precision, now we are moving towards the genetics. So initially it was the rapid onset, and then why the difference? And you can easily guess the genetics of type 1A and type 1B. And this is similar to the severe insulin deficient diabetics, which was put forth by Alchemist in his different subtypes. And these are the different genes which we have. For type 1, all of us are aware of the HLA, the PTN22 and insulin and CTLA4. These are the typical genes which are responsible for type 1. But type 2, you have those two entities of proinsulin and insulin secretion, where there is predominant involvement of TCF7L2, etc. Now we come to the second part. So we are discussing type 1, and now we come to the MRDM. And MRDM, these are all old texts, I would say, and it incorporated PDDM, which was later the terminology put forth by WHO was MMDM, malnutrition modulated diabetes mellitus. So be very particular about this. Malnutrition related diabetes mellitus, it incorporated PDDM, later on said to be MMDM and FCPD. So FCPD we correlate with type 3C. It was nicely dealt by Subhas, and PDDM was MMDM. We have this classification of diabetes by the IDF, and here MMDM is said to be type 5. And lower down you see it is typical. We will see in the subsequent slides what does it incorporate. It is mainly the PDDM part. And look at the patient population. IDF is projecting 20 to 25 million people are living with that entity of type 5. Found out more about type 2 on IDF website, and you won't have to go to the IDF website. We are having a talk by Dr. Rajan from PMCH, who will be dealing with type 5 diabetes of the IDF. So this is the PDDM or MMDM. Look at this. The basics is age less than 30 years, BMI in the lean category of less than 18.5. They are having a moderate degree of hyperglycemia, high insulin requirement to the tune of more than 60 units or 1.5 unit per kg, and they are ketosis resistant. So two groups, Ahuja's group and Tripaঠি's group, putting forth this the scoring criteria for PDDM or MMDM. And then we have this FCPD. This is the diagnostic criteria of FCPD in absence of conditions like alcohol, hepatobiliary disease, primary hyperparathyroidism, and then you have to demonstrate the evidence of chronic pancreatitis. But we were talking about the precision aspect, and in FCPD, you can go for this pinky gene mutation. You might be aware, Unni is sitting over here. He was one of the pioneers in putting the national registry of FCPD. And then the important thing came out that everybody is aware of that these patients are more prone to develop pancreatic carcinoma. So FCPD patients, a patient having this entity, particularly with deteriorating glycemia, age after 50 years of age, you have to think of malignancy. Okay? So what's the significance of this gene mutation? So you see the two categories. Patients in the older age group, above 40, they are more prone to have pancreatic pain. Okay, but the patients harboring that mutation, they are younger, they have less of a pain intensity, but they have more of endocrine and exocrine dysfunction. So pancreatic insufficiency, exocrine, and the hormonal imbalance is more in the younger age group who are having this spinky gene mutations. So this is again about the precision in FCPD. Now we come to GDM. So we started with the IDDM and in the the MRDM, and now we come to GDM subtypes, and here two distinct entities have been put forth. One is when we go for the GDT, you have the fasting and you have the postprandial, 1 hour, 2 hour, and the high risk group and low risk group. The importance is in the high risk group, there is both maternal and neonatal outcomes are poor. And important is the fasting includes patients with hepatic insulin resistance, and the postprandials, they primarily are having muscle insulin resistance. So you just look from a simple test, you can easily guess the pathophysiology. And these postprandial elevation patients, they mostly do well with simple boluses, so during pregnancy. In the fasting, you need to have a basal insulin because we need to take care of the hepatic glucose production. So important is when you are having that fasting, that also involves the mixed type, you are having postprandial plus fasting elevation, and here the outcome is poor. And not only that, even for development of pre-diabetes, the same holds good. So these patients who are having of increased fasting, they are falling under both categories. The immediate outcome, maternal poor maternal outcome and neonatal outcome, and more so the long-term chances of developing pre-diabetes in this fasting category and the mixed category compared to the GDM postprandial category. So this is the subtyping and precision medicine regarding the gestational diabetes. Now we come to the latent autoimmune diabetes in adults. This term was used by Tuomi in 1993. Initial description was with type 2 diabetes who had ICA positivity, so behavior was like type 2, 1977. In 1986, it was typically type 1, but it was latent in onset. And that was by group, but ultimately these two were combined and the term latent autoimmune diabetes in adults was put forth by Tuomi in 1993. This is known to us, age more than 30, OHA responsiveness at least for 6 months, and you have ultimate insulin requirement and presence of autoantibodies. So these are the three characteristics of latent autoimmune diabetes of adults. The second nomenclature is slowly evolving autoimmune diabetes. So we'll see that in the WHO classification. So from the LADA we come to this flatbush or phasic IDDM ketosis prone atypical diabetics. Two modes of onset you see in children 14 and 40 years. Males more than females, they are obese with family history of diabetes. And interesting is this, they require insulin for a couple of days, even for months, but then they may not be requiring any treatment. Okay, and this has been found that the duration of remission is more in the patients who are initially treated with sulfonylurea or metformin, and that can last even for 10 years. So this is ketosis prone atypical diabetes, typically like type 2, but having a ketosis presentation. So this is phasic IDDM, but typically they are ketosis prone or typical type 2 diabetic like patients. But as you see, they also have HLA association of 35 to 60%. This is the WHO classification 2019. Okay, again showing type 1, type 2, other specific types, and the pregnancy. But two things which highlight this is hybrid forms. And this includes slowly evolving immune-mediated diabetes of adults, this is LADA, and ketosis prone type 2 diabetes. This is the flatbush we were talking about. And then one category is the unclassified diabetes. Okay, and unclassified is that you have worked up with the patient, you are treating the patient, but you have not come to a definitive diagnosis. So it does happen. Patients coming with very high glucose and we are giving insulin, but we have this in mind that possibly he might be having type 1 or having other types of diabetes, and that comes under unclassified till the diagnosis is done. Okay? And these are the different mutations which we are having there. So WHO, this was a full-fledged change in the classification. And from here we enter the precision medicine in type 2 particularly. Okay, and including the MODI. So these things I would just highlight what was the salient points in this study. Monogenic diabetes is not a single disease, this is known to us. The importance of polygenic risk score, PRS. And the advantage is they can be helpful in occasional patients for preventive diabetology. Importance is even PRS may not be sufficient, and from here we may have to go for the proteomics or metabolomics. So that starting from genetic mutations, you go for the genome-wide scoring, the PRS, and then the proteomics and metabolomics, and by all this we can improve our knowledge about precision medicine and imparting a better treatment for the patient. This is the usual flow chart for diagnosing different types of diabetes. It was spoken well by Ved. He could have put this slide, a very easy one for the management in youth. And lower down you see on the monogenic type, you don't have ketonuria, C-peptide is fair, response to sulfonylurea, these are falling under monogenic diabetes. That was sufficient previously. But nowadays, if you say monogenic diabetes, you have to prove it genetically. Okay, and this is the message. The different genes which are there in MODY, and look at the treatment profile. Sulfonylurea, GLP-1, type 1, you have type 3, HNF1 alpha, 1B is type 5, and here you have the different extra pancreatic conditions like renal, exocrine pancreatic dysfunction, and lower down you have the neurodevelopmental delay. Dr. Hemsankar Sharma talked about the mitochondrial diabetes. So you have to be vigilant about these conditions. Very nice slide. When to suspect MODY. So 6 points are there. Diagnosis of diabetes before 12 months, positive family history, particularly non-autoimmune, preserved beta cell function after 3 years of diagnosis. Okay, stable mild fasting hyperglycemia, MODY 2. Presence of insulin resistance in the form of basal insulin fasting more than 20 units, severe insulin resistance more than 70 units. This is the fasting one. Or presence of extra pancreatic features. Okay, and here I have mentioned tetraspanin A. And this is deliberate because we know about the antibodies. It is ICA antibody. We talk about Fogrin, IA2. We talk about zinc transporters. We talk about GAD. GAD is present for a longer period, and that is the antibody which we see for LADA. Tetraspanin A is another, and it has a diagnostic value, but more so a prognostic value. This is another antibody in type 1, which shows that if the patient harbors this, the patient will be having rapid C-peptide decline. Okay, so this is another one, and you need to remember. Lower down, I have mentioned about MODY 5 and de novo mutation. So you don't have always the 3 family penetrance to diagnose MODY. It can happen at de novo mutations, and you have to be cautious about this entity and more, I would say, proactive in diagnosing MODY, and the characteristics I have laid down. MODY 5 I have mentioned, it took a decade for me to diagnose a patient of mine who was being treated with insulin, no issue. But a decade later, I diagnosed the patient as having MODY 5. And that stemmed from the extra pancreatic involvement in the form of agenesis of the dorsal pancreas, from the increased PTH these patients have, and these things are to be kept in mind for MODY. One thing I always ask whenever I talk on the MODY is monogenic forms of insulin resistance. So we correlate MODY with beta cell function. We can have monogenic forms of diabetes linked with insulin resistance, and these are the entities. It was elegantly dealt by Dr. Hemsankar Sharma about the insulin resistance, leptosonism, absent mental hall, the lipoatrophic, and mutations in PPAR gamma. So these are the insulin resistance types of monogenic forms of diabetes. Interestingly, HNF4 alpha, we link this with MODY, but the different polymorphisms, as you can see, they can be linked both with beta cell function and insulin resistance. So look at this, only genetic mutations, getting a test done, undo. So you have to put the things in perspective in the type of patient you are seeing. So it can be linked with insulin secretion defect and insulin resistance defect. Okay, now from here the second part, from monogenic world to polygenic world. And what's the significance of this? Genetic propensity for obesity, you can see there is younger age of onset of hyperglycemia in MODY. So if the patient is prone for diabetes, for obesity, and the onset of MODY will be earlier. Lower down, if the patient is having other variants linked with type 2, viz. TCF7L2, there are more chances of having sulfonylurea failure in MODY patients. So just see how the polygenic risk score is modifying the presentation of different types of MODY in day-to-day practice. And here the significance, this third part, from genomics to proteomics and metabolomics. And P and M, this is quantitative trait loci, that is the term we use, quantitative trait loci, and one P is for proteomics and M for metabolites. Now here we enter into the arena of type 2 diabetes subtyping, because this we correlate with Alkevist data, and then it was modified by others. This is Swati Misra's paper. Wagner's was there. Wagner was one of the pioneers in incorporating the clinical type and the genotype. And this was a very nice study, 2023. One is the simple approach. the other is complex, involving all those things, BMI, GAD, HOMA. That's the typical third category which we have. But I'm interested in the simple one. This is one of the earliest studies of precision medicine, clinical trial, the TriMaster study. Look at the beauty. Patients with having BMI more than 30, pioglitazone had a better HbA1c lowering compared to sitagliptin. Just imagine the paradox. BMI more than 30, pio is scoring over sita in reducing HbA1c. Similarly, the obese females, they responded in a better way with pioglitazone. Non-obese males, they did well with sulfonylurea. Interestingly, EGFR more than 60, sitagliptin had a scoring point on canagliflozin. So these are simple markers where the patient characteristics will just tell you which molecule to prescribe in that patient for good response. Now we come to the typical SED, SID, SERD, and MOD and MERD, and everybody, I think, in this hall is aware of these terminologies. We have severe insulin deficiency, we have severe insulin resistant, mild obesity-related diabetes, mild age-related diabetes. And don't get this impression that mild is that the clinical profile is mild. This mild terminology is regarding insulin secretory dysfunction or insulin resistance. Okay, so that nomenclature mild is for that only. As because we will see in the complication slide, we do have problems even in the SID category, even in the mild obesity diabetes or the mild age-related diabetes. As I said, the process is ongoing. Okay, and here the other variants which have been shown, ALP negative category, alkaline phosphatase, reduced SHBG, and more so, talk of the day, elephant in the room, lipoprotein little a. And these are now newer entries in the arena of precision medicine, linking the increased incidence of diabetes and more so increased incidence of CKD, as you can see in this polymorphism of lipoprotein little a. Now clusters, you have the GWAS, genome-wide screening, and the metabolic part, and look at the beauty lower down. You have the different genotypes, the liver lipid, they will be presenting with reduced EGFR, but interestingly, they also have reduced USER. And occasionally you will see patients where you don't have the answer. Okay, a patient having a marked reduction in EGFR, but the USER is not that much. So you can easily guess in which category they are falling. Similarly, the lipodystrophy, they will be having elevated USER. And the significance I will show you in the subsequent slides. So this is the genetic part, and then you have the typical metabolic part, which was put forth by Alkevist. This is the scenario, the complication part, beta cell proinsulin, obesity, lipodystrophy, liver lipid, and loci. So this is from the genetic analysis. And it won't be tough to understand when I will show you the comparison of the genetic and the clinical clusters. This is it. Look at the complication part. In SID, you are still having increased retinopathy, you are having peripheral neuropathy, you are having cardiac autonomic neuropathy, and interestingly, high prevalence of erectile dysfunction, which is still there in the third category. Okay, and third category patients are typical of having increased incidence of CKD and MAS LD. MOD, you see intermediate prevalence and risk of diabetes-related complications. Lower down, as I was saying, mild age-related diabetes. Here you have increased risk of coronary events and stroke, like you have in the other categories. Okay, so this mild terminology should not be there regarding complications. Okay, the age-related categories, they are at increased risk of coronary events and stroke. This will be easy to understand the cluster-wise genetics. So severe autoimmune diabetes and severe insulin deficient diabetics, I told you about this genetic differences in type 1. This is the SIRD and mild obesity-related diabetes. So see the overlap. The FTO and MC4R, they are in both the mild obesity and the SIRD, but lower down, this is the liver adipose tissue, you have the mutations in the other genes. Okay? And then this is the mild age-related diabetes, you have lowest diabetes genetic risk score, but weak association are there with both beta cell genes and the insulin resistance genes. So this is the mild age-related diabetes. And this is just the differences in the insulin resistance and secretion according to the GRS. Now, according to the mechanistics, this was a very recent study of this month only. And they have looked at the visceral adipose tissue volume, and this was maximal in patients with SIRT. The hepatic lipid content was maximal in patients with SIRT, and that will be easy to understand why there is increased cardiovascular problem, why there is increased mass LD problem in patients with SIRD. This is the treatment part. Anybody's guess, SIDD, insulin or sulfonylurea, SIRD, particularly the molecules which will impact the insulin resistance, including the glutazones, and typical role of SGLT2 inhibitors, GLP-1 receptor agonists because of the CKD and mass LD protocol. For MARD, you have a combination of the drugs, and for MOD, mild obesity-related diabetes, is typically the weight reduction which matters, and here you have lifestyle modification, SGLT2 inhibitors and GLP-1 receptor agonists, which will be much helpful for this category of patients. We have mixture of these in the other Asian populations. So that was from Sweden. This is from the Asian population, and here you don't find a mention of SIDD in separately. So this is all combined. This incorporates severe insulin resistance with relative insulin deficiency, and look at the drugs which we are using. It is just like typical SIRD, and in patients with mild age-related, again, you have to think of the sarcopenia part and proper use of molecules which will take care of sarcopenia. Above, on the top, as you see, the emphasis on lifestyle modification to reduce weight in the mild obesity-related diabetes. Now the importance of pharmacogenetics, the different polymorphisms impacting the actions of efficacy of these molecules. So I won't go into the details. If you want to take a snap, you can. And these are the other adverse reactions or efficacies which can be impacted by the different genetic polymorphisms, again leading towards precision medicine. And now we are coming to 2 to 3 slides which are there. And this is very important. These are the summary slides. What to do with this concept. Okay, and on the top you have robust and reproducible genetic predictors of response. Step 2 is metabolic phenotype modifiers of response. Step 3 is evidence that prediction leads to better outcome. So from these two we can predict. Okay, but step 4 is evidence for cost effectiveness. If you incorporate everything, how cost effective it can be. And lastly, how effective is the implementation. And for monogenic diabetes, you see, it's robust. Large effects with the predictors, genetic predictors, but a small effects of the phenotypic differences. I told you about obesity genes. I told you about the type 2 genes which can change the presentation of MODI, and evidence that prediction leads to better outcomes, robust. Okay, evidence for cost effectiveness, definitely good. And effective implementation is moderate at this juncture. But look at for type 2. For the genes, weak to moderate effects. Okay, and then for the phenotypes, moderate to large. Definitely the different phenotypes, we talked about the metabolites, the metabolic aspects, it's definitely good. But evidence that prediction leads to better outcomes, it's limited still. Evidence for cost effectiveness, limited still. And effective implementation, still I won't say it is at an infertile stage. We need to do better regarding this. Same has been done for precision medicine in type 1, and I'll only lead the last one. And Unni has talked much about this. So step 1, evidence of functionality. Closed loop and CGM systems demonstrate improved glycemic control and quality of life in trials. Evidence of cost effectiveness, definitely. Increasing evidence in high income countries, inaccessible for low income countries. This was the question which was put forth to him. And recent implementation of CGM in UK standards of care guidelines. NICE is very cost effective. Despite that, they have made it clear for incorporation of CGM in their practice. So this was the last slide. In clinical practice, what matters is this. This is not in any classification, but this is definitely for our precision medicine. When we talk of refractory diabetes, we are sweating what to do with the patient and what could be the factors there. Inappropriate diet, diabetes and depression, presence of occult or symptomatic infection, instrument failure, we have lack of exercise, ethanol and endocrine problems, including the adrenals, and we are well aware of the Catalyst trial where patients who are having poor glycemic control, receiving multiple antihypertensives, it is mandatory today, I would say, to go for the dexamethasone suppression test to look at this aspect of apparent cortisol excess. So this is important even in our clinical diabetic practice. to look for the adrenal problem. And then the technique of insulin, it should be our practice to show the patient how to take insulin properly, the timing of administration, and U40, U100, it is known to all of you. You have to see by yourself whether the patient is injecting U40 insulin with U40 syringe or U100 insulin with U100. No problem with the pen. But when you are giving cartridges, you have to be very particular about the type of syringe the patient is using to avoid a catastrophe. Sleep disorders, equally important, surgical comorbidity, and important again, the social determinants of health. So if you write something, semaglutide by Ajay sir, sulfonylurea, metformin by Hemsankar Sharma sir, but it's important that the patient has to afford that medicine for his benefit. So thank you all for the patient hearing, and again, my pranam to H.K. Singh sir, and my thanks to my brothers for this prestigious honor they have given to me.
Thank you, Santosh. As usual, it was a very power-packed and knowledge-packed oration. As is the want of the occasion, the orator for this, any oration is presented with a plaque. For that, RSSDI BIHAR chapter would like to felicitate Dr. S.K. Singh by presenting this plaque.
Let me read it for Dr. Professor Santosh Kumar Singh. To commemorate the academy legacy of Dr. Professor H.K. Singh and in recognition of scholarly excellence in diabetes, that Dr. H.K. Singh oration is conferred upon Dr. Santosh Kumar Singh, DM, FACE, a distinguished endocrinologist and a diabetologist from Patna, Bihar. He received his formative academic training under the mentorship of Professor Dr. H.K. Singh during his MD course in 1988 to 1990, and later served as a deputed assistant professor of endocrinology from 1998 to 2000 in Patna Medical College. His academic engagement is reflected in 56 scientific publications in peer-reviewed journals, contributing meaningfully to endocrine and diabetes education and clinical practice. Dr. Singh has provided notable leadership in professional bodies, serving as President, Endocrine Society of India, Bihar Chapter, President, Dr. Bihar Diabetes Federation, and Chairman, RSSDI BIHAR Chapter 2018. He has also served on Executive Committee of Endocrine Society of India, 1998-2000, and continues his academic contributions as faculty CCEBDM and ACMDC, upholding the value of mentorship, scholarship, and service exemplified by Dr. Professor H.K. Singh, sir. Thank you very much.
Thank you, sir, for the masterly oration. We are elated to see an almost packed hall for the afternoon session. To take forward the next session, I would invite the moderator, Dr. Shankar Kumar from Sitamarhi. I would also like to invite the chairpersons on the stage, Dr. Sudha Jha from Sitamarhi, Dr. Birendra Sharma from Muzaffarpur, Dr. S.N. Goit from Darbhanga, if he's here, and Dr. Deepak Kumar Pintu from Darbhanga. Over to the chairpersons.
Hello. Now I am going to start a very wonderful session, and the speakers are Dr. Sudhir Chand Jha, Dr. Raj Kamal Chaudhary and Dr. Kamran Khan. First of all, I invite Professor Sudhir Chand Jha, a renowned diabetologist of Bihar and Professor of Medicine, to deliver the lecture on remission and regeneration. Can beta cell recovery become a reality? Okay, sir. Over to Dr. S.C. Jha.
Respected chairpersons, seniors, and esteemed colleagues, I will start with a very astounding fact. In a 70 kg person, pancreas weighs 70 gram. And out of those 70 gram, only 2% is beta cells. That comes to around 1.5 gram. Yet, that little tissue is the master controller of the glucose metabolism. Hence, this talk becomes so meaningful, talking about regeneration of the beta tissue and remission of diabetes. Beta cell failure occurs in both type 1 and type 2, and we know the key difference that in type 1 it is autoimmune mediated, and surrogate markers used to evaluate beta cell functions in practicality are C-peptide levels, disposition index, and HOMA beta. And we'll be discussing this under these headings: defining key concepts, then reviewing mechanisms, evaluating evidence, and then explore therapeutics. We all agree that the whole world is witnessing a tsunami of type 2 diabetes mellitus in particular, and most of this tsunami is occurring in middle and low income countries like India. That is the unfortunate part. 108 million in 1980 jumped to 530 million in 2024, and 10% of the adult population affected by it. Now, pathophysiology of beta cellular failure is very important at the outset. First is the insulin resistance, all of us know. Peripheral tissues become less responsive, triggering compensatory hyperinsulinemia that places excessive demands on beta cells. And beta cell overwork is there, and that leads to exhaustion, glucotoxicity and lipotoxicity, where they create a vicious cycle of the progressive beta cell damage. And chronic inflammation further compounds beta cell dysfunction through cytokine mediated signaling system. Now, this concept of diabetes remission was first taken up by ADA 2021, which defined it as achieving glycosylated hemoglobin less than 6.5 for at least 3 months without active pharmacological therapy or ongoing procedures. Partial remission when it is sub-diabetic hyperglycemia, glycosylated hemoglobin between 5.7 to 6.4. And complete remission when the glucose parameters come down below 5.7 glycosylated hemoglobin. And sometimes we use the term prolonged remission when the complete remission is maintained for 5 years or longer. one very important point to remember. Remission reflects disease inactivity and does not constitute a cure. It represents a favorable metabolic state that requires ongoing monitoring and lifestyle maintenance. So what are the mechanistic basis of remission? If we consider 4 pillars can be considered. One is the enhanced insulin sensitivity, restoration of peripheral tissue responsiveness. That will lead to improved glucose uptake, reduced adipose tissue lysis. And beta cell recovery is the second thing. Relief from chronic metabolic stress provides this. Then ectopic fat reduction is very important, now we know. The twin cycle hypothesis by Taylor et al. In 2018 demonstrates that reducing intrapancreatic fat and liver fat specifically improves beta cell function. Then there is a term cellular redifferentiation. Now reversal of beta cell dedifferentiation. When beta cells lose their power, that is dedifferentiation. When they regain it, it is redifferentiation. Well, reversal of beta cell dedifferentiation restores expression of key transportation factor and insulin secretory mechanism. Now, the direct trial was the landmark evidence to show what is the result of weight loss and calorie restriction. It was first published by Taylor and colleagues in 2018, and patients were evaluated for 12 months, and it showed the groundbreaking evidence that substantial weight loss can induce diabetic remission in nearly half of participants. The underlying mechanism centers on the twin cycle hypothesis again. Dramatic calorie restriction reduces both hepatic and pancreatic fat content, which directly improves insulin sensitivity, restores beta cell secretory capacity. Now, bariatric surgery, all of us know, they have got the astounding results out of it on the beta cell recovery. Surgical intervention, metabolic surgery produces remission to the tune of 60 to 80%. And it results in the hormonal changes as well. Anatomic rearrangement triggers dramatic increases in GLP-1 and other beneficial gut hormones within days of surgery. And metabolic benefits, they are sustained improvement, persisting for years after the procedure. And Mingron and colleagues demonstrated that long-term follow-up studies produces durable remission rates far exceeding those achieved with medical therapy alone. That was the groundbreaking results. Now, are there any pharmacological modulators? Yes, we are very lucky to witness the changing paradigm of the treatment of type 2 diabetes mellitus with GLP-1 receptor agonist and SGLT2 inhibitor and DPP-4 inhibitors. And combination therapy also provides very important results. Now, early intensive insulin therapy have been talked about, and this is known as the beta cell rest hypothesis. The short-term intensive insulin therapy in newly diagnosed type 2 patients induces remission in approximately 50% of the cases, as demonstrated by Wang and colleagues in their landmark 2008 study. The mechanistic rationale centers on providing exogenous insulin to rapidly normalize glycemia, thereby relieving beta cells the burden of hypersecretion and allows their recovery from the glucolipotoxic states. So rapid normalization occurs after 2 to 3 weeks of intensive therapy, and beta cell rest period is there. Then there is reversal of toxicity and functional recovery occurs. So molecular pathways are very important, and these are the cellular mechanisms for recovery. One is the dedifferentiation reversal we just talked about, and mitochondrial repair occurs as a result of this, transcription, fat expression, and autophagy expression or activation. Now, regenerative possibilities, what are they? Why we are talking about this? Are there any regenerative possibilities? Yes, sources of new beta cells. Beta cell replication is one. That is the self-duplication of the existing beta cells. That represents the most straightforward regenerative mechanism. While this occurs at the low baseline rates in normal humans, it can be potentially enhanced through mitogenic stimulation. Second is the progenitor neogenesis. The pancreatic progenitor cells within ductal epithelium may differentiate into new beta cells under a specific condition. Very wonderful observation. Transdifferentiation. The cells which were supposed to secrete glucagon, conversion of those alpha cells into insulin producing beta cell is the wonderful landmark. And it has been demonstrated in mice, and this is hoped to be replicated in human beings also. Now this is stem cell and islet based therapies. Stem cell based beta cells, groundbreaking advances in directed differentiation protocols have enabled generation of functional beta cells from human pluripotent stem cells. Pagliuca and colleagues in 2014 developed a multi-stage protocol that recapitulates pancreatic development, yielding cells capable of glucose-responsive insulin secretion. And then islet transplantation. The Edmonton protocol published by Sapiro and colleagues in 2000 established islet transplantation as a viable therapeutic approach. By infusing isolated pancreatic cells into hepatic portal vein and using immunosuppression, which is steroid-free, the protocol achieved insulin independence in type 1 diabetes. Now there is another, this gene editing and epigenetic modulation. Good work is going on, precision tools for beta cell enhancement. The advent of CRISPR Cas9 gene editing technology has opened unprecedented possibilities for correcting genetic defects and enhancing beta cell function at the molecular level. The precision tool allows targeted modification of specific genes implicated in beta cell dysfunction, potentially correcting monogenic forms of diabetes or enhancing resilience to metabolic stress. Researchers are exploring applications including correction of MODY mutations, which Dr. Hemshankar Sharma sir was so nicely talked about. The technology could also be leveraged to improve stem cell derived beta cells before transplantation, optimizing their functional properties and stress resistance. So as a result of this, it is possible to correct the genes, reduce stress resistance, and epigenetic reset is possible. Now this is immune modulation in type 1 diabetes. Unlike type 2 diabetes where metabolic factors dominate, type 1 is the autoimmune issue. Now early trials showed initial anti-CD3 monoclonal antibodies showing proof of concept for immune modulation preserving C-peptide. And then the landmark thing, FDA approval of teplizumab in 2022 for delaying type 1 onset in high-risk individual marked the watershed moment in the treatment. Then the future, the combination approaches are coming into different trials giving good results. And last but not the least, we have got a future vision where we may achieve our goal. The dictum is intervene before significant beta cell loss, maintaining endogenous insulin secretion long-term as much as possible. Then nutraceutical and microbiome influence is also there. The emerging evidence suggests that specific dietary compounds may support beta cell health, and they work through their antioxidant and anti-inflammatory mechanisms. Polyphenols found in berries, green tea, cocoa demonstrate protective effects. And omega-3 fatty acids, particularly EPA and DHA, exhibit anti-inflammatory properties that counteract the chronic low-grade inflammatory properties. Then everybody is talking about gut microbiota that plays an increasingly recognized role in the metabolic health. Specific bacterial species influence insulin sensitivity through production of short-chain fatty acid, modulation of gut hormone secretion, and effects on the systemic inflammation. Intervention targeting the microbiome, including probiotics, prebiotics, dietary modifications, show promise for improving glycemic control. While the effects are generally modest, microbiome optimization may serve as an adjunctive therapy supporting remission, maintenance, and reducing relapse risks. So predictors of successful remission, who benefit? are all diabetes going to benefit? No, disease duration is very important. 5 to 6 years of diabetes is okay. Beyond that, it becomes very difficult. Then good C-peptide level promises good future. Baseline glycemia, that is HbA1c, closer to diagnostic threshold, that indicates preserved beta cell function and predicts better response. Then weight loss achievement, magnitude of weight reduction directly correlates with remission likelihood. That is why so much talk about semaglutide and tirzepatide. Loss of 15 kg or more shows particularly strong association with sustained remission. Reduction in hepatic and pancreatic fat content rather than total weight loss per se appears mechanistically crucial. So limitation and challenges of course are there. First is the definitional inconsistencies prevailing across the different apex diabetic bodies and relapse. Second is the immunological and ethical constraints. Cost and complexity of regenerative therapies. The current costs estimate $1 lakh to $5 lakh per patient for experimental therapies. Healthcare system barriers are there. Then what are the future directions? The new frontiers in the diabetes treatment. Number one, multimodal regenerative approaches. Combining gene editing with stem cell therapy and incretin-based treatment may yield synergistic effect. Biomarker guided precision medicine. Each patient is different from other. Advanced delivery system. We just heard about the advanced delivery system of bionic pancreas. And emerging technologies including machine learning for outcome prediction, continuous glucose monitoring are very important. So the take-home message, esteemed colleagues, are that beta cell recovery is biologically plausible and clinically had been demonstrated. Regenerative, metabolic and immune therapies are converging. Early intervention maximizes remission potential. So the idea is intervene early and delay the loss of beta cells as much as possible. Remission, however, does not equal cure, but represents an achievable target. Thank you for the patient hearing.
Thank you, sir. Thank you, sir, Dr. S.C. Jha. And you covered remission, diabetes, and regression, remission, and reversal of beta cells. Nicely presented. Any question, audience, please? Okay. Okay.
The next speaker, I would like to invite next speaker, Dr. Raj Kamal Chaudhary, sir, who will talk on individualized care in diabetes, the importance of a multidisciplinary diabetes care team.
Good afternoon, everybody. First of all, I must thank Dr. Vijay, who has invited me in this RSDI forum, and I'm here to present you this public health domain. This is nothing, the importance of the multidisciplinary care team for diabetes. Diabetes mellitus, as you all know, is a major global health challenge affecting hundreds of billions of people worldwide and contributing substantially to morbidity, mortality, and healthcare costs. As a chronic metabolic disorder characterized by impaired secretion, insulin, action or both, leads to persistent hyperglycemia and long-term damage to multiple organs. The burden of diabetes continues to rise due to the aging populations, urbanizations, lifestyle changes, and increasing obesity rates. It differs clinical presentation, associated comorbidity, and significant risk of complications. make a diabetes a complex condition, require timely direction, continuous monitoring and coordinated healthcare strategies. More than 500 million people living with diabetes worldwide. So you can expect the devastation it is causing. Expected to reach 643 million people by 2030. 1 in 10 adults currently affected, leading cause of blindness, kidney failure and amputations. Major contributors to cardiovascular mortality. Now, complications. We come to macrovascular complication, that is, all of you know diabetic retinopathy, nephropathy, diabetic neuropathy, peripheral neuropathy, and automatic neuropathy. Macrovascular complications, coronary artery disease, angina, myocardial infarction, and heart failure, cardiovascular disease, stroke, TIA, peripheral arterial disease, claudication, critical limb ischemia, and amputations. Other clinical significant complications: diabetic foot ulcers, infections, osteomyelitis, and amputations, skin and soft tissue infections, recurrent UTI and fungal infections, impaired wound healing, non-alcoholic fatty liver disease, NAFLD, which has taken a toll right now, depression and psychological burden, acute metabolic emergencies, that is diabetic ketoacidosis. The need for individualized diabetes care. Diabetes is a heterogeneous disease, meaning it presents differently in each individual. Variations exist in a metabolic profile, comorbidities, socioeconomic factors, and cultural practice. Consequently, a one-size-fits-all approach of the treatment approach is ineffective. So you cannot say that one treatment is effective for all. Leading clinical guidelines now strongly advocates for individualized care where therapeutic decisions meticulously aligned and each patient's unique characteristic preferences and personal health goals. This approach ensures more effective and patient-centric management of the condition. Introduction to the multidisciplinary diabetes care team, that is collaborative model, integrates diverse healthcare professionals for holistic care. Preventive aims to mitigate complications and improve long-term outcomes. Patient control focuses on individual needs, preferences, and goals. Comprehensive approach addresses medical, educational, and psychological aspects. A key pillar of individualized diabetes management in the multidisciplinary care treatment. This collaborative model together various healthcare professionals to deliver comprehensive, preventive, and patient care centered. Each member plays a distinct yet interconnected role in supporting the patient throughout their distinctive journey. Now, the core members of the MDCT, that is the primary care provider, this PACP serves as the initial and central coordinator of the diabetes care. Their responsibilities include routine clinical assessments, monitoring glycemic trends, evaluating cardiovascular and metabolic risk factors, and screening for early complications. They also initiate or adjust pharmacological therapy and ensure timely referrals to specialists providing longitudinal care. Endocrinologists often specialize expertise in hormonal regulation and glucose metabolism. Their involvement is crucial in complex cases as of diabetes type 1, severe insulin resistance, recurrent hypoglycemia, or those requiring advanced therapeutic technologies like insulin pumps and continuous glucose monitoring. They optimize individualized treatment strategies based on physiological and patient preferences. Diabetic care education and specialists. Diabetic care education professionals and provide structural diabetes self-management education and support. The evidence-based approach covers blood glucose monitoring, medication adherence, lifestyle modification, the reduction to provide solving and ongoing strategies. DSMEs significantly improves glycemic outcomes, reduces emergency visit and enhances quality of life by empowering patients and the self-care. Registered dietitian, medical nutrition therapy provided by RDs is the cornerstone of the diabetes management. RD is assessment dietary patterns, metabolic needs, cultural practices and socio-economic context to develop personalized meal plans. The plans aim for glycemic stability, healthy body weight, improved lipid profiles and reduced cardiovascular risk and sustainable lifestyle changes. Ophthalmologist and optometrist. Diabetic retinopathy is the leading cause of preventable blindness. Eye care specialists are required for comprehensive retinal evaluations to detect early changes and like laser photocoagulation and anti-VEG injections preserving vision. Audiologist can affect the auditory system causing early onset hearing impairment. Audiologist conducting hearing assessment for early detection and timely rehabilitative strategies, supporting better communication, safety, and overall quality of function of life. A podiatrist, as you all know, peripheral neuropathy and arterial disease heightens the risk of foot ulcers and amputations. Podiatrists provide preventive foot examination, wound care, and corrective interventions, playing a critical role in preventing life-threatening complications and improving functional outcomes. A pharmacist are crucial for optimizing pharmacotherapy. They conduct medication reconciliation, identifying drug interaction, advise on proper timing and adherence, and guide safe overall counter drugs that may influence glycemic control. They also educate patients about potential side effects, ensuring medications safely effectiveness. And dentists, a higher risk of periodontal disease and oral infections due to diabetes and due to the altered immune function. Dentists provide preventive dental care, early detection of periodontal disease management and oral infections, and guidance on maintaining oral hygiene. Addressing periodontal inflammation can contribute to improved glycemic control and overall health. Nephrologist, as you know, diabetic kidney disease is the leading cause of chronic CKD and the end stage renal failure. Nephrologists evaluate renal function, implement renoprotective strategies, manage electrolyte imbalances, and prepare patients for dialysis or transplantation. Early referral is critical for slowing progression and improving outcomes for those. Mental health professionals, psychological factors such as diabetes, distress, depression, anxiety, and burnout significantly impact disease diabetes management. Mental health professionals provide psychotherapy, behavioral, individual and pharmacological management, which Dr. Kamran Khan will tell you more of it in his next topic. Exercise specialist. So physical activity improves insulin sensitivity, cardiovascular health and functional status. So we can go on it. The patient, the pivotal member, modern diabetes management, emphasize shared decision making where patient actively participate in setting goals, selecting therapies and implementing lifestyle modifications, recognizing patient autonomy, preferences, beliefs and social context, strengthens adherence and enhances outcomes. Within the MDCT, the patient remains the pivotal member supported by coordinated professional care. Discussion, and this is the last slide, the multi-dimensional nature of diabetes and necessitates a coordinated multidisciplinary approach to demonstrate effect, improve metabolic outcomes, reduce complications rates and enhance the patient satisfaction compared with isolated provider-based care. While implementation such barriers such as resource limitations and fragmented health system persist, innovations like digital health integration, telemedicine and community-based coaching are bringing this gap. Strengthening integrated patient-centered healthcare system will be crucial, will be critical for achieving the goal, long-term goal, the success in diabetes care globally. Thank you.
Thank you very much, sir. Thank you very much.
Thank you.
And I invite next speaker, Dr. Kamran Khan. And the topic of today's discussion is depression, subtypes, and diabetes, sorting the stronger link.
Good afternoon, everybody. I am very much thankful to the Bihar RSSDI organizing team for inviting me to speak. So, I am not going to discuss the minutest science regarding diabetes or something which is not being reflected on the prescription very easily. Rather, I am going to discuss some basic things which we meet in our day-to-day practice. So, we all have patients who, when pronounced that they are diabetic, they become gloomy, they become depressed, and rather they become distressed. So, how this mental issue goes with a diabetic patients? We will, in the next 15 minutes, we will explore the things very quickly. So I don't have any conflict of interest. So what's the reality of mental issues prevailing in diabetes? There is 2 to 3 times higher risk of diabetes in diabetic patients than the normal subjects. And there is a bi-directional relationship. There is a proverb that 2 to tango. That means 2 persons are hurting each other and both are making the things worse for each other. So this is the exact situation in diabetes and mental issues. It is highly prevalent. Clinical implication is dysglycemia, uncontrolled blood sugar level, increased rate of complications, HbA1c not getting controlled, and there is heterogeneity like behavioral and metabolic effects on diabetes management, and precision care necessity is being there as a strategy. So depression leads to low motivation and increased cortisol, and diabetes leads to hyperglycemia and inflammation, and that results into 2 to 3 times higher risk of developing depression. So if as compared to general population, type 2 diabetes patients are having depression 2 to 3 times, and in 50% of the diabetic population, depression is not diagnosed. Who are prone to have depressions? Type 1 adolescents, because they have to study, they have to have jobs. Women with type 2 diabetes, women have many responsibility of household things, so they become distressed. Patients with complications, if somebody is having complications like renal disease or some heart failure issues, they become very much distressed and depressed. And insulin treated patients, the fear of pricks, the fear of longevity, the fear of what will happen next, ab insulin ke baad kya hoga. So these things make a people depressed. What are the things which play the role? This HPA axis hyperactivity, they promote insulin resistance. There is a pro-inflammatory state due to dysglycemia in the form of elevated IL-6 and TNF-alpha, and autonomic imbalance because there is high sympathetic overdrive, there is heart rate increase and blood pressure increase, and that will give rise to increased cardiovascular risks. Other altered pathways are dopamine-related pathways. Dopamine dysregulation leads to cravings for high sugar food, fat foods, and overeating. Because we all know that dopamine and serotonin, these are the hormones which makes the mood elevated. So they will be go for the eating without any appetite. Beside that, there is reduced motivation. अब diabetes हो गया, अब life में क्या करेंगे? अब कुछ नहीं हो सकता. Sleep disturbances, insomnia or hypersomnia due to various hyperosmolar symptoms, nocturia, polyuria, these are the things. So each depression and diabetes as correlates with each other, and they augment each other. So what is the impact on diabetes outcome? There will be glycemic control affected up to 0.5 to 1.5% if the patient is having this depression. You will normally see in your clinic that the patient's attendants say that बहुत गुस्सा करते हैं आजकल, and when you find their blood sugar level, it is higher and the HbA1c value is raised. This is the way in which it affects HbA1c control. Whatever the drugs, newer drugs we have in our basket, GLP-1 receptor agonists, SGLT2 inhibitors, if we are not focusing on the mental health of the patient, things are not going to work. Besides that, there is increased complications due to depression, there is increased glycemic variability, poor self-care adherence, and finally leading to all-cause mortality. So another burden is higher cost, increased primary care visits because they will develop somatoform disorders, they will having weight pain syndrome, their pain perception will get increased, their foot pain and all the neuropathic pain will increase, and they will visit you often. Productive loss is there, they will try to avoid things, and finally the quality of life changes. So there are various subtypes of depression in this condition. Major depressive disorder may be there, atypical depression is there, persistent depressive disorder is there, subclinical depression is there, and bipolar depression. These things are to be treated by a psychiatrist, not by a physician or a diabetologist. Accordingly, we have to demarcate whether the patient is suffering from diabetes depression or diabetes distress, because both are different identity. So again, the same thing which I have already told, that HPA axis activation, sympathetic overdrive, abdominal adiposity, inflammatory cascade, sleep architecture all lead to depression or stress, which will lead to counter-regulatory hormones like cortisol to increase inflammation, sleep loss, and inactivity. We have many questionnaire-based tools to see whether the patient is having depression, like PHQ-9, HADSD, BDI-2, and CSDD. All are based on depressive scales like motivation, like sleep hours, like appetite, and we can come to a conclusion that the patient is having some sort of depression, and accordingly either we treat it ourselves by giving some SSRIs or SNRIs, or we refer the patient to a psychiatrist. So here comes the actual thing which we face. What is diabetes distress? It is not depression, it is diabetes specific emotional burden. And this emotional and behavioral challenges that arise from living with and self-managing with diabetes impact day-to-day decisions and health behaviors. They will feel overwhelmed by self-management, worry about future complications, क्या होगा मेरा, बच्चों का क्या होगा, frustration with glucose variability, इतना शुगर कंट्रोल नहीं हो रहा, इतना दवा लेने पे भी, conflict or misalignment with family and healthcare team. There will be often a tiff with the family person, with the spouse, regarding the foods they are giving, regarding the things which he cannot do due to diabetes, and this in turn leads to development of diabetes distress. So if we see it in the statistical form, 65% patients are having no diabetes distress, but 25% of the patients may be having mixed type of diabetes distress and diabetes depression. 10% patients may be diabetes distress. So what are the things a patient of diabetes distress feels? They feel defeated. They deny the things that they are having diabetes. They will eat sweet in the public, in the functions. They will deny that they are having diabetes. They fear a lot. If they listen some news that somebody has died suddenly and he had diabetes, they become very much feared. Frustration is there. Why me? मुझे ही क्यों diabetes हुआ? Low motivation, loneliness. These are the things which causes diabetes distress. So there is a scale to diagnose diabetes distress. This is diabetes distress scale 17. It had 17 items: emotional burden, medication related distress, physician related distress, interpersonal distress. So this distress was not adequately catering to the populations of the country where the literacy is low, where the financial conditions are not good, a country like us. So I, along with some of my colleagues, tried to develop a scale, modified diabetes distress scale, which are being validated under the process of validation. And what we included is socio-religious pressure, a pressure of religious compulsion like fasting in Ramzan or in Navratri or some sort of another religious things. They can give rise to distress. Besides that, sexual health issues, like they are not able to say it publicly as compared to the Western population. They hide it, and in that way they develop a distress, both male and female. Financial stress is there, of course. They are not able to possess the exact amount of drugs which we write. And health literacy and myths regarding alternative medicine and a solid cure. This is the final distress which is causing these days. They are taking Ayurvedas, they are taking any sort of pathy, and they are very much confident that this will cure their diabetes. And if it fails to cure diabetes, they develop a distress. So these 4 things we have added in our modified diabetes distress scale, which is in under process, and we will take it to the higher level to get it validated. So key additions in diabetes DDS 20 has all these things, and the results which we have initially of 4 centers, 55% of the participants had no distress. Again, I would like to say that no distress means that the patient is not strong. That means the patient is not compliant either. He is not worried about his DKD. He is not worried about development of heart failure. He is not taking drugs. So that's why he is not distressed. It will be a distress for us in future, but they are not distressed at present. 36% reported moderate distress, 9% experienced high distress, and moderate and high distress were statistically significant. So this was our initial study in 500 adult diabetic patients with mean age of 45 plus minus 13.3 years, and both gender were equally distributed, and mean duration of diabetes was 3.2 years with mean HbA1c 9.2 plus minus 2.1%. And sampling method was non-probability convenience sampling. Now, what are the therapeutic strategies to combat both depression and distress? We have CBT, cognitive behavioral therapy, in which we have to involve a psychotherapist in our clinic, very much as we are engaging a dietitian. Behavioral action, activation, motivational interview, and combined antidepressant, lifestyle changes and all, beside physical activity, sleep hygiene, dietary pattern, and mindfulness. So personalized management can be done with drugs, with counselings, with pain management, and integrated care is required. Thank you for the patience listening. I finish my slides. Thank you.
Thank you, Dr. Khan. So you are getting late, so I conclude the session.
Thank you, sir.
I thank the chairpersons and the speaker and request them to move to the side stage for felicitation. I know it is lunchtime and the ghrelin inside our body is increasing, so I request you all to join us for lunch, and we will be taking only a short 20-minute break because of the paucity of time. We are running behind time with our sessions. So I request you all to reassemble within 20 minutes to begin the post-lunch session. Thank you. To moderate the first post-lunch session, I would request Dr. Manoj Kumar Chaudhary from IJMS to moderate the session. So kindly come to the stage. I would like to invite the chairpersons, Dr. Rahul Kumar Sinha, Dr. Farid Alam Ansari, Dr. Amit Kumar, and Dr. Arshad Hussain from Madhubani. Sir, Dr. Pradeep Kumar.
Once again, a warm welcome to everyone for the post-lunch session. And a speaker of the next session is Dr. Pradeep Kumar. And the topic of discussion is diabetes, remission, definition, durability, and controversies. Sir.
Thank you, Chairperson. Thank you, moderator. As you can see, the topic is about the remission of diabetes. This is not a new agenda in management of diabetes, but recently there has been a lot of impetus on it. Because initially what we were trying to do is control the blood sugar. Later what we were trying to do in last 2-3 decades is protecting the organs. But now, can we get rid of everything? And that is what is the dream, and we'll talk a little bit about the dream. So, type 2 diabetes, can we say that it is a reversible condition? And the majority will accept that we can reverse the pathophysiology that is happening since the early age. Eventually we may reach a stage, not everything, but 80% of derangements are reversible. So it was considered as a permanent lifelong disease. Now we can say that it is at least partly reversible condition. How is it reversible? Because we will try to reduce the fat, especially the ectopic fats in the body, which are mainly responsible for the metabolic derangement. The studies that we will discuss in a short while will confirm that ectopic fat in the liver, ectopic fat in the pancreas does cause the metabolic derangements, and they are to some extent reversible. We don't have the enough data to quantify it, but eventually over the coming years and decades we will have the data to quantify it, how reversible it is. The weight management is the cornerstone in the normalization of glycemia. But the question remains, is it just the normalization of glycemia or normalization of everything else that is part of the diabetes? The first thing first, what should we call it? Should we call it a remission of diabetes? Should we call it a resolution of diabetes? Should we call the reversal of diabetes? Or simply remission of hyperglycemia? Because diabetes is not just hyperglycemia. So, what eventually we are trying to get in the studies that we will discuss is the remission of hyperglycemia so far. We do not have enough data to predict, to suggest remission of hyperglycemia protects how much the organ. So the current definition as by the ADA and Diabetes UK is the HbA1c of less than 6.5 for 3 months after stopping the glucose lowering treatment. So one thing to mind here that there is no consideration for glucose per se, fasting or postprandial. So there is a lot of problems with the definition. As we see, it is very glucocentric approach. We are talking about glucose, nothing else. It does not incorporate the longer complications of diabetes. If we have managed to get the glucose in the normal range, are we going to get the lowering risks of cardiovascular risk of the diabetes, or will they progress as they were expected to do in the people with diabetes in control on the medicine? The long-term maintenance of the weight loss will be the key of the macrovascular and macrovascular outcomes, and that will be a real challenge, especially on the means that we have, except the surgical treatment. So the red alerts are, first, it is very glucocentric, but the next is equally important, which is the false sense of security. You may declare the patient that now your diabetes is in remission. What message he takes home or she takes home may be that I am now free of disease. And that can give a false sense of security, and that will have its own adverse effect. The bariatric surgery, as we all know, is the greatest tool we have to get a good weight loss, and that is only therapy that is proven to give a long-term remission of hyperglycemia or long-term remission of diabetes. So we have this tool, but how easily is it available, and does it suit to everybody? Obviously, the answer is no. So it is not an option for everybody with type 2 diabetes. But the silver lining is that it gives hope to the people with diabetes that it is a reversible condition. Let us see if I fit into that category or not. Why do we want to pursue this dream? Why do we want to pursue this aim for the treatment of diabetes? And the answer is that we are not treating only glycemia. While doing so, while reducing the glycemia without medicine, we are motivating the person to a lot of lifestyle changes, exercise, diet control, and eventually it will not only control the diabetes, the hyperglycemia, it will control the other associated risk factors, blood pressure, the lipids, and the eventually cardiovascular outcomes. So this is something which will be beneficial in many fronts. Coming to the term, as we know, the dream that actually started in 1992 with the first study in this line, but ADA took the step to have a terminology meeting and the international meeting in 2009. There was a consensus statement that came for the first time in 2009, and we'll see that in the next slide. It was quite difficult to follow, especially for the people who were doing that for insurance and for registry. So we needed to simplify it, and so in 2021 there was more simplified version published, and that is mostly followed nowadays. There are updates coming, and we'll briefly discuss the one update from 2024. So this was the original terminology that ADA came in 2009. And it had three categories: partial remission, complete remission, and prolonged remission. So the partial remission in nutshell is person is not having the criteria of diabetes, though it will fall in the criteria of pre-diabetes. So it is below the cutoff for the diagnosis of diabetes. At least for 1 year, without any treatment, without any pharmaco treatment. Lifestyle treatment is something which will be ongoing. Complete remission. Now here it will not be in the category of pre-diabetes, it will be normal range. So for normal glycemic measures, the rest is same for at least 1 year after stopping the pharmacotherapy, and the diet and exercise lifestyle measures will be ongoing. Lastly, the prolonged remission, which is the complete remission, so not in pre-diabetes range, in the normal range, at least for 5 years. So these were three categories, but they were not easy to follow for the studies also. So multiple studies were conducted. This is the compilation of about 178 studies that have been done since, and they all have followed different criteria of HbA1c, of the blood sugar cutoff, and the duration as well. Interestingly, more than 60% did not have the duration criteria for the remission studies. So, jumping to 2021, because the criteria was not simple and the different studies were conducted on a variable criteria, so a simple criteria was designed by ADA, and that was HbA1c of less than 6.5 at least 3 months after stopping the pharmacotherapy. A very simple criteria. So it looks very incomplete. How do we apply it in practical consideration? So the person should be at least 3 months free of medicines, no medicine for diabetes. The HbA1c was chosen as a single criteria because the reproducibility is easy for HbA1c. If we give the blood sugar control, the person may be doing too many times. Sometimes it is below the criteria, sometimes it will be above the criteria, and that will confuse the picture. Optionally, we can say the fasting less than 126 can be added as an optional criteria. There are some alternative discussion. We'll try to skip. Only thing to know about is that these three studies were done. So the direct study had this criteria, which is HbA1c of less than 6.5 for over 3 months without any pharmacotherapy. The look ahead study, it was based on the criteria, which is the fasting less than 100 and HbA1c less than 5.7. So that is the complete remission over a year. So that fits into the complete remission from the 2009 criteria. And lastly, the surgical cover, we will not go into detail of that. That is more than 5 years. The controversy will remain, which is purely glucocentric focus, in focus. It has grouping of too many treatment options, surgery, lifestyle, medicine, everything. And it suggests the lowering of HbA1c criteria, but many will suggest no, the 24-hour glucose monitoring will be important. So we need to go beyond HbA1c, and we may need to do the oral glucose tolerance test. What is happening when we talk about the remission? When we talk about the remission, the first thing is we are going to get rid of the fat. The fat, you know, is mainly in the three places, which is the peripheral fat, central fat. Central is omental, and the intra-organ fat. So the intra-organ fat, especially the liver and pancreas, are mainly responsible. So what we are trying to get rid of is this intra-organ fat. But overall, the weight loss is the cornerstone in achieving that. Well, how does it help? It helps in the not only the weight loss, but the insulin sensitivity is restored, the beta cell function is restored. If we give the initial insulin, very old concept, that if we give the initial insulin, the glucotoxicity is less, and the redifferentiation of beta cell will help to regenerate the beta cell function. So this is the direct trial, and what direct trial was, the diabetes remission clinical trial, where the person was given the total diet replacement, where about 800 to 850 calories were given per day in a very, very calculated manner, and the outcome was reviewed. This was done by the primary care in UK, and the person who was selected for the study must have diabetes for less than 6 years of duration. So relatively short duration diabetes. The outcome was about 46% people did achieve the remission at the end of the 1 year. But sustained weight loss was the key, which was not easy to maintain. What happens after 1 year? So if we look at the 5 years, the weight loss, mean weight loss was 7.6 kg at the end of the 2 years, and the people who actually had the remission, only 13% remained in the remission at the end of the 5 years. So people who had the subsequent weight gain went back into the relapse. So remission was not long lasting. It's a typical shortage of time. So next is the data from the Norwood audit. Here the 8-year UK primary care audit was done. The 51% achieved the normoglycemia by losing 10 kg of weight loss, and in average the mean HbA1c dropped from 7.9 to 6.4. What are the predictors? Obviously, the shorter the duration of diabetes, it is better. Additionally, if the baseline HbA1c is less, it is likely to have more remission. What can be the strategy? The strategy can be either we can give the intensive insulin therapy at the very beginning, that will help to redifferentiate the beta cell. We can go for the surgery, which is the strongest, and the lifestyle, low calorie diet. The surgery is strong because it increases the incretin function, it increases the beta cell mass, it increases the glucose dependent insulin secretion, and all the ways ultimately will have the type 2 diabetes if you can successfully complete that path. One line about the insulin. So this study had data to show that patients who received the intensive insulin therapy at the very beginning of the treatment, they achieved the glycemic control, and not only glycemic control, they achieved the remission better than the oral agent. So insulin at the initial stage of type 2 diabetes diagnosis has a very key role to play. Now the thing is complicated because the newer agents, so the SGLT2 inhibitors and the GLP-1s, so people who received not only the calorie restriction but also had the dapagliflozin given additionally, they had 44% remission compared with the people who only had the calorie restriction. So that is the dapagliflozin is any additional tool we have to hand if we are really aiming to achieve the remission of diabetes. The weight loss again is the, as we say, there are multiple ways to get the weight loss. I will take one moment. So next is the GLP-1, again very strong agent to get the weight loss, get the ectopic fat drained from the places. And additionally, if we can give GLP-1 and the insulin for the short term, the chances of the remission is quite high. Bariatric surgery will remain the benchmark for these studies because 60 to 80% remission has been observed. Not only the remission, there was 83% in the largest study. Not only the remission of diabetes, but the complication resolution is much. So the macrovascular events are reduced, but as we discussed, it is limited to very limited number of people who can actually have it. So just skip the surgery. So these are the conventional and the surgical group. If you see on the right side, very few patients were actually able to receive to achieve the remission, 13%. On the left, the surgical group, 73% achieved the remission. So the controversy, the first controversy that I wanted to show is the dilemma about withdrawing the agents like GLP-1 and SGLT2 inhibitor. So somebody has achieved euglycemia, is able to keep maintain the euglycemia. Should we stop SGLT2 inhibitor? Should we stop GLP-1? It's difficult to answer because we know the organ protection will still need these agents. So that will remain the dilemma, and we have no answer to that. The jury is out. Next is the relapse risk that will always be there. The implementation in our day-to-day clinical practice, which way should we go? Should we go the direct method, which is the calorie restriction, or should we do all the clinical management and try to achieve that? So to conclude my presentation, first thing to remember that remission is achievable, but it is not the cure. Especially if somebody's diabetes is not very long duration. Weight loss is the main target to achieve that, and weight loss maintenance is the key to maintain the euglycemia. If we fail to achieve that, are we going to lose everything? No. Even if we do not achieve the diabetes remission, we have achieved a lot of metabolic corrections anyway in attempt to achieve the diabetes remission. So it is attempt worth taking. Thank you.
Thank you, sir, for a nice talk. Now house is open for question answer session. Is there any questions? Okay.
So the next speaker, I invite Dr. Rajan. Yes.
We have a scientific session going on, and I request those taking lunch to kindly be seated on the seats and maintain silence. Thank you.
This is the topic is type 5 diabetes mellitus, the impact of malnutrition. Yeah, and he's a Professor Dr. Rajan Kumar, MD DNB, Patna Medical College, Patna. So I invite him for the lecture. Thank you.
There in the horizon for last 70 years, but not being diagnosed, branded. Because this year January, it has been labeled as the type 5 diabetes mellitus by the IDF. So suppose a patient of 30 to 40 years with very high sugar levels and he's also dehydrated, but there is no ketoacidosis. That is the key thing. And he has got the lean body mass, less than 19 or 18.5 kilo, and he is malnourished. And from low or middle income group countries, and we are having this early diabetic complications such as neuropathy or visual loss. So we should actually to show that think about the newer type of diabetes, that is the type 5 diabetes in a time. Are we dealing with the type 1? No, because it didn't have any ketoacidosis. Type 2, he is not obese, and there is no insulin resistant. So we are dealing with a new type of the diabetes with severe insulin deficiency diabetes. So how to diagnose it and when to consider it? With the history of low birth weight, less than 1.5 per kg, and David Baker's hypothesis, the malnutrition in the fetus leading to the development of some of the adult disease, diabetes, hypertension, coronary artery. David Baker has given this hypothesis. And there is no ketoacidosis, that is the key thing. Absent of DAD antibodies, so it is not an autoimmunity. There is little visceral fat or no fat deposition in the liver when detected with the MRI. Unlike the type 2 diabetes mellitus. Imaging of the pancreas, so nothing in the there. Neither it is shrunken, no non-dilatation, no calcification or anything else. If there is no, also there is no history of alcohol intake or calcification. So pancreas is almost normal, but it is functioning less. Structurally normal, no ketoacidosis, no antibodies, no insulin resistance. So this is type 5 diabetes mellitus. So what is type 5? Chronic undernutrition, leading to the pancreas development during fetal and after fetal life in early childhood and adolescence. The pancreas has not developed and beta cell is not functioning well. They will lead to the less secretion from the insulin. But they are being secreted. Formalin is not related as a malnutrition related diabetes mellitus or type J because of the Jamaican. In the Jamaica it has been worked up. Key recognition officially classified as type I, International Diabetes Federation in January 2025. It affects 20 to 25 million people mainly in the Southeast Asia and the Sub-Saharan Africa. Key characteristic, autoimmune, non-insulin resistant, and diabetes is resulting from the beta cell failure due to poor pancreatic development during the fetal or post-fetal period.
If any questions from the audience, you are welcome to ask. Fine, I think no questions. Okay, one.
This is the summary.
Sir, how will we differentiate type 5 diabetes from type 1 diabetes idiopathic?
You go for the C-peptide, number 1 it will be low, then go for the antibodies. They will be present in the type 1, not in the type 5. And
that should be enough.
in the type 5 diabetes, insulin will be there, C-peptide. They are, type 1 is prone to the ketoacidosis, but it is not prone to the severely hyperglycemic and the dehydrated. Because baseline insulin is there that prevent the resistance to the development of ketoacidosis.
Thank you, sir.
Thank you, sir.
With your past long experience of medical teaching, sir, how frequent or how often or how non-often do you get these type of type 5 diabetes in Bihar?
You are
No, we often get FCPDs in Bihar. FCPDs are reported from Muzaffarpur, from Katihar, from Kishanganj. Type 5 is a new nomenclature. MRDM was the previous nomenclature. So have we seen any case report from Bihar reporting MRDMs? Santosh sir, please, you taught us MRDM.
Amit, I don't think there is any paper from this area. In our RSSDI 2 to 3 years ago, I had requested all our friends to just communicate what's the percentage of FCPD patients they had. And it turned out to be around 2% of FCPD. It was not MRDM as such. And in my talk, I clearly showed you the initial term of MRDM incorporated both PDDM and FCPD. PDDM was later coined by the WHO as MMDM. Okay, so that's an entity, and this type 1, that's 5 diabetes is akin to the PDDM type of diabetes. It should not include FCPD. FCPD, we have that nomenclature. So this, I am pinpointing this because if you had looked into my slide and Rajan's slide, they have used the term MRDM. This is like MRDM, but truly it should be MMDM. This is typical PDDM patients. Now, the criteria which was laid down for the diagnosis initially for PDDM, it was primarily age less than 30 years, with BMI in the lean category, less than 18.5, evidence or history of malnutrition, moderate hyperglycemia, and insulin resistance, which was more than 60 units per day or more than 1.5 unit per kg. So this was the clinical classification, and in that they had shown that you should not have pancreatic calcification. So that was PDDM separate from FCPD. So we don't have any paper, but if you were talking about patient in clinical practice, definitely we do see those patients. And sometimes the clinical diagnosis in mind comes as PDDM. In today's practice, we don't write it because from the ADA classification, it is not mentioned about anything by PDDM. But typically, we do see patients falling under that clinical category of PDDM in clinical, but not that common. And I would, if you say numbers, I would say it is not more than 5%. It's 5% of the type 2 patients we are seeing. So like that. It's more common than FCPD, definitely, in our clinical practice.
We should report these patients from Bihar.
We should make it a registry. I don't think it's a big deal.
Thank you, sir. Thank you, sir, Rajan sir, and Santosh sir for enlightening us on this new entity. Now I would like to invite my next speaker, Dr. Ajay sir, for his talk on managing DKD, SGLT2, phenomenon and beyond.
Respected chairperson, seniors and dear friends and colleagues, very good evening to all of you. And I am very thankful to RSSDI BIHAR chapter team and organizer for giving me the opportunity for being here as a speaker and chairperson. Today's topic allotted to me is management of DKD with SGLT2, Fileron and beyond. So, diabetic kidney disease is a prevalent and complex disease among patients with diabetes, requiring comprehensive treatment strategy. Traditional management strategy targeting blood pressure, blood sugar, lipid and lifestyle are foundational approaches of DKD treatment. each of them still holding importance in current paradigm. The four pillar renin angiotensin system inhibitor, sodium glucose transporter 2 inhibitor, glucagon-like peptide 1 receptor antagonist, and non-steroidal mineralocorticoid receptor antagonist (MRA) can enhance PKD treatment. Expanding beyond this pillar with feature-oriented pillars including precision medicine, digital health, gut health, anti-inflammatory and fibrotic agent, psychosocial behavioral health, and regenerative medicine can further advance DKD treatment strategy, offering a more cohesive framework which shifts a disease-centered approach to a patient-centered approach. Expanding beyond this structure by additionally integrating rapidly advancing data science, bioengineering techniques, and holistic lifestyle modification may offer a more personalized and robust defense against the progression of DKD and its complications. The objective of this article is to explore current treatment paradigm and investigate the feature-oriented innovation to establish a comprehensive DKD treatment. With this background, prevalence of diabetic kidney disease in India, the START India project, which assesses the prevalence of CKD among diabetic patients, has estimated that more than 40% of type 2 patients have CKD. Leading cause of CKD and ESRD worldwide, associated with increased cardiovascular morbidity and mortality. Major public health and economic burden, especially in India. Pathophysiology and factors that contribute to the development and progression of DKD. If hyperglycemia remains untreated, it leads to hypertension, dyslipidemia, genetic mutation. Contributing factors are hyperglycemia, hypertension, dyslipidemia, genetic mutation, inflammation, and so on. And it ultimately leads to kidney function loss. So what are the consequences of DKD if not treated? If it's not treated, then may be cerebrovascular disease, coronary heart disease, diabetic cardiomyopathy, PVD, foot disease, bladder dysfunction, neuropathy, ED, eye disease, periodontal disease, depression and anxiety, and cognitive impairment. Which medications are used to delay DKD development and progression? Inflammation, hemodynamic dysregulation, and hyperglycemia all are drivers of DKD progression. And SGLT2 inhibitors and GLP-1 are take care of hyperglycemia, and the non-steroidal MRA take care of inflammation. AC inhibitors, SGLT2 are hemodynamic dysregulation. Current treatment strategy and potential target for DKD are SGLT2 inhibitors, ACE, ARB, GLP-1 receptor agonist, anti-inflammatory, anti-fibrosis, DPP-4 inhibitors, MRA, that is Suzeron, and stem cell therapy. How to treat a holistic approach for improving outcomes in patients with DKD? The first is the lifestyle management is the main skill. That includes healthy diet, physical activity, stop use of tobacco products, and weight management. First line drug therapy for both patients are SGLT2 and targeted therapy for complications, manage hyperglycemia for the type 2 diabetes guidelines plus use of GLP-1 are where indicated. Which glucose lowering agents should be selected in patients with DKD? Amongst metformin, SGLT2, GLP-1, DPP-4, insulin, sulfonylurea, thyroid, and alpha-glucosidase inhibitors, among all only SGLT2 inhibitor and GLP-1 receptor take care of delay the progression of CKD, and all others are not involved in delaying the progression of CKD. DKD management in type 2 diabetes. like healthy diet, smoking cessation, and weight management, pharmacological treatment, SGLT2 inhibitor, GLA1 RNA, non-steroidal MRA, monitoring and follow-up for UACR and EGFR every 3 to 12 months. Potassium monitoring is very important, and blood pressure, glycemic control, lipid management, and regular risk factor reassessment every 3 to 6 months. DAPA CKD trial, EMPA trial, EGFR dip with SGLT2 inhibitors. SGLT2 inhibitors are likely to cause an acute transient decline in EGFR within 2 to 4 weeks after initiation. Therapy should not stop SGLT2 due to dip. Once an SGLT2 is initiated, it is reasonable to continue an SGLT2 even if the EGFR falls below 20 ml per minute per 1.73 milliliter, unless it is not tolerated or kidney replacement therapy is initiated. Indication and practical use of SGLT2. Type 2 with CKD, with or without diabetes, DAPA CKD and EMPA kidney trial used in addition to ACEI and ARB. Common side effects are genital mycotic infection and volume depletion. SGLT2 inhibitors reduces the risk of kidney disease progression, acute kidney injury in patients with chronic kidney disease irrespective of diabetes status. Fineron in DKD, non-steroidal mineralocorticoid receptor antagonist, more selective than spironolactone and eplerenone, targets inflammation and fibrosis in DKD. MR overactivation, key driver of renal damage. Mechanism of action of Fineron, blocks mineralocorticoid receptor overactivation, reduce inflammation, oxidative stress, renal and cardiac fibrosis, and minimal anti-androgenic effects. Fidlo DKD phase 3 double-blind multi-center randomized control trial. In patients with CKD, type 2 diabetes, treatment with Fineron resulted in lower risk of CKD progression and cardiovascular event than placebo. If we compare with placebo, it is 7.8% and 30% with placebo. Effects of Fineron on CKD outcomes in type 2 diabetes. Figaro DKD phase 3 double-blind randomized control trial. Among patients with type 2 diabetes and DKD, Fineron improved cardiovascular outcome compared with placebo, low rate of hyperkalemia-related discontinuation. Safety and monitoring of Fineron. Main risk is hyperkalemia less than steroidal MRS. Monitor serum potassium, EGFR, avoid in severe hyperkalemia or advanced CKD. Combination therapy, a friendly duo SGLT2 inhibitors and Fineron. Potential benefit of SGLT2 plus Fineron duo in DKD. SGLT2 inhibitors and Fineron have complementary action targeting glomerular hyperfiltration, SGLT2 inhibitors, and inflammation and fibrosis taken care by Fineron. Combination therapy achieves greater and sustained albuminuria reduction compared with either agent alone. Secondary and pool analysis suggests additive cardiorenal benefits without loss of efficacy when used together. SGLT2 inhibitors may reduce Fineron-associated hyperkalemia, improving safety and treatment persistence. Both drugs show an early reversible EGFR dip
followed by long-term slowing of kidney function decline. Guideline endorse SGLT2 inhibitor as first-line therapy with Finron considered for residual risk in DKD, pending confirmation from ongoing trials. Proposed mechanism of SGLT2 and Finron in improving renal outcomes in DKD. SGLT2 inhibitors reduce renal glucotoxicity, glomerular hyperfiltration, renal hypoxia, podocyte loss, lipotoxicity, tubuloglomerular feedback activation, and Finron reduce inflammation and fibrosis, and both increase the sodium excretion and decreases albuminuria and intraglomerular pressure. Beyond SGLT2 inhibitors and Finron, GLP-1RA in DKD. GLP-1RA, glucagon-like peptides, 1 receptor agonist, are a class of injectable or oral medication that mimic the natural hormone GLP-1, helping to regulate blood sugar, reduce appetite, promote fullness, and slow digestion, making them effective for managing type 2 diabetes and obesity, with added benefits for heart health, kidney disease, and potentially neurodegenerative condition. GLP-1RA renoprotective effect. It reduces GLP-1RA reduces renal fibrosis and glomerulosclerosis, and ultimately it gives renoprotection. And GLP-1RA direct effect, indirect effect, both ultimately give the renoprotection. In these all 4 trials, semaglutide significantly reduces kidney failure, cardiovascular events, and death in patients with type 2 diabetes and chronic kidney disease. Relative impact of SGLT2 and GLP-1RA. If you compare with SGLT2 and GLP-1RA, weight loss, metabolic control in type 2 diabetes, blood pressure control are better with GLP-1, and CVD risk, MAS, heart failure, CKD progression risk goes in favor of SGLT2 inhibitor. So clinical indication of SGLT2 is type 2 diabetes, CKD, and heart failure, and for GLP-1RA is overweight, obesity, and type 2 diabetes. Emerging therapy, early clinical trials and ongoing studies demonstrate promising signal of renal function stabilization with stem cell therapy, supporting their potential as future disease-modifying treatment in DKD. So summary, diabetic kidney disease affects 40 to 50% of patients with type 2 diabetes in India, is frequently underdiagnosed and markedly increased cardiovascular and microvascular risk. DKD progression is driven by hyperglycemia, intraglomerular hypertension, inflammation, and fibrosis, underscoring the need for early detection using eGFR and albuminuria. Management requires a holistic approach combining lifestyle modification, blood pressure and lipid control, glycemic management, and organ protective therapy. SGLT2 inhibitors are foundational therapy slowing CKD progression and reducing kidney and cardiovascular events across CKD stage, despite an initial reversible eGFR dip. Finron targets inflammation and fibrosis, significantly improving renal and cardiovascular outcomes with a low risk of hyperkalemia-related discontinuation. Combining SGLT2 inhibitors with Finron provides complementary mechanism, greater albuminuria reduction, and additive cardiorenal protection. So combination of SGLT2 and Finron give better result in DKD management. GLP-1 receptor antagonist, especially semaglutide, further reduce kidney failure, cardiovascular events, and mortality in patients with DKD. Thank you.
Okay. Question?
Dr. Ajay, with lot of benefits of Finron, so would you like to start from day one, or at what stage will you suggest to start Finron? So with addressing inflammation and fibrosis.
There
So
is only
even a guideline to start from day one.
If to avoid the fibrosis and hyperkalemia, then we can go for Fineron. Otherwise, SGLT2 is the drug of choice in.
No, in addition to SGLT inhibitors, can you have this molecule, this
At
guidelines
this
suggesting this?
At this stage, we can't say.
Sir, an elderly lady presents to us. She is very frail. Her urine is absolutely normal. The ultrasound of kidneys are also normal. Then when we calculate the EGFR, it is less than 60. Say it is 55. And 3 months later also, when we measure the EGFR, it is same. Will we label this lady as DKD and start nephroprotection strategy or not? No protein. No protein. Sorry? Yes. Potassium is okay.
Ajay sir, please brief comments in view of lack of time. Next session is about to start. In view of lack of time,
At this
please.
juncture, we can not give the renal protection treatment.
Right. Thank you.
Thank you, sir. Thank you very much.
Thank you, sir. Now we will close this session, and I request the speakers and the chairpersons to move to the side stage for felicitation. Moving ahead to the next session, I would like to invite the chairpersons, Dr. B.K. Singh sir, who is zonal member of East Zone National RSSDI, and Dr. Hemshankar Sharma sir from Bhagalpur. Over to the chairpersons.
Hello. A very good afternoon. I have the proud privilege to introduce my mentor, my senior, my guardian, Dr. Ajay Kumar, over here. I'm not going to say anything about him because he is internationally acclaimed. I don't want to waste any time. This time of introduction will be added to his talk. Thank you so much.
Honorable Chairpersons, Dr. Hemshankar Sharma, Dr. B.K. Singh, ladies and gentlemen, at the outset let me say that since morning we have been watching this program, and I would like to congratulate the President, the scientific team and the entire organizing committee for putting up this wonderful show of the quality, not the quantity of the scientific program. Thank you so much. When we talk about diabetes, immediately the picture comes of long-term microvascular and macrovascular complications. But for a clinician, it's extremely important to appreciate that what exactly drives these complications. And for that, you don't have to look at hyperglycemia and the other risk factors in silos. You have to combine them together, whether we are talking of inflammation, obesity, hypertension, adiposity, insulin resistance, and of course, beta cell deficiency. If we do that, then only we will be able to answer the twin epidemic of diabesity, what we call diabetes and obesity. Unfortunately, India is the second largest numbers in terms of people with diabetes, close to 101 million, and another 136 million pre-diabetics. Somebody can just argue that even if my blood sugar is high, how does it matter? I am feeling perfectly well. If you remain uncontrolled for 1 year, you have 67% increased chance of myocardial infarction, 64% increased chance of heart failure, and 51% increased risk of stroke. That's why it is extremely important not only to achieve good glycemic control, but as you would look on this slide, you must achieve good glycemic control right in the earliest stage of the natural history of type 2 diabetes, because then only you will create a good metabolic memory, what we call the legacy effect. And this legacy effect will not only show you
immediate reduction in micro and macrovascular complication, but also even 5-10 years after your diagnosis, for some reason you lose the control, yet you will continue to reap the benefit of reduced risk of long-term complications because of this good metabolic memory. But it's not only the desirables, it's also important to know the tools which will make you achieve these desirables. And Ralph DiFronzo came out with this wonderful pathogenetic chart, what we call the ominous octet of type 2 diabetes. And the GLP-1 receptor agonists are uniquely placed in this situation to actually address 7 out of 8 pathogenetic mechanisms of type 2 diabetes, except for the renal reabsorption of glucose, which of course is targeted only by the SGLT2 inhibitors. So GLP-1 receptor agonists are the unique molecule to address most of the pathophysiological mechanisms of type 2 diabetes, and therefore it is no wonder that all the recommending bodies across the world, if you look at the ADA recommendations, the latest recommendation, it doesn't matter which part of the spectrum you are talking about. You are talking about cardiorenal protection, GLP-1 receptor is the first choice. You are talking about weight management, it's the first choice. You are talking about the highest efficacy in terms of glycemia control, again it's the first choice. So at every spectrum of the type 2 diabetes, it is the first choice in the management of type 2 diabetes. Semaglutide is one of the prototypes of GLP-1 receptor agonist, and this afternoon I am going to focus on the qualities of semaglutide in my presentation. It is a molecule which gives you very robust reduction in the HbA1c and very robust reduction in the body weight. And all of us know that for last 2 years, now we have semaglutide available in India in 3 different forms. One is the oral form, which is called Rybelsus. The other was the Wegovy, which was launched to treat obesity without diabetes, starting from 0.25 milligram to 2.4 milligram. And now very shortly we are going to have Ozempic, which was a blockbuster drug across the world for last 3 years, which is primarily to treat type 2 diabetes, but gives you the additional benefit of very robust weight reduction. What is the quantum of efficacy that we are talking about? We are talking about a weight loss up to 21%, a glycemic control up to 2.8%, and more importantly, number of different trials dedicated in different clinical scenario. Say for example, if you look at the cardiovascular outcome trial, the SOUL gives you clear-cut reduction in the primary 3-point MACE. If you look at the MACE outcome, 26% reduction through SUSTAIN 6 trial. Heart failure with preserved ejection fraction is a very important situation in type 2 diabetes because it gives you a very early window to prevent cardiovascular disease. And the data from the STEF, heart failure with preserved ejection fraction trial, that shows you 69%. That is a whooping number. 69% reduction in heart failure events of cardiovascular death. If you look at the STRIDE trial, that gives you 13% reduction in the peripheral arterial disease risk. And then you have the liver benefits from the ESSENCE trial. And finally, the SELECT and the FLOW trial gives you reduction in the all-cause mortality. This gives you a very comprehensive idea as to how semaglutide gives you benefit in the entire spectrum of type 2 diabetes management, providing excellent glycemic control, weight loss, and all the other cardiovascular, renal, and other benefits. What is this molecule so special about? This is a human GLP-1 analog, and this has got 94% homology to the native GLP-1 molecule, and therefore almost free of many of the problems which can be there if you are not using the human GLP-1 receptor agonist data. We have data from the randomized controlled trials and real world evidences, and all of them are very robust. 7.5 million people have already been exposed to Ozempic alone, which is the semaglutide injectable form, weekly injection to treat type 2 diabetes. Approved in 75 countries, and it is the #1 prescribed GLP-1 receptor agonist across the world, and now it is approved in India. It has undergone through a very robust clinical development program. When we talk of clinical development program, we call it phase 1, phase 2, phase 3, 3A, 3B, and then the post-marketing surveillance and observational study and real-world evidences. And almost all these trials are now complete. What is important from our perspective is that more than 20,000 patients have been exposed to this molecule in these studies, and more than 1,000 patients were recruited from India. So whatever global data is available, that can be easily extrapolated on our Indian patients. It provides, as I told you earlier, 2.8% reduction in the HbA1c. That's not in all patients, of course. It is from 1% to 2.8%, which is translated into the fact that 4 out of 5 patients that you prescribe semaglutide, that will achieve the target HbA1c for your cohort of your patients. Up to 8 kilograms of weight loss, that means 2 out of 3 will reach the target of the weight for a particular patient that you are using. Cardiovascular benefit, I told you, 26% reduction with semaglutide, Ozempic particularly. This was largely driven not by the reduction of myocardial infarction, but largely driven by reduction in the incidence of a stroke, 24% reduction in the composite kidney outcome. And what is most important is that 65% patients actually had slowed rate of loss of kidney function. And it can delay the progression of kidney diseases by almost 5 years. All these data are very, very robust. So when we look at the other surrogate markers which drive the cardiovascular diseases, like free fatty acids, serum triglyceride, VLDL and LDL cholesterol, all of them are significantly reduced by the use of semaglutide, and that's very heartening. Of course, every GLP-1 receptor agonist is associated with GI side effects, but what you clearly see that the GI side effects with oral GLP-1 receptor agonists are largely mitigated by the subcutaneous form of administration, and even if they do occur, they occur in the first 4 to 8 weeks of the treatment, where you can easily explain to the patient, warn to the patient that this is a recognized side effect, this can be mitigated, and this is definitely going to disappear by the end of 4 to 8 weeks time. So this is how we deal with the GI side effects of semaglutide. And as you can see here, 0.5 milligram and 1 milligram doses, which are the weekly doses for semaglutide, is very nicely shown here that this should not be a problem in your clinical practice at all. There was when this 26% reduction came in that cardiovascular outcome trial with Ozempic, then it was shown that there was an increased risk of retinopathy. And therefore, a lot of other studies were done which were actually to demonstrate that the benefit risk profile of GLP-1 receptor use, including Ozempic, actually doesn't show a very strong correlation with increased risk of retinopathy. We also know that any molecule which will reduce the blood sugar rapidly, that will increase the risk of retinopathy anyway, which happens with insulin. And similarly, because this one leads to almost 1% and above HbA1c reduction, so it is likely that it is the reduction in the glucose level which drives the risk of increased retinopathy rather than the molecule itself, which can be incriminated for this side effect. There is a study which is dedicated to this focus trial, which will provide more data on this particular subject. There was this newspaper article which took the entire world by storm, which is called NION, non-arthritic ischemic optic neuropathy, and there was this increased risk of this particular entity, but in fact they had the common risk factors, and the pooled analysis actually showed 8 events per 100,000 patients exposed to semaglutide versus 7 patients exposed to placebo. So I don't think this actually makes a cause and effect relationship between semaglutide and non-NION. And once again, the large scale data shows absolutely no association of semaglutide with NION in this. So who are the patients who are going to benefit from Ozempic or the injectable semaglutide we are talking about? Ozempic is now approved for the first line management of type 2 diabetes, along with diet and exercise, of course, because it provides very powerful glycemic control, compelling weight loss, long-term cardiorenal protection that I talked about. But it's very important to ensure that your patient is not exposed to a lot of side effects, and therefore proper titration is extremely important. You have to be patient, you have to explain to the patient that it will take 4 to 8 weeks time to get you to the desired doses. We start with 0.25 milligram, then move up to 0.5 milligram, which gives very good glycemic control in most of the patients. But if you want further reduction in the HbA1c, then you can titrate up to 1 milligram, and then you can stay on the 1 milligram, or if necessary, you can come back to 0.5 milligram. Now, across the world, we have huge experience. Convenience of a weekly dosing. As I told you earlier, 7.5 million patients have already been exposed to Ozempic. Excellent glycemic management, weight management, cardiovascular disease reduction, chronic kidney disease reduction. All these make this molecule a very powerful tool to treat your patients with type 2 diabetes, and therefore we have to use them more frequently. I do appreciate that the cost is an important barrier in our clinical practice. We don't belong to the advanced nation having a very, very high GDP, and therefore we will not be able to provide the benefit of this drug to every patient of type 2 diabetes who actually merits to have this particular drug. But because the patent of semaglutide is expiring, so I understand that hopefully the cost of this medication is also likely to come down in very short future. Thank you very much for your attention.
Thank you very much, sir. May I request you to take your seat over here?
Just sir, welcome. Good afternoon to all of you, and you have listened the one of the best or great orator of our part of India, and particularly whole India. Now the second speaker is also very important, and if I consider it molecular and beyond molecular pathophysiology of diabetes, then no one other than Santosh Kumar Singh is the real answer. So welcome to Dr. Santosh Kumar Singh. He is happened to be my friend during PG courses, and he will speak on beyond the dual hype, semaglutide leads the way in CKM story. Dr. Santosh.
Honorable and dear chairpersons, respected seniors, dear friends, beyond the dual hype, semaglutide leads the way in CKM. I will take the cue from Dr. Ajay sir's talk. Dual hype, definitely you can guess it is the dual agonist, GLP-1 and GIP agonist. Just to mention that one of the effects of GIP is to reduce the nausea, and by that way improving the escalation of the drug, improving the adherence to therapy, and the added advantage of the benefit of GIP on the adipocytes, whereby it acts in conjunction with GLP-1. But one of the effects of GIP is increasing the glucagon, and glucagon, you know, the holy grail of weight loss is glucagon. It increases lipolysis, it increases energy expenditure, but at the same time it preserves the hepatic function, it improves the hepatic health, and I just wanted to highlight this aspect. Two things which are not talked about usually about these GLP-1 receptor agonists, and one is the improvement in the glucagon function, and this is a property of GLP-1 receptor agonist. It was elegantly shown with liraglutide, and we have studies with semaglutide improving glucagon function. So by that way it will be doing the same thing as we can achieve with elaboration of glucagon by GIP, knowing well that one of the effects of GLP-1 is to suppress glucagon release. But at the level of the liver, by increasing the sensitivity, we can have the benefit on the liver. Second aspect is thyroid hormone receptor, the function at the level of the liver. Again, these molecules have been found to improve thyroid hormone function, and we are well aware of the use of thyroid hormone receptor beta agonist in the management of NASH. So from these two things you should be clear about the utility of these molecules acting like a dual agonist, and we will be seeing how it is benefiting our patients. Obesity is a chronic relapsing progressive disease process characterized by abnormal and excessive adiposity that adversely impacts health. And from here, the same language applies to when we talk of CKLM. This is, the crux is dysfunctional fat, the link with all these structures, the kidney, the heart, the liver, and the associated metabolic conditions, acting in conjunction, producing multi-organ dysfunction, and adversely affecting cardiovascular health. So you can see the importance of fat on impacting the overall health of a patient. And again, I would like to add, the cause of death in obesity is 80% is driven from cardiovascular disease. And important again, you will be seeing that only 20% of the cardiovascular benefit of these molecules stems from weight loss. So this should be very clear to us that GLP-1 receptor agonists are working not only through the weight mechanism, it is also working through improvement in the other metabolic parameters. Okay? So this is the scenario, 1 billion people, this is obesity, and it is just double if you include overweight. Okay? And the way I remember is bill number 786, so 786 adults or 86 हो जाएगा adolescents और वहाँ पे 70 million children. So this is the way I remember this slide. But important, you see on the right hand side, greatest number of people living with obesity are in low and middle income countries where there is a double burden of malnutrition and obesity. And this should be very clear to us. Since morning we are talking about type 5 diabetes, we are talking about obesity, and this should be borne in mind that we are dealing with both types, malnutrition and the obese individuals. This is 254 million with generalized obesity, almost 28%. 351 million abdominal obesity. It was again to the tune of 35% of the patients having that, and this data was from ICMR, and this was from Puducherry. So almost 28%, 35% Puducherry, and along with it was only 10%, 20% generalized obesity and abdominal obesity in Jharkhand. So again, as I told you, we are dealing with both types of populations. Okay, one the affluent one, the other the nutritional aspect. Same applies for the prevalence of diabetes, and we had a prevalence of almost 26% and 5%. Okay, and this is there. UP with only 5%, Goa leading with 26%. So there disparity is there in India, and we are to deal with both the things. Lower down you see obesity is linked with multiple health complications, including heart disease, type 2 diabetes and certain types of cancers. And I will quote the figures. And if you take the mortality part, it is 1.5 million from diabetes, 4.5 million from respiratory disease, 9 million from cancer, and 18 million with cardiovascular disease. So this is the present day mortality data of around 46 million. 1.5, 4.5, 9, 18. So this is the diabetes, respiratory, cancer and cardiovascular. So the importance of obesity over there. Important again, only 33% people with obesity are labeled truly as obese. They think they are overweight or काम चलता है type, but they are truly obese. And here I would like to remind you about the present day classification of obesity. It is important to measure the body fat. It is not only the BMI which matters. So it is termed as preclinical obesity if there is only increased percentage of fat irrespective of the BMI. And if you are having other metabolic conditions which are complications of obesity, then only you label as clinical obesity. So again, underlying the importance of body fat percentage. These are the conditions which are associated with obesity. और एक question आप लोगों के लिए रहेगा. You can see the benefits: 5% weight loss, 10%, 16% weight loss. And this is one of my favorites. 3 to 5% weight loss में what are the metabolic parameters which you can change? थोड़ा जल्दी जल्दी from the front benches also. Glycemia and hypertension, 3 to 5%. 5 to 10, it is the lipids and NAFLD. जल्दी जल्दी बता रहा है. 10 to 15%. Now we enter MASH. Okay, here you enter OSA, and then you have PCOS in this category. Osteoarthritis, they are all impacted when you lose more than 10%. 15% के ऊपर we had a talk on remission of diabetes, heart failure with preserved ejection fraction and cardiovascular death. So 10 से 15% में you reduce cardiovascular events, but if you are losing more than 15%, you can impact cardiovascular death. So remission, heart failure with preserved ejection fraction and cardiovascular death. So quantum of weight loss, benefit. Now with lifestyle modification we do lose weight, very minuscule, 3 to 5%, with bariatric surgery around 30%, what about in between? And this can be achieved with the use of these group of molecules. So we will be talking about this. This is known to us. What happens when you are doing only with diet and exercise? This happens also with the drugs if you are using and you have stopped it. This happens also after bariatric surgery. And there are intervention data when there were increase of around 15% post-bariatric surgery, and for 6 months of treatment, in 1/4 of the individuals, the patient were able to reduce 15% of that gained weight. And these are dedicated studies with semaglutide 1 milligram and liraglutide, reducing almost the same 15% which was gained after bariatric surgery. So and this is opined that it will be better if you use it in the initial period rather than waiting for pretty long time. Although intervention data are there from 1.5 to 10 years of time post bariatric surgery. Okay, and the hormones we are well aware. It is due to elaboration of ghrelin. It is due to leptin resistance. It is due to the reduced energy expenditure, and that happens because of reduced catecholamines, the thyroid hormone signaling, the POAMC and NGY upregulation. So these are the different hormonal changes which can happen, and they will promote weight gain after the weight loss. And hence we need to have agents which will continue with the weight loss profile without plateauing. Okay, and this we can achieve with this group of molecules. So going Ajay sir, and the mechanisms is known to us, increasing satiety, and not only that, reducing the food cravings for certain foods. This is very important aspect whereby the type of food which will lead to obesity can be reduced. The different trials with this molecule, and starting from step 1 to step 11, I would like to mention about step 6, step 7, step 11, and this is in East Asians. And the East Asian category in step 6 was mainly it was Japan and South Korea, and step 7 was in China. Step 11 was again Korea and Thailand. And the weight changes were different in these two categories. The difference was in step 6 and 7, the cutoff was again 27. But in step 11, it was taken as more than 25. And this is important because whenever we think of these molecules, we only think of the very obese individuals, but this Asian data pertains to patients with a BMI of more than 25. And interestingly, there was more percentage weight loss in the step 11 compared to step 6 and 7, although all of these patients were including patients with diabetes. And it is important to highlight over here that the benefit of weight loss is lessened in diabetic patients, and it is more in female individuals. And in step 11, it had less number of diabetics, more females, and hence this increased weight loss in step 11 possibly was because of these two factors, less diabetes and more female population. Lower down you can see a mention of preserved ejection fraction, both in non-diabetics and diabetics. We have the select cardiovascular trial and the essence trial in NASH. And here I would like to add, when you talk of treatment in NASH, we talk of two things. One is the resolution of inflammation without worsening fibrosis, and the other is improvement in fibrosis without worsening of inflammation. And this study of Essence showed 20% and 30% benefit in reduction in fibrosis, placebo versus semaglutide. And the corresponding figures for MASH resolution were 40 and 60%. So this 30-60% MASH resolution improvement in fibrosis was achieved with this molecule with a dose of 2.4 milligram. Similarly, we had improvement in kidney function as was shown by Ajay sir, and that was in a dose of 1 milligram only. And this I want to highlight because these things we keep in mind when we are prescribing these molecules, which patient population to prescribe for what benefit. So weight loss benefit, this is there, 18% on an average. Never forget, whenever you see this data, always think of the placebo, and it should be placebo subtracted benefit. So don't go only by 18%, always see what was the placebo, and then placebo subtracted is taken as the actual benefit. More than 20%, 1 in 3. Important is it was sustained weight loss over 4 years, and this is important. I was talking about plateauing effect or even increasing weight gain. Now we have the different step trials, और यहाँ पे आप लोगों को विशेष करके देखना है on the this one. 107 kg 96 kg पे आया, और यहाँ से it was two arms. One continued with semaglutide and the other was placebo group. The patient which were on semaglutide, they further reduced 9% of the body weight. There was increase in body weight in the placebo arm. So this was a trial which showed that for reaping benefit, you have to continue with the drug. So this is a very elegant thing. And on the right hand side you see lesser percentage of weight loss in 6 and 7 because there were more of diabetic patients compared to the other step trials. This should be borne in mind. Almost 90% losing 5% of the weight, 75% 10%, 50% 15 and 1/3. Previous slide में भी देखे हम लोग 20% का. And important is to know this same percentage, 1/3, 50% and 75% were not able to achieve 5%, 10% and 15% weight loss in step 2 trial. And from that came this study of step up 7.2, जहाँ पे उसको escalate करके 7.2 milligram पर ले दिया गया to achieve further weight loss. So this should be borne in mind. यही figure याद रखना है step 2 के लिए. 5%, 10%, 15%, 1/3, 50% and 75% were not able to achieve 5, 10 and 15%, which was possible with escalating the dose to 7.2 milligram. Okay? And now we have 20%, ये तो बता ही दिए थे. This is the important slide. 3.5% improvement in lean body proportion with Wegovy. Lean body mass proportion increased by 3.5%. And this is a very important slide for me. और कोई बताएगा कि is it possible to increase muscle mass with GLP-1? It's not possible. So this is the proportional muscle increase which was there. Okay, but next slide has explanation. 4.5 kg improvement in hand grip strength with Wegovy. This was in the Semaglutide study. And this is my own data also where we do see increase in the hand grip strength. And this stems from the mechanistic aspect. And when we talk of muscle strength, we talk of the cardiac output, we talk about the intramuscular fat, we talk of the capillary density. Okay, and all these factors matter in improving muscle function. And GLP-1 receptor agonists have been found to affect all these parameters, improving the cardiac function and in reducing the intramuscular fat, increasing capillary density, microvascular function. Okay, although it reduces muscle mass to 1/3, but it is improving muscle function. So this is a drug which definitely you can use in sarcopenic obesity. It should not be used in anorexic malnourished type of frailty, but it can be used in patients with sarcopenic obesity. Now beyond weight loss benefit, this is the quantum. Systolic, diastolic 10, 11 and 5 और पहले भी हम बताया, I remember as 11, 15, 5, 16. 16 was for waist circumference, 1.9% step 2 HbA1c reduction, 63% CRP reduction, 22% for triglyceride. But this is not the true picture. अगर select trial की बात हम लोग करें तो यहाँ पर HbA1c reduction was only 0.3%, systolic blood pressure was only 4 millimeter, diastolic was 1 millimeter, triglyceride was 18%, CRP was 39%, waist circumference reduction was only 8 centimeter. So just to emphasize the cardiovascular benefit which we had, it was with lesser affection of all these metabolic parameters. But this molecule, along with weight reduction, it is also impacting the other metabolic parameters, including the lipids, including the inflammatory cytokine CRP, which nowadays have been approved as a treatment from the American Heart Association, and they have laid down the treatment protocol for patients having hsCRP more than 2 milligram per liter. Now we come to the last slide, and this is it. Well tolerated drug. We do have gastrointestinal problems. Observed rates of hypoglycemia in step 2. Cholelithiasis is more common. We are apprehensive of this problem because it is linked with the dose of semaglutide. It is linked with the exposure time of semaglutide. Almost 1.5-fold increase of the gallbladder problems. Okay, but not with pancreatitis. It has been shown that there is the incidence of pancreatitis is reduced with the use of this group of molecules. We know the background population of diabetics, particularly obese diabetics, they are more prone to develop pancreatitis, but elegant data have shown that there is less percentage of pancreatitis in the long run. No increased risk of malignant neoplasms, increased risk no increased risk of diabetic retinopathy in people with obesity. To some extent it was there in diabetics, and from here I always would like to remind people, particularly who are there in ophthalmic practice, that as when we talk of labeling a patient as retinopathy, we always say that you cannot say there is no retinopathy without fluorescein angiography. We are now going for OCT, and similarly there will be much emphasis on measuring the optic disc diameter. So this is an area where these sort of patients are more prone to develop retinopathy and also NION, as was said by Ajay sir. So this non-arteritic ischemic optic neuropathy is more common in patients who are having a smaller optic disc diameter, because the chances of hypoxia and damage is much more. And definitely the cardiovascular benefit, as I said, 80% of the benefit comes from the non-weight reduction. And here again the figures to know 4% CVE reduction, cardiovascular event, was linked with almost 5 kg reduction in body weight and 5 centimeter reduction in waist circumference. So this is the cardiovascular effect which we had. In one of my slides, in my oration which I showed you, the implications of visceral adiposity more so in the third group compared to the others. But I would like to say the positioning of this molecule is across the spectrum except MARD. The present day data suggests this is more efficacious in patients with SIDD. SIRD you can easily correlate with CKD, and the MASH, definitely it's a molecule we have to use. And the MOD category with particular obesity, again the first drug which will come to mind is GLP-1 receptor agonist. So across the spectrum we are having the utility of this molecule. Thank you all for this hearing.
Sir, please take your seat over here. Before we just proceed for some questions from the house, one or two, I will just ask one thing. I am not pointing to you or to Ajay Kumar sir. There is a universal fat loss, agreed, with semaglutide. Now this fat loss also affects those young ladies who are sexually active. So there is also pubic fat loss, there is also loss of fat from labia majora. How it is going to affect the sexual problems in females, because cases have been reported with depression from USA. Right? I think Dr. Santosh sir will agree with me that in last 1 and 2 months there were a couple of papers which went like this, and this was the minus aspect. I don't understand this was the minus aspect, because much has been discussed by the previous speakers about depressions and all that. So just shortly in a minute sir, please. Thank you.
These studies have come up with the sexual dysfunction with this group of molecules. Libido was one of them. It is not only the fat. And interestingly, libido was impacted in both ways. One was, it was on the negative side, and from the weight loss part, there was improvement in libido. Secondly, these molecules, they fared better in head-to-head trial with testosterone supplementation in affecting the hormonal profile, where it was to benefit, but that was particularly in males, it was not in females. Regarding the sexual aspect in females, I don't think we have much dedicated data I should comment upon. At least I have not come. If you are aware, you can just highlight. But these things are, I would say, favorably impacted by GLP-1 receptor agonists, because these molecules, they are also acting on the consequences of obesity, including the improvement in the hormonal profile. You say, for example, the PCOS patients, you keep patients with secondary hypogonadism, they are favorably impacted by this group of molecules. And to highlight the erectile dysfunction, if you remember my slides in the morning, it is more common in patients with SIDD, it is more common in patients with SIRD. So with this use of these molecules, we will be improving that erectile dysfunction also.
So Hemshankar, you should appreciate that these entities that you are talking about, some amount of fat loss, some amount of sexual dysfunction and this and that, these are not mathematical hard endpoints. These are very abstract terms which have got multivariate factors. To incriminate one particular agent because that patient was taking that particular drug at that point of time, there is absolutely no cause and effect relationship, and therefore this should not be brought into scientific discussion at all.
Thank you very much. Over to the next person waiting in line.
Sir.
एक सीनियर आदमी
Sir.
खड़े हैं,
You mentioned that, Ajay sir, you mentioned that semaglutide addresses 7 out of 8 part of pathogenesis. But these drugs, they increase lipolysis. How can they address 7 out of 8?
So what is the problem? If increased lipolysis takes place, there will be reduction in the bad fats, so that's perfectly all right. What is the problem?
No, Defrenzo, when he
inflammation will go down because of that.
It's okay. But Defrenzo in his article of Octet clearly mentioned that increased lipolysis is a predisposing factor or a causative factor for development of type 2 diabetes.
No. You are mistaken. When we talk about ominous octet, we are talking about aberrations in the lipid metabolism, right? And lipid metabolism, lipolysis is not the only word that we are talking about. It's a very comprehensive chapter, right? So overall, when we take all the issues of the lipid management, obviously GLP-1 receptor agonist, both because of its direct mechanism and indirect mechanism of weight loss, it is going to favorably impact. In fact, that is one of the most robust effects of GLP-1 receptor agonist.
Pioglitazone, he mentioned, had positive effect on lipolysis. Pioglitazone, the mechanism of action which he promotes is pioglitazone will suppress lipolysis. And that is why he is so fond.
I don't understand what you are talking about.
Okay,
can you make any sense out of it, Santosh?
नहीं सर का ये था कि वो जो स्लाइड हम लोग ओमिनस ऑक्टेट की बात किए थे है ना, उसमें एडिपोज टिश्यू की इन्वॉल्वमेंट में लाइपोलिसिस वाला एरिया जो है वो ज़्यादा शो करने के, इट इज़ अ कंट्रीब्यूटेड टू एग्रावेशन ऑफ ग्लाइसीमिया. तो ये कह रहे हैं कि अगर लाइपोलिसिस हो रहा है तो इट इज़ नॉट अ फेवरेबल एस्पेक्ट फ्रॉम दैट एंगल. हिज क्वेश्चन इज दिस वन.
सर,
as usual, sir, Dr. Ajay Kumar is our star presenter. Always used to go beyond the limits, and any topic you give, he can talk on it. He, as per his slides, he emphasized more on body weight loss, but I was thinking about the lean body mass loss or sarcopenic obesity that Dr. Santosh has cleared it. He has cleared about the sarcopenic and lean body mass. You have not talked about muscle mass loss. And it is just like managing the patient who are on semaglutide or GLP-1 receptor. Just like after bariatric surgery, you have to manage micronutrients, hydration proper, and then your protein supplement 1 to 1.5 milligram per kg body weight. So all these aspects we have to see. I was thinking about, first of all, I was asking about the body mass loss. You talked about weight loss.
This is a very
body mass or sarcopenic obesity. You have not talked about.
Yeah,
that was my question.
This is a very important question, and we should appreciate that any tool to reduce the body weight, whether by diet or exercise or by GLP-1 receptor agonist or dual receptor agonist, it is imperative on the part of the physicians to explain to the patient that along with the fat mass loss, there will be some amount of protein lean mass loss as well. At the same time, there is some amount of bone loss as well. So all three will take place. And therefore, to say that GLP-1 receptor agonist will not lead to lean mass loss, will not lead to bone mass loss is rubbish. It will. And therefore, every patient we put on these molecules, we always suggest the patient beyond aerobic exercises to perform isometric exercises. It is isometric exercise which will take care of the small amount of lean muscle loss that takes place with these molecules. Even the treatment of sarcopenia is eventually isometric exercises. Muscle building is not only related to disease process, to treatment process, but in fact in the overall gambit of increased health. And therefore every person at any age, particularly more so after the 60 years of age, should have at least 30 to 45 minutes of dedicated isometric exercises.
In elderly individuals, we can use it after age of 65 or 70.
What is your definition of elderly?
It's my age 69, sir.
65 and above?
Only 960.
I am 72 years of age.
Yeah.
And I do isometric exercises 45 minutes every day. Come to my house, come to my gym, and I will show you.
Okay, thank you.
So yes, I do suggest even in elderly people to do isometric exercises. That will only keep you young at the age of 72. That's it.
One question from my
The
side.
organizers are really troubled. 30 seconds. 30 seconds.
Sir, there is always risk of diabetic retinopathy with sudden lowering the blood sugar level. How can you explain this?
कोई नई बात थोड़े है यार.
नहीं.
टारगेट ऑर्गन डैमेज तो पढ़ रहे हो आज से नहीं 50 साल से.
This will lead to alteration in the hemodynamics. Sudden reduction in the blood sugar will lead to aggregation within the microcapillaries, and that is likely to increase ischemic damage to the retina.
So before that, is there any nephropathy, diabetic retinopathy?
No.
Diabetic nephropathy, as we
No, that is
to
related
rule
to
out-
molecule,
Yeah.
like SGLT2, initial dip in the EGFR and then further. Same happens with Finrenon as well, but not because of the quantum of the reduction.
Okay, sir. Thank you.
For you and the audience, the easy way to understand this, when you have this, these people develop hypoxia, and there is elaboration of VEGF. And VEGF is always helpful in the early retinopathy. Mild moderate tak mein it is beneficial, and hence there is benefit of GLP-1 receptor use in reducing retinopathy. Problem is in patients with PDR. And if you go into the details of the non-use of these molecules, it is advanced retinopathy. Patients with maculopathy, because in there is this increased elaboration of VEGF will aggravate the condition, new vessels formation and aggravation. So by that way, you can easily conceive the benefit and the bad effects of this molecule. Remember the VEGF, we use anti-VEGF.
And in all the semaglutide trials, in no other trial there was increased risk of retinopathy. It was only the CV outcome trial in which there was increased risk. So we cannot generalize this association as well.
Thank you very much. And who said, sir, you are elderly? You are as young as anyone else. CB sir, आप अपनी बात को वापस लीजिए. So thank you very much for wonderful discussion, and we close the session.
CV राय सर बैठे हुए हैं. पूछो उम्र और पूछो कितने एक्टिव हैं.
I am thankful to the stalwarts of diabetes for enlightening this audience with their in-depth knowledge. I request the speakers and the chairpersons to move to the side stage for felicitation. William Osler had very famously said that to study the phenomenon of a disease without reading a book, it's like not going to the sea at all. But to read the phenomenon of a disease without seeing the patient, it is almost criminal. So we should not only read but apply the learnings in a routine patient clinical care. So to begin the next session, I would like to invite the moderator, Professor Dr. Arshad Ahmed sir from IJIMS, and I would also like to invite the chairpersons, Dr. Bheem Ram sir from IJIMS, Dr. Abhay Kumar from Emergency Medicine Department at IJIMS, Dr. Anand Dev from Medicine Department at IJIMS, and Dr. Anita Sunil from Patna. Over to the chairpersons.
Good evening. For session 9, the first speaker is Dr. Ajay Kumar Sinha. and he will talk on elderly onset diabetes, overlooked, classification, and dilemma. Dr. Ajay, sir.
A very good afternoon to you all, honorable chairpersons, national faculties, my seniors, Professor A. N. Raj sir, all the youngsters, my friends, the people from Pharmaceuticals House, and the media. Thank you very much to the organizing team of RSSDI 2025 BIHAR for giving me the topic and giving me opportunity to give oration. My talk is not shifting towards any product or kind of things. I'm totally prepared the presentation based on the clinical experience which I have got during the ward round of Nalanda Medical College Hospital and my clinic. So elderly onset diabetes is now very common, but what is the overlooked classification dilemma? So my session will revolve around the first is epidemiology and burden, why misclassification occurs, what is the clinical differentiating features if there is a subset within subset, what is the case vignettes and reasoning, what is the evidence-based management, what is the clinical takeaways. So you know that the life expectancy of Indian people when we became independent in 1947, the life expectancy was 32 years only, and the UK life expectancy was 71 years at that point of time. In 2025, the Indians have become closer to the Western people. The life expectancy at birth is 72 years, and the UK 82 years. So meaning why the number of the elderly population is reaching every year in a good way, 0.8% to 9%. The numbers is rising. India is not an exception. India experiencing rapid population aging. 1 in 4 adults more than 60 years of age is supposed to be suffering from pre-diabetes or diabetes. And diagnosis is often delayed because the patient, if they are not symptomatic at the age of 60 or 60 plus, they do not want to reach to the clinician, and thereby they miss the diagnosis of diabetes. So the problem is, the other added problem is that we thought the elderly always type 2 diabetes mellitus, which is not. This oversimplification leads to widespread misclassification and inappropriate therapy. And some of you might have experienced that you have thought that this patient is very simple. We have given the metformin and any other drugs. Initially, the sugar is controlled, but then after 3-4 months, you will find that this patient has jumped from the oral HA to the insulin. Why this? So I will come through that point. Before that, why the classification is needed? The classification, if you do the real classification, subset within subsets, we will reach towards the targeted treatment and thereby improve our outcomes and all those benefits of the good glycemic control. And if we will misclassify, we will have all the bad things which occurs after the poor glycemic controls. So why this? Why you have found that in some 70 years patient, initially he was well on the metformin on sulfonylureas or any other OHA, in only 3, 4, 5 months, he has jumped to the insulin therapy. Why this? He has become the obese to lean. Why this has happened? So these are the subsets within subsets. One is type 2 diabetes, which is a very common, but then you may have type 1 diabetes in elderly. You may have the LADA You may have the KPD, ketone process diabetes, and you may have the secondary diabetes. So this will be hidden if you will not look closely, and that will hamper your the target management of the blood sugar. So why aging changes the game? As talked by previous speakers, the aging leads to the beta cell exhaustion. The another danger, if you will it will give the drugs very aggressively, there will be more chance of hypoglycemia, and you know well that hypoglycemia is more dangerous than the hyperglycemia itself. The older people has got sarcopenia, and yes, the previous speaker have given the benefit of the exercise about the sarcopenia, but the sarcopenia is a common in the older people. And the altered drug metabolism. In older people, sometimes the drug may not act in the same way as it works in the younger people. And in elder people has surrounded by a lot of comorbidity which we have to consider. So these three things which we forget to add in during the treatment management program for the elderly people, one is the LADA. The LADA is closer to the type 1 diabetes, but it occurs after the 30 years of age, and it may, if you don't give the insulin, initially it will show control, later on it will not show control before giving insulin. So it is autoimmune, closer to type 1 diabetes, but slower onset, initially responds to oral drugs, then fails rapidly. So that's why it is called the 1.5 type 2 diabetes mellitus. 1.5 diabetes mellitus. The ketosis prone diabetes, there are some patients, of course the number is less, but we have found that the admission, ICU admission is very frequent because of the development of ketosis. The patient was well on oral hypoglycemics, but still patient has entered into the ketosis, type diabetic ketoacidosis. This is a different subset, which I will deal you up in this presentation. And the third is the pancreatic diabetes. Sometimes the pancreatic diabetes may mimic as a type 2 diabetes mellitus in elderly people, which we thought patient will not give you this history of the acute pain abdomen, still they are carrying the pancreatitis. So what is LADA in elderly? The LADA is beta cell destruction progressing slowly over years, initially responds to oral agents but rapidly fails as insulin production declines. So what are the good features, clinical features to identify this patient is having LADA? The age is more than 30 years of onset. The lean body type, and it will show also the positive GAD or in IA2 antibodies, and low or declining C-peptide. So you may have C-peptide, you may have the positive GAD. Initially it responds to the oral hypoglycemic drug, but later on it will jump into the insulin kind of therapy. So some of your elderly patient may have the LADA, and you need insulin very early to control the blood sugar. The ketosis prone diabetes, why this subset is there? Is there a genetic abnormality? We do not know exactly, but these are the patients which makes us pose a challenge to the diabetic management, ideal diabetic management patient. So this patient, to identify this patient, these patients are seen in lean or moderate build. They look like a closer to type 2 diabetic patient, but they are frequently prone to ketosis. Simple urosepsis will lead to recurrent ketosis. And the secondary diabetes, the drug-induced pancreatic disease, endocrine disorders, and so these three things which we have to remember if we are not able to control the blood sugar, which previously we have found the patient was controlled on blood sugar. Now, even after the best of the OHA, the patient is not being controlled. We have to think about the pancreatic or secondary diabetes, even in elderly. So, clinical red flags for misclassification is lean or normal BMI. Elderly patient with lean and BMI, previously he was having a good weight, unexplained weight loss, rapid insulin requirement, recurrent hyperglycemia, and sometimes recurrent ketosis. So this makes to think about that whether we are dealing with the different subset within subset. So what are the differentiating point between these three type 2 diabetes, LADA and ketosis prone? The BMI is high in type 2. Usually the type 2 diabetic patient will show the high BMI. The LADA people will be normal sometimes or sometimes lean, and ketosis variable. So this is one point which will make you to think about that whether you are entering into the different subset of the elderly people. The BMI will be high in type 2 diabetes mellitus, but it will be low, it will be normal or lean, sorry. The C-peptide will be normal in type 2 diabetes mellitus, you know well, or high. It will be low or declining in the LADA. And it will be variable in ketosis prone. So yes, the C-peptide will not give you, it will give you some clue, but may not give you the ultimate diagnosis. The GAD antibodies or IL antibodies, it will be negative in type 2 diabetes mellitus, and like type 1 diabetes, it will be positive in LADA. And in ketosis prone, it is not type 1, so it will not show any positivity towards these antibodies. And the ketosis will be rare in type 2 diabetes mellitus. LADA also rare, but it is possible in ketosis prone diabetic patients. So what we have to remember, if we are not getting success, initially we have got success, so now we are not getting success, or we are thinking that this is something we have to take it as a challenge. So we have to think for the C-peptide testing before food or after food. Autoantibodies, of course, a bit costly, but with the patient consultation and taking into the confidence, you can go for the autoantibodies. Glucose markers, fasting and HbA1c, definitely it is raised, previously it was showing the normalcy, and the ketone profile. So these all are the tests which can give you the clue that yes, we are dealing with the different kind of things. So what is the diagnostic algorithms? If we think that this elderly patient is different, identify patient based on the BMI or all those things, assess phenotype, order tests. The tests are GAD and IL antibody tests. Interpret results, low C-peptide plus positive GAD is LADA likely. Adjust therapy accordingly. It's very simple. Once you have diagnosed, the therapy is simple. Now this is a case vignette. A patient who is having age of 67 years, no major comorbidity, no steroid use, presenting symptoms weight loss 6 months, polyuria, fatigue. He was on OHA. Diagnosis, initially we thought this is a type 2 diabetes mellitus in outdoor. We have given the metformin and glimepiride. The HbA1c was initially good, but after 3-4 months, even after the best of therapy, the HbA1c is not coming up below 9.2. So despite appropriate oral therapy, glycemic control remained poor. So it showed that yes, we have to do something more. So patient was lean phenotype. The autoimmune history the patient attended was having the autoimmune thyroid disease. And the patient was not showing any response to even the best of the oral hypoglycemics. So we have gone for the testing. The fasting C-peptide was low. The GAT antibody was positive. The HbA1c was 9.2%. This results revealed that this patient is having some autoimmune and needs insulin. So what we have done, we discontinued the sulfonylureas. We have started the basal insulin, not the regular insulin. Basal insulin, continued the metformin, given the patient education which is needed in diabetic management, and regular monitoring, and that shows the good result. The HbA1c reduced to 7.1%, weight was stable, no hypoglycemia. So the management principles are very simple, not very complex. Individualized targets, suspect the things, avoid aggressive lowering, low risk agents should be given priority. You know all about the ORHA, I will not go into it further. So when to initiate insulin? When the persistently high HbA1c, when low C-peptide, evidence of autoimmunity by testing, and symptomatic hyperglycemia with symptoms. So what is the key takeaway? Not elderly diabetic is type 2 diabetes. Identify red flags, early classification drives outcomes, case-based reasoning. And this is a 5M approach in elderly. While we are dealing with elderly, we have to remember 5M. The ADS says the 4M, the Canadian says the 5M. So what are the 5Ms? The mind, we have to check whether the patient is dementic, delirium, or depressed. In diabetic, depression is very common. So once you will not diagnose the depression, you will not take care of the depression, you may not get success. So one is the mind, the second is mobility. So patient is whether having the balance is proper, the gait is proper or not, so we have to look for that. Medication, this kind of patient or elderly patient may have suffering from a lot of other things. So that requires the drugs. So there is a drug-drug interaction. So that you have multi-complexity. Elderly patient, particularly elder, more than 85 years age. The multi-morbidity. So we have to consider it. And matters most. The matters most means sometimes aggressive therapy leads to more deranged quality of life than the good quality of life. So what matters most for the patient and attendant, that is also required. Based on all those things, we have to make a proper prescription for the elderly diabetic people. That's all. Thank you very much.
Thank you, sir, for your nice talk and clearly classification for diabetic patients. Now I will request you, please come in this. Sir, please. Sir, please. Ajay, sir. Sir, please come. Thank you.
Good evening to all. Now I am inviting Dr. Rashmi Kumari from Pavapuri. Her topic is reproductive dysfunction across gender in PWD. Please, Dr. Rashmi.
Thank you, ma'am, and to your persons, and thank you to the organizers for providing me this platform. Thank you to the Saibal Guha sir for giving me this bold topic. So I'm a little bit nervous too. So my topic is the reproductive dysfunctions among gender in persons with diabetes. So, considering the reproductive dysfunction, it's a significant but often the under-recognized complication of diabetes mellitus, affecting both sexual functions and fertility in individuals with type 1 and type 2 diabetes. The prevalence is substantial, with approximately 1 in 3 people with diabetes experiencing some form of sexual problems. The pathophysiology is again the multifactorial, involving the vascular, neurological, hormonal, psychological and the metabolic disturbances, triggering primarily by the chronic hyperglycemia. So, considering the clinical spectrum in men, the erectile dysfunction, that is the most common, the reduced libido and the hypogonadism, the ejaculative problems and the infertility, and the problems in the females, that is the menstrual disturbances, polycystic ovarian syndromes or androgen axis, sexual dysfunctions and the pregnancy complication. In both the pregestational and the gestational diabetes, there is higher risk of the miscarriage, congenital malformations, preeclampsia, polyhydramnios, macrosomia, and the neonatal hypoglycemia and operative deliveries. So, what is the pathophysiology behind these dysfunctions? So, the most common, that is the endothelial dysfunction and the nitric oxide impairment. The chronic hypoglycemia that causes the progressive endothelial dysfunction, which is central to the erectile dysfunction and the reduced sexual arousal in the both sexes. The fundamental issue is the impaired nitric oxide, and that is essential for the erectile dysfunction. So nothing to explain in the detail, that causes the activation of the CGMP, which maintains the penile smooth muscle relaxation and permits the blood flow for the erections. So in diabetes, there are the multiple factors that is operating for these endothelial dysfunctions. The decreased endothelial nitric oxide synthase activity, the reduced nitric oxide productions, and impaired nitric oxide dependent smooth muscle relaxation, all this lead to the decreased dysfunctions in the erectile functions. So hyperglycemia leading to the production of advanced glycemic end products and the oxidative stress, ultimately leading to the molecular alteration and ultimately leading to the cavernous endothelial dysfunction, ultimately the erectile dysfunction. So advanced glycemic end product, that is the molecule that are the irreversible product, non-enzymatically glycation product of the glucose and the proteins, lipids and nucleic acids. These compounds accumulate significantly in the diabetic tissue, including the penile erectile tissues and reproductive organ. And this causes the decrease in the extensibility of the erectile tissue through the pathological collagen cross-linking. So that is the advanced glycemic end product significantly associated with the severe erectile dysfunctions, and that further amplify the oxidative stress and inflammation, creating the vicious cycle of endothelial damage. The oxidative stress that generate the excessive reactive oxygen species and free radical, and they exacerbate along with the AG, the mechanism is exacerbated and the functional abnormality that is increased. The autonomic neuropathy, that is the direct consequences of the hypoglycemia, induce damage to the unmyelinated nerve fibers. This autonomic nervous system normally regulates sexual functions through the complex sympathetic and parasympathetic signaling. In diabetic autonomic neuropathy, this signaling is impaired, and that results in the loss of normal neurotransmission necessary for the erectile responses, abnormal sympathetic nervous system activity that prevents the relaxation of penile smooth muscles functions, adult sensation and the reduced sexual arousal, and dysfunction of the internal sphincter muscles controlling the ejaculations. So diabetic neuropathy that we all know, the different mechanism and different type that is operating here also. The central hypothalamo-pituitary gonadal axis and insulin signaling. This is disturbed in cases of the hyperglycemia, the chronic hyperglycemia, and the insulin and leptin normally act at the hypothalamic kispeptin neurons, which stimulate the GnRH release. In diabetic, reduced or dysregulated insulin signaling decreases the kispeptin expression, reducing the GnRH, LH, FSH secretion, and leading to the hypogonadotropic hypogonadism. Inflammatory cytokines such as the TNF-alpha and the interleukin-1 beta also suppresses the GnRH release, further blunting pituitary gonadotropic output in men with type 2 diabetes. In males, this central suppression produces the low or inappropriately normal LH or FSH, which lowers the testosterone, decreasing the libido and impairing the spermatogenesis. In females, altered GnRH pulsatility disturbs the LH and FSH patterns, giving the delayed menarche, oligomenorrhea, anovulation, and sometimes the amenorrhea, especially in type 1 diabetes. The hormonal abnormality is main approximately the 25 to 30% with type 2 develop the hypogonadism, and that is because of the low testosterone and the low LH and FSH. Low testosterone reduces the libido and the sexual motivation and mood, though that is the mechanism behind the regulations. In the women, that is the directly high glucose directly impairing the GnRH release, and that causes the dysfunctional leading to the insufficient gonadotropic release. Additional mechanism is also operating along with the other complicated factors associated with this that lead to the excessive androgen production and features of the PCOS. Metabolic, oxidative and the inflammatory factors. The metabolically hyperglycemia activates the polyl pathway, depletes the NADH and the glutathione, and amplifies the reactive oxygen species. This oxidative stress is a shear mechanism for endothelial injury, nerve damage, and gonadal dysfunctions in the diabetes. So both together form the peroxynitrite, causing the DNA and protein damage in vascular and reproductive tissues. Low-grade chronic inflammation is going on, that is also contributing to the insulin resistance and the suppresses the GnRH. There is also the micronutrient disturbances, especially the altered gene transport expression in the testes and the beta cells that impairs the both insulin secretion and the testosterone synthesis, causing the further reduction in the male reproductive capacity. So what are the male reproductive dysfunction? Basically we are concerned with because of the hypoglycemia, and the most common is the erectile dysfunction that is predominantly organic, not always the psychological. The ejaculatory disorders in the form of the retrograde ejaculation or premature or anejaculation, that all because of the high glucose induced nerve damage. The reduced libido and the impotence, that is the hormonal deficiency, especially the low testosterone, and along with that, the psychological factor. Apart from this, there are the comorbidities including the hypertension, obesity, smoking, and depression that further contribute the sexual dysfunction in males. There is the sexual changes and the male fertility that is directly caused because of the damage to the testicular structures because of the hyperglycemia, and experimental and clinical studies show there is the germ cells apoptosis, vacuolations of the seminiferous epithelium, disintegration of the nuclei, and the mitochondrial abnormality in the sperms, all which reduces the sperm count, motility, and the morphology. Hyperglycemia and oxidative stress disrupt the Sertoli cells metabolism, damages the blood-testis barrier, and induce the endoplasmic reticulum stress and apoptosis in leading cells, suppressing the testosterone synthesis. So this oxidative stress and AG also damages the mitochondrial DNA in the sperm, causing the defective ATP productions and increased DNA fragmentation, which contribute to the early embryonic loss even if fertilizations occur. So clinically, almost half of the men with diabetes show the impaired semen parameters and subfertility independent of the classic erectile dysfunction. Considering the spectrum in the female reproductive dysfunctions, the most common is the menstrual irregularity and the anovulation, and that is commonly in the type 1 diabetes. And that is partially reversible, but sometimes it is the persistent also. Considering the polycystic ovary syndrome in the type 1 diabetes, despite being a state of absolute insulin deficiency, there is associated increased prevalence of PCOS, and that is because of the supraphysiological doses of subcutaneous insulin. So that is the reasons in the type 1. In type 2, both insulin resistance and hyperinsulinemia both predisposes to the PCOS development. In females, there is the less extensively studied sexual dysfunctions than the male, but is increasingly recognized as common. Women experience the most commonly, that is the vaginal dryness from the hormonal changes and reduced blood flow to the genital tissue, decreased libido and the reduced response to the sexual stimulation, increased rates of vaginal infection and the urinary tract infection, dyspareunia and the reduced sexual satisfactions. So these manifestations result from the endothelial dysfunction, impairing the blood flow to the clitoris and the vaginal tissues, autoimmune neuropathy, reducing the vaginal lubrication and sensation, and hormonal dysregulation affecting the sexual motivations. So female sexual dysfunction in type 1 diabetes occur almost twice the rate of the type 2, potentially reflecting the greater degree of metabolic derangement or effect of the intensive insulin therapy. Considering the ovarian dysfunctions and the female fertility in women, the diabetes alter both ovarian reserve and the steroidogenesis. So that lead to the ovarian dysfunctions, and the ovary quality can also be the reduced. In same time, hyperinsulinemia stimulates the theca cells and synergizes with the LH to increase androgen production, contributing to a PCOS type of phenomena with anovulation, hirsutism and infertility in both type 1 and type 2. Insulin resistance and obesity also disrupting the feedback at the hypothalamus and pituitary, and these changes together more frequently luteal phase defects and early pregnancy losses explain why female of type 1 diabetes may take 2 to 3 times longer to conceive and have higher miscarriages if glycemic control is very poor. Women with type 1 diabetes exhibit the reduced fertility, taking 2 to 3 times longer to conceive as compared to the non-diabetic women. And fertility reduction is independent of the disease duration, but is worsened by the presence of diabetic complications. The mechanism involves the ovulatory dysfunctions from the hypothalamo-pituitary ovarian axis disruptions, impaired ovarian reserves, and increased spontaneous abortion rates. So gestational diabetes is the other parameter that causes the increased maternal complications, and there are the neonatal complications also because of this maternal gestational diabetes. So overall, that lead to the impaired quality of life. The sexual dysfunctions in diabetes significantly impair the quality of life beyond the sexual domain alone. Diabetic men with the erectile dysfunction report the worst overall quality of life than the non-diabetic men with erectile dysfunction, with greater psychological impact on the emotional life. And that psychological burden frequently leads to depression, anxiety, which further exacerbate the sexual dysfunction, creating a negative feedback cycle. So we definitely need to manage this condition. And the fundamental intervention is optimizing glycemic control. Chronic high blood glucose is being the most common behind this problem, and improving the glucose control directly address many underlying mechanisms. So a specific strategy for the management is to maintain the HbA1c as much as below the 7% with the preconception targets of below 6.5% for women planning pregnancy. Treating the modifiable comorbidities like the hypertension, dyslipidemia, obesity, depression and smoking cessation is also important, and lifestyle modification is always on the topmost. Specific management in the men for the erectile dysfunction, the phosphodiesterase 5 inhibitor like the sildenafil or tadalafil, they are the first line therapy. The diabetic men have the very less response than the non-diabetic persons. Alternative therapy for the phosphodiesterase inhibitors refractory cases include the intracavernosal injections, intraurethral prostaglandins, vacuum erection devices, and the emerging options such as the low-intensity shock wave therapy. Management in the men also include the combination therapy with the oral supplements like the arginine or the L-carnitine may have the synergistic effect. The testosterone replacement can be considered in hypogonadal diabetic men with symptoms. The long-term cardiovascular and metabolic outcomes require the individualized assessment. In the females, addressing the hormonal dysregulation, managing PCOS-related features with the metformin or other insulin sensitizers, and treating depression are the key approaches. Preconception counseling is the most important that required with the women with diabetics should emphasize achieving the near normal glycemic control 3 months prior to the conception to reduce the adverse pregnancy outcomes. So in nutshell, we can say Reproductive dysfunction in diabetes represents a complex interplay of vascular, neurological, hormonal, metabolic, and psychological derangements triggered by the chronic hypoglycemia. Clinically, this translates to the erectile dysfunction and sexual problems in the men, menstrual irregularity, fertility challenges, and the pregnancy complication in the woman. Recognition of this complication by the healthcare provider and proactive screening remains essential, as many patients do not spontaneously report the sexual problems. Aggressive glycemic control, lifestyle modification, and targeted pharmacological intervention offer substantial opportunity to improve reproductive and the sexual health in the individual with diabetes. So, as per the take-home message, diabetes is a systemic disease that commonly impairs the reproductions and sexual function through vascular, neural, hormonal, and metabolic mechanism driven by the chronic hyperglycemia. These complications are frequent, organic, and under-recognized, significantly affecting the quality of life. So early screening, optimal glycemic control, lifestyle modification, and targeted therapy are the essential to prevent the progression and improve the outcome. Thank you everyone for patience hearing.
Thank you, Dr. Rashmi. That was very elaborate presentation. And now please come to this side and
organizer kindly.
Now I would like to invite next speaker Dr. Gunjan Kumar. He will talk on a stroke prevention, role of diabetic control, statin and dual therapy.
Thank you, chairpersons. Thank you, Vijay sir and Shaval Guha sir, for this opportunity. I've been given this topic on talking about the stroke, and yeah. So we are fond of numbers. So stroke is basically a major health challenge. It ranks 4th in mortality and 5th in disability. And when you look at the incidence, there have been many studies from NIMHANS and other places, and the incidence is like 119 to 145 cases per 1 lakh people. Probably this is an underestimate, as most of them are not reported as such. So when you look at this, this is a stroke, patient with stroke. So how is it associated, diabetes and stroke? So almost 28 to 30% of the cases of stroke have diabetes as one of the risk factors, and 33% in ischemic cases and 26% in hemorrhagic cases. So ischemic, there's a stronger correlation between diabetes and stroke as compared to the hemorrhagic stroke. So what is the percentage, what is the risk factor? So every year passed with diabetes, the risk increases by 3%, and the chances of risk is almost 3 times in 10 years in patient with diabetes. What is the relative risk? There are various studies which show that relative risk is like 2% to 4% for ischemic stroke in cases with diabetes. As for hemorrhagic stroke, it is not more. Probably there are few studies which have shown that even though we think that the risk should be more, the risk is probably less in hemorrhagic stroke as compared to ischemic stroke. What is the mechanism of association of diabetes with stroke? The first thing is there's an inflammation and oxidation. You have a vascular endothelial dysfunction is there, you have an inflammatory response is there, and there's a decrease in nitric oxide and increase in free radicals. This damages the endothelial or microvascular membrane, and there's endothelial dysfunction. It causes a prothrombotic state. There's an inflammatory cascade is there. Along with it, there's an insulin resistance, formations of AGE, that is advanced glycation end products. And finally, there's an mRNA downregulation leading to endothelial progenitor activity, inflammation, atherosclerosis, apoptosis. So diabetes has been associated with small vessel disease, large vessel embolisms and thrombus, and even with atrial fibrillation. So these all things, they contribute to predominantly increase in the ischemic stroke as compared to the hemorrhagic strokes and all. So in background of there's an insulin resistance, inflammation, oxidative stress, and suppression of endogenous mRNAs. These are predominantly the mediators of stroke in patients with diabetes. So is there any role for intensive glycemic control in stroke? Both yes and no. No in active setting, usually intensive glucose control has not shown to have a much more beneficial effect, though there's a chances of hypoglycemia is more in these patients versus conventional control. So the recommendation is that the glucose level should be kept between 140 to 100 mg per deciliter in patients with acute stroke. Why is it important? It is important because hyperglycemia leads to increased blood pressures, it leads to increased failure of thrombolysis, and also it leads to poorer prognosis. So this is what is the recommended. Too intensive a setting can lead to more of hypoglycemia and can endanger the patient. But when we talk about the long-term effects, then an aggressive multi-risk factor approach is probably what is warranted here. So I'm talking about not only the sugar control, but it is a multi-risk approach when we talk about the lifestyle modification, the exercise, the physical activity, so that it has to be done in totality rather than just concentrating only on the sugar levels. So this is the study which was like published in NEJM, and they have shown that effect of a multifactorial intervention is beneficial rather than just concentrating only on the sugar levels or other things. And probably a more intense approach is warranted in these patients. And what is the choice of therapy? We have a lot of drugs over here. So this was specifically an article which has been like targeted toward the neurologist. And you have articles which are coming up with like newer therapies and all. So the therapies which is recommended is these are the ones which have the best evidence for prevention. These are the GLP-1 RAs and glucagon-like peptide-1 receptor agonists, which have an increased neuroprotection and decrease in cerebral atherosclerosis, either by indirect effect, which is decrease in weight, decrease in blood pressure, or by direct effects, which is increased nitric oxides and antioxidants. So these are the best evidence. And when you look at the articles, they have proposed that patients with stroke and all, they may be put up on this. So this is the flow chart. I'll not be going too much into the detail, but it is not recommended to give these GLP-1 RAs along with DPP-4 inhibitors. The reason is not toxicity. The reason is mechanism of actions. So you can start these patients and just concentrate on the HbA1c. If there's HbA1c is more than 8, there's no need of adjustment of the sulfonylureas or insulin. But if it is less than 8, there should be reduction in the dosage of insulin by 20% and also sulfonylureas by 50%. Metformin still can be given. So the best evidence what we have is for GLP-1 RAs, and second is SGLT2 inhibitors. SGLT2 inhibitors, there's a contradictory evidence is there. There's meta-analysis was done, many meta-analysis were done, and it has been shown that there's been reduction in hemorrhagic stroke as compared to ischemic stroke. So the ones in the green have beneficial effects. The third is the pioglitazone. This is beneficial for secondary prevention of stroke, and the ones in the black are having, like, they do not have any negative or positive as such. So the best evidence, again I reiterate, is for GLP-1 RAs. Coming to statins, so there we have a lot of drugs which are in pipeline and which are already available in market for our fight against lipid. These are the lipid lowering drugs, and statins are the oldest and most prescribed drugs. What are the recommendations for this? It is recommendation that high dose, high intensity statin should be started as soon as possible. So what is the dosage and what are the drugs which have been studied? The most studied and the most quoted is atorvastatin, which goes like 40 and even 80 mgs. 80 mgs have been used regularly for this prevention of the stroke. And you have to keep in mind what are the other medications the patient is taking, like the enzyme inhibitors, enzyme inducers. So these have an interaction amongst themselves. So before prescribing statin and all, these should be kept in mind. Evidence for is mixed for statins considering hemorrhagic stroke and ischemic stroke, but it is definitely recommended, and strong evidence still supports statin in reducing ischemic events and cardiovascular events. The levels which are recommended are LDL-C target is less than 55. Now we have newer guidelines like European guidelines which are still pushing it lower, but probably we are more comfortable with these levels, 55 or 50% reduction of baselines. And in patients who do not tolerate statins, or even with highest doses of statins, the LDL levels do not come down, then ezetimibe is to be added in these patients, or if the patient is unable to tolerate statins, develop side effects and all, then the patient may be shifted to ezetimibe. Apart from that, what the recommendation says that other drugs are the PCSK9 inhibitors which can be added. So these are the ones which we have in our arsenal. And for primary prevention and all, the score and other things have to be calculated, and based on that, the patient has to be treated according to this. When do we monitor? How do we monitor this? Ischemic stroke, it is advised you get a CPK at the baseline. If the CPK is more than 4 times the normal, usually statin has to be avoided in these patients. And at 8 weeks, you do the LDLC, you do the CPK, alkaline ALTs. And if there's an increase in this, disproportionate increase in then probably statins have to be stopped and you have to shift on the other things. Other than that, based on the combination therapies, statins have been evaluated along with statins and antihypertensive, and they have shown to have a beneficial effect. This is again a HOPE-3 study. I'll not be going too much into detail in interest of time. That is the statin arm plus blood pressure lowering arms. So when you see here that there was a significant decrease in the risk of fatal or non-fatal stroke group was significantly lower in the combination therapy, which was 1% versus 1.7%. And again, you have seen here that there has been increase in this. And when you combine with the statin and ezetimibe, this was the trial, it was a treat stroke to target trial. And this was the basis on which the LDL levels less than 70 have been proposed based on this. So they have shown that they have compared two groups. One was statin alone and statin with ezetimibe. And when you compare this, when you see here, the two groups are there. And the dual therapy patients had a higher level of LDL in this, but as we see in the final results, the dual therapy had reduced major vascular events versus higher LDL target. So, and statin alone show no significant benefit, no increase in intracranial bleeding. So there is probably a role for combination therapy. Obviously, some subset of patients, we do not start combination therapy as such in all the patients, but yes, a particular subset of patients, especially who are not like who are not getting benefits with statins, or who are like getting reactions with statins, or the LDL is not benefited much with statins alone. These are a particular subset of patients who may benefit with either shifting to other therapies or with combination therapies. So this was the study in which they had shown that the dual therapy does have a role in these patients. So to summarize my slides, first thing is that blood sugar control is a multimodal approach, and for prevention of stroke, HbA1c generally is target 7%, but it has to be individualized. And again, I'm reiterating this is a teamwork. You need to understand the patient's other comorbidities, lifestyle modifications, physical activity and other things. Only concentrating only on the sugars as such may be counterproductive. And the best evidence is for GLP-1 receptor agonist followed by SGLT2 inhibitors. So GLP-1 receptor agonist, the data and the randomized trial and the things are the maximum evidences for these compounds. And obviously you need to avoid hypoglycemia, as it can be detrimental and it can lead to increase in the strokes. As for statins, this flow chart summarizes whatever I have said. The patient with ischemic stroke, start with high lifestyle modifications, start with statins. If the patient tolerates statins and if the LDL is less than 70, then please continue this. If the patient doesn't tolerate, add ezetimibe or the shift to ezetimibe. If the patient again doesn't have LDL less than 70, add another or this or shift to this PCSK9 inhibitors. And combined therapy is warranted in patients who do not tolerate or who have side effects with statins, or the patients in which LDL-C is not getting reduced as much as we desire in this. And there are now many drugs are there which we see, I have mentioned in the previous slide also. Now the newer therapies are coming, I think you people know better than me, which is targeted towards some particular targets in the lipid cascade and other things. Especially like you have the icosapent ethyl which targets the triglycerides. So you have drugs which are coming up for isolated triglyceridemia and other targets are there. Thank you.
Thank you for nicely elaborating the topic by Dr. Gunjan. Please take your seat, sir. Next topic by Dr. Saurav Karmarkar. And the topic is from TB to COVID, diabetes as a silent driver of pulmonary infection. So over to you, sir.
At the outset, I would like to thank the organizers for this opportunity to be invited in the August gathering of the intellectual chairpersons, the respected senior physicians of this state, of this zone, and the rest of the delegates. So I begin my talk right away. The topic of my talk is From TB to COVID-19, Diabetes mellitus as a silent driver of pulmonary infections. So diabetes is an immunological saboteur. It sabotages our immune system in a way. I will be talking about that. I will be briefly touching upon TB and diabetes nexus in this viral era which started after COVID-19, which brought us to terms with the fact that viral infections can take away a large part of the population, our loved ones from us. And I will talk about the bacterial and fungal threats and the preventive strategies. I will just touch upon the preventive strategies because the therapeutic strategies is best left to the physicians amongst us. So as we see, the prevalence of diabetes is slowly increasing in this community, and it is projected to increase to a vast number of 700 million. So diabetes leads to an impairment of the innate immune system as well as the adaptive immune system. It impairs both of these systems. Okay, it leads to an altered structure of C3 complements, inhibits the C3 mediated complement effectors, and diabetes is a state of chronic inflammation. There is increased production of reactive oxygen species, increased release of pro-inflammatory cytokines, and elevated formation of neutrophil extracellular traps. Now these neutrophil extracellular traps, they are a double-edged sword. Okay, so in this, what happens is that in diabetes, these nets, they become sticky types. As a result of infection, they are released, but these nets, they are unable to migrate to the site of infection. They lead to excessive inflammation at their local sites, and this faulty pathogenesis of net has been implicated even in the onset of vasculitis, like the anti-neutrophilic cytoplasmic antibodies. They are also a type of net. They lead to the production of nets, and they induce vasculitis in the middle ages because vasculitis, as we all know, has a bimodal distribution. So in the cytological, immunological level, this diabetes causes excessive nets and excessive migration of these nets. This leads to impaired wound healing, vascular complications, and the net increase in diabetes, the neutrophil extracellular trap increases because of metabolic reprogramming, the epigenetic changes, and trained immunity, what we call as the innocent bystander effect in the vaccine immunology, and these are the mechanisms which increase the risk of infection in diabetes. Now coming to TB, being in India, we cannot escape this disease. It is the topmost cause of death from a single infectious agent worldwide. Overall, it is the 13th most common cause of death, tuberculosis. So during 2022, whatever advantages we had in our TB control program, there were widespread disruptions. The end TB strategy envisaged a 75% reduction in the TB deaths in these 10 years, but unfortunately it was only 19%. As we can see here, although the number of deaths by TB was reducing up to 2019, but due to the disruption brought about by COVID-19, again these deaths climbed up. So it resulted in an excess of 500,000 deaths. 5 lakh excess deaths occurred from TB in 2020-22, just the immediate first wave, second wave, third wave period. But having said that, even in the absence of this COVID-19, the death rate from untreated TB is high. 50%, it is about 50%, so it is a disease that we should be treating. So now with COVID-19 and diabetes, it is a perfect storm for reactivation TB. In the patients of COVID-19, TB is associated with more severe disease, more delayed recovery, and higher deaths. A past history of COVID-19 magnified the known association between diabetes and TB. So the odds ratio for TB in patients of diabetes is 2.7. A patient of diabetes has an odds ratio of 2.7 times as compared to a non-diabetic patient of catching TB. But if he is a COVID-19 positive as well as a diabetic, then that odds ratio magnifies to up to 8 times. So lymphopenia due to COVID-19, it synergizes with the defective monocyte macrophage effector functions in diabetes to compromise the cell-mediated immunity needed for TB containment. As we know that as compared to humoral immunity, the immunoglobulin levels IgG, A, M, E, which affect diseases like bronchiectasis, in TB, as compared to the immunoglobulins, as compared to the humoral immunity, we need this cell-mediated immunity more. That is why TB is so common in HIV positive patients in whom the CD4 counts are lesser, or in idiopathic CD4 lymphopenia. Problem is that in low and middle income countries, TB is endemic. So we don't have the national TB eradication program. We cannot eradicate TB is what I personally believe, but we have a national TB elimination program. So we should know that we can eliminate it, but we cannot definitely eradicate it. So the prevalence of TB, diabetes, but problem is that in the endemic countries, the burden of diabetes is now increasing. TB तो पहले से endemic था ही, साथ में diabetes भी increase कर रहा है, and this TB diabetes comorbidity ranges from 13 to 15%. Increased TB incidence, where longitudinal studies have shown that where diabetes prevalence is slowly increasing, the TB incidence is also slowly parallelly catching up with that rise in the amount of diabetes. TB per se can lead to impaired glucose tolerance. It can induce IgTT through a variety of mechanisms in our pancreas. So using this mathematical model, they have predicted that new TB cases attributable to diabetes by 2050, they will comprise about 1/3 of the total patients in whom we can attribute diabetes to be a causative agent for his for that patient's tuberculosis. And mathematical models, they have predicted that by 2050, about 42% of the TB deaths will be attributable to diabetes alone, while the 2017 figures are of the actual figures. So they use a Levine model of population attributable fraction, as we have a Stablo equation for estimating the TB incidence over time. These are mathematical models. Now TB and diabetes, they have a complex comorbid interaction. We should treat both the conditions concurrently to ensure optimal outcomes. Controlling of blood glucose levels is very essential. As per the NICE sugar study, the blood glucose levels in ICU should be optimally, it should be up to 180. Tighter glycemic controls are associated with more mortality, and ADA as well as ACP, they say that even in frail elderly people, balancing the risk of hypoglycemia up to 8 is also allowed, whereas in a young non-diabetic person, we should go for a HbA1c of 6.5 or 7, whatever. It depends, a lot depends on the population, economics and things like that. So conventional regimen of RHEZ followed by RHE over a period of 6 months should be taken under supervision. We don't need any additional drugs for the sensitive TB. We should wait, okay, give certain time for the, because rifampicin is ultimately the most potent sterilizing agent, even if you are comparing it to streptomycin. Problem with rifampicin is that it induces liver enzymes and it can reduce the effectiveness of the OHAs. Rifampicin accelerates the metabolism of sulfonylureas and biguanides, reducing their plasma level. Isoniazid may also antagonize the effect of sulfonylureas, and sometimes the adverse effects of TB and diabetes medications may frequently overlap. However, having said so, social and economic conditions heavily influence treatment options, especially among the developing societies of South Asia and Africa. So, how TB affects, how diabetes will affect the TB risk and severity? how are diabetic TB patients different from non-diabetic TB patients? The bacillary burden is higher at presentation in diabetics. Diabetics have a modestly longer time to sputum culture conversion. And the rates of sputum culture conversion are similar to the non-diabetic patients by 2 to 3 months of treatment. Means once you have started ATT for the diabetics or non-diabetic TB patients, by 2 to 3 months their bacillary burden equalizes. As we see in the global India estimates of TB cases, most common cause of TB is still attributable to undernourishment, be it in the world or be it in India, followed by HIV, and diabetes is responsible globally for around 3.7 lakh TB patients, and in India diabetes per se is responsible for causing or attributing tuberculosis in 1 lakh patients approximately. So the NTP now does active diabetes screening. So they have found that around 92% TB patients in their program underwent diabetes screening. Of them, 7.7% TB patients were newly diagnosed with diabetes, and of them 63% patients commenced diabetes medication. So treatment failure and death are more frequent in diabetic patients, and diabetic patients were 3 times more likely to have TB than controls. Whether diabetes per se contributes to drug-resistant TB or not, this matter is a bit dicey, because there are certain studies say that the diabetic patients are more prone to drug-resistant TB. Certain studies says no, it is not like that. The prevalence of drug-resistant TB is equal in diabetics and non-diabetics. Even some studies have shown that metformin has a good effect. Metformin has a tuberculostatic effect. It augments the effect of the other ATT drugs. But again, more evidence is needed for this. But yes, in our setting in the developed countries, we can rely on proper OHA control for a diabetic patient if he has suffered from tuberculosis. Both can move concurrently. Regarding other infections, the community acquired pneumonia in diabetic patients, so CRP and leukocyte values were higher in the diabetic patients as compared to the non-diabetic patients. The diabetic patients have higher frequency of enterobacteriaceae, bacterial isolation. Diabetic patients have increased rate of ICU admission within 28 days, and death from any cause within 180 days. So we see diabetic patients of community acquired bacterial pneumonia, they fare worse than, they suffer more than non-diabetic patients of community acquired pneumonia, and patients with diabetes mellitus represent a highly prevalent and clinically vulnerable population in the context of community acquired pneumonia. A community acquired pneumonia patient, when he walks into my OPD and he has diabetes, it is always a scary scenario for me, and always we have to convince the patients to get admitted for observation. So fasting blood glucose levels at admission predict a mortality in patients with viral pneumonias. It is not that we should not attribute every high sugar to stress-induced hyperglycemia. Insulin reduces the hyperglycemia, but it does not reduce the ACE2 receptor expression in the lungs in diabetic patients. And this ACE2 receptor in the lungs, it was responsible for the entry site of COVID. So, and diabetic patients have an increased ACE2 receptor expression. The prevalence of patients of type 2 diabetes in viral pneumonia was 38% as compared to up to 25% in CAP among hospitalized patients. So, diabetics have more frequent viral pneumonias, and we should know that in the Western world, the viral pneumonia winters ke samay aata hai, at the onset of winters, November, December. But unfortunately, again, India is, I will take a few slides more. So unfortunately in India, the viral pneumonia season starts from July, August onwards, continues through the winter. So somehow our country suffers more from this than the West, and polymorphism in ACE2 receptors increases vulnerability to viral invasion, especially it increases the invasion to COVID-19 virus infection. And so there is a lack of effective antiviral medications other than influenza. We have a poor viral pneumonias can coexist with bacterial pneumonias. cardiovascular and cerebrovascular diseases contribute to this poor outcome, and emphasis only on glycemic control should not be there. Viral pneumonia patients, they need assisted respiration, they need oxygen support, they may need ventilation support, things like that, and a higher fasting blood glucose level, greater the risk of death at 90 days, and this fasting blood glucose level, they predict some mortality and it is responsible for deaths like that. Coming to fungal diseases, which is a very, dreaded thing. Established risk factors for invasive fungal diseases, steroid use, neutropenia, immunosuppression, but multivariate logistic regression analysis have shown anemia, albuminemia, elevated serum creatinine to also cause invasive fungal disease. 48% patients of fungal disease have bacterial infection. किसी को bacterial infection है तो fungal नहीं होगा, या fungal है तो bacterial नहीं होगा. It is not like that. Co-infection can present as pneumonia caused by gram-negative bacteria. Mucormycosis के लिए, for mucormycosis you need a lot of acidic environment, be it diabetic ketoacidosis, be it chronic kidney disease, because ultimately creatinine is an acid. So acidic environment favors pulmonary mucormycosis. Aspergillosis can grow without diabetic ketoacidosis. Nosocomial invasive fungal disease spectrum differs from a community acquired invasive fungal disease, and patients developing nosocomial invasive fungal disease are older. Older patients are more sicker in the hospital. They have a problem of catching hospital acquired invasive fungal disease, and longer disease duration is there. So in our data set of post COVID-19 fungal lung infection patients, as we see diabetic patients, half of those patients had diabetes. In our data set of strictly pulmonary infections, we did not look for the ROCM, the rhino-orbitocerebral mucormycosis. Strictly pulmonary patients, most common fungus was Aspergillus, followed by mucorales, and as we see in India, you cannot escape from this TB coexisting with fungal diseases. Always know fungal culture is the gold standard. It can frequently give false negative, because mucormycosis may, they always grind the, when we send a lavage sample or a tissue sample for culture, the microbiologist always grinds the sample to inoculate it, and since mucor has aseptate hyphae, mucor का hyphae में septa नहीं होते हैं, it is very difficult to grow mucor in culture. So although fungal culture is gold standard for mucormycosis, frequently it can come negative in mucormycosis, frequently it can come negative in cases of aspergillosis. So for aspergillosis, Bal galactomannan with a threshold value of more than 3 times the normal had a good positive predictive value in our case series of original article. And so we have completed the fungal infections. So radiologically, radiology is very non-specific for invasive fungal diseases of the lung. Imaging may just reveal ground glass opacities. Look, always the clinical context matters. If he is a diabetic, if the patient is uncontrolled diabetes with diabetic ketoacidosis, sir, just allow me 2 minutes. I'm really sorry for that. So we should have a low threshold for diagnosing the invasive pulmonary mycosis, and well, we should get some sample, some lavage, some tissue sample. Tissue sample is a definitive, provides a definitive diagnosis, and host factors are important. Just last 2 slides. Prevention के लिए we need a good glycemic control, annual influenza vaccination, pneumococcal vaccination, COVID-19 vaccination in patients who are very poorly controlled diabetes. We should follow the hand hygiene and the general hygienic practices. NTP recommends for screening, symptom-based screening, screen all registered TB patients for diabetes. Every patient of TB, screen them for diabetes. Ensure diabetes is managed properly in the TB patients. Intensified detection in the community of active TB disease should be done among diabetes patients if they have this 4 symptom complex of TB. Ensure TB infection control measures. If you are admitting patients of suspected TB, ensure good infection control measures in your hospital ward. ensure TB treatment and management in comorbid patients. And I thank you for your patient listening, and I apologize that I have overshot my time. I would happy to take any questions if there are any.
We are over time, so
Sir.
the next topic.
Sir, thank you, sir, for enlightening on this topic. Now I'd like to invite, sir, please you can have a seat, sir. Thank you, sir. So now I would like to invite Dr. Surendra Kumar, retired professor PMCH, for his talk on the topic Future of Diabetes Care, Wearable and Implantable Technology. Over to you, sir.
Thank you, sir. I am late, and I have given this topic, the future care of diabetes, wearable and implantable. Many of us are taking the insulin, and why they have given the topic, it is the opportunity for me. I worked for the changing diabetes in children for more than 12 years. With my team, I recruited the children from 1 year to 18 years of type 1 diabetes, and we provided them the insulins, the glucometers, the investigations, all free from a pharmaceutical company. So, our children always smiled with the pain of the insulin, and they did well. But the few persons among them, especially the guardians, told me, please tell me the best treatment of type 1 diabetes. What is that? Now, you may have some answers from this topic. Now, it is the changing diabetes in children. Now come to the topic. I will not take more than 15 minutes because it is the new thing for the Patna, especially in Bihar. People come to us that डॉक्टर साहब लड़की की शादी करनी है, इसका कोई उपाय बता दीजिए छिपाने का. Then we thought it is the one of the treatment for the every type 1, type 2 and the diabetes in pregnancy. There are two segments of this, the glucose monitoring devices and the insulin delivery modalities. Now come to the first. You see the journey of the insulin syringe, the glucometer, the all ultimately comes to the AID. I am not going to give you details of this, but I remember the Dr. Subhas, who has given a talk in the Diabetic Federation on this topic. So we always do the self-monitoring blood glucose. You see the glucose 7 times, 5 times. We advise the 5 times, that is the fasting postprandial, pre-lunch, pre-dinner, and the random. All the people, everywhere, they advise before the meals and one at night. You see, the difference between the CGM technology and the SMBG. SMBG takes a snapshot of that time, particular time, but the CGM technology checks the blood sugar, give the reports of the blood sugar every 1 to 5 minutes. So this is the difference between the SMBG and the CGM technology. Now, in the 1970, there was a big CGM system that was only for the check the blood glucose, but now it is available, the transdermal. You can put over the arms, and it is the one of the most small and the affordable, bearable CGM system, that is transdermal. Now you look for the implantable. It works for the 6 months. The transdermal and the others, except this one, this is approved. This works for the 6 months. You can put the sensor inside the body, a smart transmitter, and mobile app. Always the mobile app is required there. It is the implantable. The cost is more. How we calibrate the sensors? It is by factory, calibration by the self-monitoring blood glucose, and calibration by the code. Code are given over the system. What is the limitations of the SMBG? All we know the limitations of the HbA1c and the SMBG. Regarding the HbA1c, if it is less than 6.5 or 6.5, we are happy. But there are some where J and U curve, what we think that if it is lower than that, you can have the more mortality than the preventing the complications. You see the differences. They completely transform the diabetes care, the CGM technology. I am not going to for the meta-analysis because only 7 minutes is there, but this is the triangle. Why the CGM technology we use? One thing, to avoid the hypoglycemia, to limit the glycemic variability. It is something difficult to calculate the glycemic variability, but for the type 1, it should be less than 36%. It improves the overall glucose level. Why we try to avoid the hypoglycemia? Hypoglycemia leads to neurologic consequences and the cardiovascular disease. Whether the cardiovascular disease is more with the hypoglycemia, I am not sure, but it is given in the one of the text. So I am using all the lines, I am showing all the lines from a textbook. Remember, whether now I know the one person who reads the textbook too much. I have also that one. That is the Santosh Kumar Singh. And it is the 15th edition of the Williams Endocrinology. I have read this chapter also, and I have brought the few lines from that. That's why I am not giving the reference name of the articles and the other things. It is from the textbook. Now, the last one, it is the small, sorry, it is the last one. It is the implantable for the 6 months. It continue for the 6 months. Others are the 14 days, 7 days, 10 days, the only one. These are the CGM systems. The advantage is they make daily decision about your blood glucose, and what the trend shows, the upward, the flat and the downwards. It gives, you have the, where you are going to have the hypoglycemia, hyperglycemia, or you don't give the extra insulin. There is slide rule system. We have read previously the sliding rule system. Now it is the slide rule system by some author. They remember the 10%, 20%. If it is going up, increase by 10%, if going upwards more than that and very fast, you can increase by 20% of the insulin dose. This is the final recommendation. If anybody needs, we can give him. Where we can use in type 1 diabetes, type 2 diabetes and diabetes in pregnancy. Really type 1, it is not the mistake. Now just 1 minute, Sir Supreme Mukherjee. Just you see the type 1, how I have written the type 1 diabetes. It is the type 1D. It is the type 1, type 2D. This is the new. This is the new. You don't need to write the M. Now, time in range. Already we know that all four. The one thing, we are not agreed with the 180. We always, in all patients, whether it is the children, whether it is the elderly, the sir, one, Ajay sir is not here, the elderly, the most elderly doctor. Just one remember, time in tight range. The second one, time in tight range, that is 140, 70 to 140. Women with type 1 diabetes mellitus? Okay, sir. These are the platforms. These are the per day, the insulin delivery. Insulin, a smart pen. Now, modern insulin pump. Low glucose suspend. When glucose comes down, it withdraw the insulin supply. Now, the AID system. The brain behind the AID system. Remember the algorithm. that is MPC, PID and the Fuji Logic controllers. It is the US FDA approved. You can download, it will guide you for the everything. The special situations, go ahead, inhale insulin delivery. The one thing, use bi-hormonal system that integrates the both insulin and the glucagon. All the drugs, in the bottom line, whether it can be used in the type 1 or not, it is till date not recommended. Please always remember it works. What is the future directions? The future goal must be to have AID system made available as the standard care in the type 1 diabetes. For the type 1 diabetes in India, everyone should have the AID. This will come from the government side, and we demand, we think we can transform the treatment of the type 1 diabetes by this AID system. Thank you very much.
Thank you, Dr. Surinder, for your informative speech. And due to we are running late, and the organizer has asked to avoid the question answer for these sessions, so I conclude this session and ask all the speakers and chairperson to come to side stage for photo session and memento collection. Thank you.
The long session has surely tested our patience, but has left us all enriched with more knowledge. I thank the chairpersons and the speakers and request them to move to the side stage for felicitation. Going ahead to a very important session, I would like to call at the stage the chairpersons, Dr. B.K. Singh sir, who is the East Zone member of National RSSDI, Dr. Supriyo Mukherjee sir, Dr. Shaibal Guha sir. Over to the chairpersons.
Hello. Good evening to all of you. And the next session is a very important session, that is the M. Vishwanathan oration. And we all know that Bihar chapter has started this M. Vishwanathan oration 2 years back. And the first orator was the Vijay Vishwanathan, the son of M. Vishwanathan Sahab. And the second Anuj Maheshwari. And in this continuation, I invite our beloved, ever smiling, our president-elect, and he will take charge of president in 1st of this January, Dr. Sunil Gupta. And it is a well-known figure, and he is a practicing diabetologist and associated with many of the organizations, and he is well known to the Nagpur. May I request Dr. Supriyo Mukherjee to read the citation, please.
Very good evening, ladies and gentlemen. This is the time to felicitate our national president-elect, Dr. Sunil Suraj Prasad Gupta. His in honor of enduring legacy of Dr. M. Vishwanathan and in recognition of exemplary academic leadership, and services to the science and practice of diabetes. The Dr. M. Vishwanathan oration is conferred upon Dr. Sunil Gupta, MD, FACE, FRCP, FACP, FICP, FIAMS, FIACM, FDI, RSSDI, and diabetologist and CEO and managing director of Sunil's Diabetes Care and Research Center Private Limited, Nagpur, a nationally and internationally acclaimed clinician, academic. He is a president-elect RSSDI and past national president, Diabetes in Pregnancy Study Group, India. He currently serves as national treasurer, AIAARO, and executive editor, Indian Diabetes Educators Journal, that is a journal of RSSDI. His scholarly output includes 236 publications, leadership as a principal investigator in multiple phase 2 and over 25 phase 3 clinical trials, and the rare distinction of 6 consecutive Best National Research Paper Awards for RSSDI. A recipient of 29 orations, 6 international and 7 national fellowship, and 43 academic social awards. Dr. Gupta's recognition includes the Outstanding Young Person of the World Award, inclusion of Guinness Book of World Record and Limca Book of World Record, and multiple national honors for excellence in healthcare, academic, community services, and diabetes education. Over 3 decades, he has conducted 3364 academic programs reflecting an extraordinary commitment to education and outreach. Through his leadership, scholarship, and his service, Dr. Sunil Gupta exemplifies the academic spirit and the enduring influence that the Dr. M. Vishwanathan oration seeks to celebrate. Thank you.
Good morning, everyone, and at the outset, let me thank the organizers. A special thanks to the Dr. B.K. Singh, and who's our EC member also, and of course Dr. Supriyo and the whole team. Dr. Vijay Kumar, Dr. Shaibal, and Subhash Kumar. We have my elder brother sitting here, Dr. Ajay Kumar, who has always guided me. And Dr. Vasant Kumar, the past president of RSSDI. So I am actually being very well protected by big people across. I am feeling honored to deliver a talk on this oration, which is very prestigious to us because he is being called as father of diabetes in the country, Professor Dr. M. Vishwanathan. No conflict of interest for this session. We'll have introduction, roadmap for hyperglycemia and pregnancy, our data, which is still unique in the country, on GGI, on GDM, pre-gestational diabetes, type 1 diabetes, twin pregnancy, and our thirst for education still continues, and the final message. So my journey started on pregnancy diabetes long back, almost 30 years from now, where Sam G.P. Moses is one person who actually stimulated me to go for some subspecialty in diabetes. And I asked him, sir, where to go? He said, I'll make you meet Dr. Professor Sheshaiah. And he made me meet him, and then my journey started. Dr. V.S. Asgaonkar from Mumbai is a person who has actually encouraged me to go for education, public awareness. Actually, I have learned from him. First meeting in Lonavala with Type-1 diabetes I attended in my life. That was 1992 and 93. And then we have Dr. Sheshaiah, from whom my journey of hyperglycemia and pregnancy started long back. And this was almost 1999 when Dr. Sheshaiah has come to Nagpur by train. Those days, there's no flight available from Chennai. And he came all the way, almost 20 hours journey by train, 25 years from now, 26 years, and he delivered one oration on pregnancy, diabetes, and since then things are still on. And these are few of the pictures of those days. And then we have organized national meeting of DIPSI in Nagpur, and you can see the difference of me. That time I had mustache, which I have removed now, and this is Dr. Sheshaiah. And that time I had Dr. Jitendra Singh, who was the DIPSI joint secretary with me. So we were sharing the same position of joint secretary. Kya ho raha hai? I don't know what is happening here. It's automatically going. So he was he was the joint secretary. I don't know. And this is the award he gave us for diabetes education. I don't know how it is moving, beta. It's automatically moving, see. ये देखो. No? I am now going ahead. This is going ahead now?
Yes. Here you wait. Here you wait.
Yeah, here I was there. Then this is one of the award which he gave. Now, so let me now introduce. I'll be very quick because we have less time, but my slides should be with Miss. I don't know how to control it. Acha, is this working? No, it's not working. Okay. Oh, I don't know. So let me tell you just the epidemiology part, that hyperglycemic pregnancy globally says 16.7. Now this is a diagram which is from ICMR study, that dysglycemia in our country is around 2.36 crores. 23.6 crores. We have 10 crores of diabetics and almost 13.6 crores of pre-diabetes. Importantly, that IGT in non-pregnant state is GDM in pregnancy. I repeat, IGT in non-pregnant state is GDM in pregnancy. So all people with pre-diabetes are likely to have GDM during pregnancy, which number, if you count them, it's almost 23.6 crore. And if you go through the adult population of our country, 23.7 crore is the adult population above 18 years of age. So out of 96 crore whose total population, 23.7 crore they have dysglycemia. That means every fourth individual above 18 years of age is likely to have some kind of hyperglycemia, and all women of childbearing age are going to be suffering with this. So with this calculation, either you go for ICMR data or you go from IDF data, every fourth woman during pregnancy is likely to have either GDM or pregestational diabetes. And this is the IDF data, Southeast Asia, 25% prevalence. Now, whenever we talk about GDM, it's not the only mother, but those who are likely to become diabetes in future, but even offspring of diabetic mother are likely to develop diabetes, obesity in future. So we are protecting two generations. This is the recent classification of FIGO, that hyperglycemic pregnancy divided into two, diabetes in pregnancy and pure GDM. Pure GDM usually appears in after 24 weeks or 20 weeks of gestation. DIP is known diabetes type 1, type 2 becoming pregnant, or those who are diagnosed for the first time but had pre-existing diabetes. Both of them are DIP category. Now there are newer classification. We call it as conventional GDM, which is diagnosed between 24 to 28 weeks. We have overt GDM or diabetes in pregnancy, which is pre-existing. We have early GDM, now recent terminology, EGDM. So CGDM conventional, EGDM early GDM, where the GDM is diagnosed before 24 weeks of pregnancy. We also have mild GDM. We call it a gestational glucose intolerance. If your blood glucose after glucose is above 120 but less than 140. So screening, these are the IADPSG criteria, WHO and DIPSI criteria. Government of India has approved DIPSI criteria, so we usually talk of DIPSI criteria, but few people might be interested going for IDPSG criteria. They can even follow that. I am not going in detail of it, but DIPSI criteria says women coming to your clinic irrespective of fasting or non-fasting, just give 75 gram glucose, take 2-hour test. If it is more than 140, you call it as GDM. Very simple to understand. You can do it even with glucometers, that has been allowed. Now GGI is gestational glucose intolerance, where your value is between 120 to 140, because your goal, the target of glycemic control is 2 hours more than 120. So anything above 120 is abnormal. So 120 to 140, it's called a gestational glucose tolerance. In other countries, in Australia and New Zealand, they call it as borderline GDM. Netherlands, they call it as mild GDM. Some of them call it as IGT in pregnancy. So you have different names for this, but anything, even one value is abnormal, we call it as, we want it to be treated for. So this is one data on gestational glucose intolerance, where we have chosen all women who had bad obstetric history, and we have chosen these 120 to 120 and treated them. Almost 10% of them, they required insulin therapy to achieve the targets, and the fetal losses, which was around almost 35 to 36%, has come down to less than 4%. So glycemic targets, I feel everyone knows, the fasting should be less than 90, 2 hours should be less than 120, mean should be less than 105. And these are the targets. Some very senior doctor has just shown you the CGM data. So for normal non-pregnant state, your cutoff is between 80 to 180. So your TIR, time in range, is 80 to 180, but in pregnancy it is 63 to 140. So you call time in ranges between 63 to 140. So in GDM and pre-gestational type 2 diabetes, you should try to achieve more than 90% TIR. In type 1, more than 70%. Therapies, you have metformin, lifestyle modification, diet control, 70% of the GDM will do well on that. Metformin and insulin will be required by around 20 to 30% of the women. And I will be talking about insulin more here. Metformin I am just skipping here. But insulin doesn't cross the placenta. Rest all oral drugs, they cross the placenta, and that is why insulin becomes a drug of choice. I'll just share you our data on insulin. Metformin, there are indications that Government of India says after 20 weeks of pregnancy. Recently DIPSI guidelines have given a recommendation after 12 weeks of pregnancy. NICE guidelines and the European guidelines now say metformin can be given from preconception till delivery, because there is no safety concern have been observed from the MITI trial, which was done in type 2 diabetes women, and metformin, they were all being exposed to metformin. So though it's a drug which is a weak drug, 50% of those women who are on metformin for GDM or pre-gestational diabetes will not do well on metformin alone. They will not be able to achieve your target of 90 and 120, and they will need supplemental insulin therapy, that we have to remember. But metformin can be given otherwise. We still have little concern from other recommendations. But insulin remains the drug of choice. So I'll just share some of the data of ours. This is a lady, 28 years, who has a very high blood glucose at the time of diagnosis of pregnancy, 12.9 HbA1c, and she was it was a COVID period. She did not have any other thing, but then she had missed abortion at the time of diagnosis, within few days of diagnosis, and she presented to us after almost 6 to 8 months of this, and she was put on basal bolus therapy, and then she again came with the pregnancy. With that time, the HbA1c was 6.7 after 6 months, and these are her recent blood sugars. In the preconception, she required around 0.7 unit of per kg body weight of insulin, which increased to almost 2.08 by at the time of delivery. Postnatal, if you see, it came down to almost 0.32, that means 50% of the preconception dose, and postpartum it took almost 30 days to go back to the original dose. So this is another message to all of you that how the insulin requirement goes up in type 1 pregnancy and how it comes down. And this is the diagram. If you see, as the pregnancy advances, insulin requirement goes up to 36 weeks, suddenly it falls here after delivery and went up again. And if you see here, the breakfast, lunch and dinner, the pre-dinner dose of insulin was found to be highest. She delivered a male baby, 3 kg, normal weight, no congenital malformation this time. Intrapartum was managed with 70 to 120 blood glucose through insulin infusion. These are data recently published, presented in ADA or IDF on type 1 diabetes. We had around total around 33 pregnancies, and what we have seen is the preconception dose is 0.8 unit per kg body weight. At when diagnosis was done, almost 1 unit, which went up to almost second trimester 1.1, 1.2. Postnatal again came down to 0.5. So whatever we have seen in one patient was LADA, similar observation have been seen in these 33 pregnancies which with type 1 diabetes. This is another paper on type 2 diabetes on insulin, and we have seen that the pre-gestational type 2 diabetes are requiring first trimester around 0.5 unit per kg body weight, which increased to almost 0.8 unit by third trimester. And again, if you see the pre-breakfast versus the this is the breakfast dose and this is the dinner dose. This is at the time of third trimester. The pre-dinner dose was highest, and this comparison between the pre-breakfast and pre-dinner dose was statistically significantly higher, and it was found that the calorie intake in central India at breakfast is lower and at dinner was highest. Possibly that is the reason they are requiring higher dose, but very few times we in our consultation prescribe or we tell them to monitor post dinner. We usually monitor post breakfast and post lunch blood glucose. Now we should be monitoring post dinner blood glucose also very aggressively. We have rare data on twin pregnancy, and I got stimulated by reading this paper from US, where they have shown in type 1 diabetes, twin pregnancy are requiring double the dose that of singleton pregnancy. And I thought we have not observed it. We have a data of 2 centers from Nagpur and Pune, and we have come out with the conclusion, there's around 40 pregnancies, GDM1 with twin or singleton gestation differed insignificantly in their treatment strategy. That means even if you have one baby or it's a twin baby or triplets, it's not going to have increase in the insulin dose will not be dependent on the number of fetuses. So that's another message in India and in gestational diabetes. And this is the last paper which we just published last November on neonatal and maternal outcome and treat in a women. The one group who was taking only diet from starting until delivery, they were put only on diet. Another group started with insulin, have been put on insulin throughout the pregnancy, and we have tried to compare which are the factors where we can decide that these are the women who are likely to be on insulin therapy, and which are the women who are going to require higher dose of insulin versus the other group of women who are requiring little lower dose of insulin. And we have done the propensity match scoring. The conclusion or highlight will be women receiving insulin had lower risk of preterm delivery, lower risk of low birth weight, and lower risk of macrosomia, those who are on insulin therapy. Neonatal hypoglycemia was higher. If your 2-hour value is more than 162.5 or the fasting value is more than 90, they are likely to require insulin therapy. Individual with propensity score of more than 0.7 required higher dose of insulin. What is that? I'll show you this. This study has revealed that individual with bad obstetric history, family history of diabetes, obesity, elevated fasting, post glucose and HbA1c, they are requiring insulin more often. And this is the again paper initial the full term insulin requirement per kg body weight, and we have divided into 4 groups, and they used one love plot, and this love plot I heard for the first time during statistical analysis. I'll directly go to the data here. You see the first quartile, second quartile, third quartile, almost 95, 96 patients in each quartile. Initial dose is almost similar, full term dose is almost similar, but the fourth quartile with propensity score of more than 0.7, which was calculated through age of mother, to higher age of the mother, higher parity, bed obstetric history, positive family history, pre-pregnancy BMI, higher blood glucose values, are requiring higher dose of insulin at the time of initial treatment as well as till delivery, and that was statistically significant. So if you have women coming with these risk factors, they are likely to require higher insulin doses, and this per kg body weight almost the same thing. So insulin doses, if you go through different status, GGI, GDM, pre-gestational type 2 diabetes, type 1 diabetes, you require around 0.1, 0.25, 0.5 unit, which went up to almost 1.5 times in all the groups. What is more important is the awareness on pregnancy diabetes, because if you want to protect future generations from developing diabetes, you have to now focus on the primordial prevention, because the smallest amount of hyperglycemia and metabolic derangement in the intrauterine phase becomes a risk factor for developing diabetes, obesity in these children who are born to these mothers. So we'd have to catch them young, as early as possible in the first trimester, the first given opportunity, and try to treat them as intensely as you can throughout the pregnancy to avoid the development of these non-communicable diseases in their adult life, and for which we need mass awareness. 10th of March is a National GDM Day, and we have started this Prega talk almost 3 years back during my presidentship in DIPSI, which is in all 22 languages in the Constitution of India, and where in the first as well as second and third cycle, all 3 cycles, even we have included Maithili, Bhojpuri, and one more language here from Bihar, and we have done it. This is the last one, which was Maithili and Bhojpuri language, and this is of I feel 2024, and this is of 2025, and I'm really thankful to all my faculties here. What are the future directions we have? We have GDM registry in our pipeline in RSSDI during my RSSDI presidentship. Postnatal screening follow-up, we have to have awareness amongst physicians, diabetos, endos, and OBGYNs, and mass awareness for women health. And primordial prevention is one thing which is coming up. We are creating data. Once we have the data available to you, I'll come back to you with one of the novel hypothesis which has come from Professor Seshaya. And then, so we have to focus the fetus for the future, and that is what it is. And Dr. Seshaya has come out with some simple thing: between 9 to 11 weeks of pregnancy, just give take a post-meal blood glucose 2 hours. If it is more than 140, you should more than 110, you should treat it with metformin, and then if you treat it, you can prevent even GDM. So with this, if the glycemic control can be maximized to the extent that the fetus no longer recognizes that the mother has diabetes, then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in the offspring. So we have to act more aggressively, proactively in diagnosing and treating them. Ek jaanch se bache do jaan, just one test and you can save 2 generations from developing diabetes. With this, I stop here. This is the fruit. We always say don't cut the cake, but cut the fruit for celebrating, whether it's birthday or it's anniversary. Don't cut the fruit, cut the cake, and again educate your people across that your cake and cookies and pastries, they have high hydrogenated fat, which will not be good for your endothelium. So we should be aggressively promoting this concept. With this, I stop here. Thank you very much for your patience listening.
Thanks a lot, sir, for your elaborate and wonderful oration. Please come over, sir. And we stand much informed after your talk, and we are overwhelmed that you have accepted our invitation and has come here. Thanks once again, sir. And on behalf of everybody, all the RSDI members of Bihar, I would like to thank you for accepting our invitation. May I request everybody to give a gratitude, thanks for clap for gratitude to sir. As it is customary that in an oration there won't be any questions, we can close the session here. Thank you, sir. Please, sir.
What an honor it was for all of us to listen to the President-elect of National RSSDI. Moving ahead to the last session of this evening, I would like to call on stage the moderator, Professor Dr. Raj Kamal Chaudhary, and also the chairpersons, Dr. Muhammad Shahid Iqbal from Gayaji, Dr. Ajit Kumar Sinha, Dr. Richa Raj from Darbhanga, Dr. Abhishek Kumar Chandra, and Dr. Vijay Kumar from Digha. I would also like to call on stage Dr. Niharika, who is a consultant rheumatologist from Patna. Over to the chairpersons.
So, for this session, our next speaker is Dr. Sanjay Kumar, pulmonologist, and his topic is diabetes and the forgotten organ, is lung to target of diabetic microangiopathy. Over to you, sir.
A very good evening. First, I would like to thank the organizing committee, particularly the scientific secretary, for giving me this interesting topic, that is the diabetes and the forgotten organ. Is the lung a target of microangiopathy? In next 14 to 15 minutes, I will just give you a brief overview of the topic, and then I will discuss certain studies that has been done on this topic. Well, all of us know that diabetes is a systemic disease, and whenever we see a patient of diabetes, we look for the certain target organ damages. And those target organs are basically retinopathy, nephropathy, and neuropathy that we are all concerned about. And we don't think beyond that. Is that means that the other systems are immune to the diabetic changes? Certainly not. There are other organs besides retina, kidney, and the nerves that are being affected by the diabetic complications, and lung is one such. Why lung is being affected? Lung has the vast capillary system that is there, and that works just like glomerular filtration apparatus, where the fluid is being filtered, here the gas is being filtered. So there is a similarity between the lung and the kidney. So it has been postulated that lung is also being affected by the microangiopathy. Not only that, the microvascular endothelium has a distinct response to the oxidative stress and the inflammatory stimuli. And why all this happen? Of course, due to the few pathophysiological mechanisms. If we see the histological picture of an alveolo-capillary apparatus, you can see that not only the alveolar epithelium is being thickened, but the basement membrane is also being thickened, and there is the thickening of the capillary endothelial basilar membrane also, and at the same time the interstitium is also being thickened. Why all these happen? As we know that due to the chronic hyperglycemia, there is two pathways. One is the biochemical pathway that lead to the non-enzymatic glycolysis of the amino acids, and that finally lead to the formation of AGs. This AGs causes the collagen cross linkage, and that lead to the loss of the elasticity of the lung, so the lungs is restricted. And on the other side, there is cellular pathway where there is oxidative stress and inflammation, and that lead to the endothelial dysfunction. All these changes basically lead to the basal lamina thickening and structural changes, and finally leading to the functional impairment and restrictive pattern of the lung, leading to the reduction in the diffusion capacity of the gases. So basically what happens, there is thickening of the endothelial of the capillary basement membrane, thickening of the endothelial of the alveolar basement membrane, there is alveolar wall fibrosis, narrowing of the alveolar space, enlarged interstitium, and basically the basal membrane inflammation. All these changes lead to decrease in the ventilatory dysfunction and impaired diffusion capacity. So it makes the lungs prone to the other diseases like asthma, COPD, etc. So in nutshell, the lung function is reduced, pulmonary diffusing capacity is reduced, and peripheral airway obstruction is there, and lung dynamic compliance is reduced, and finally the forced vital capacity, all are reduced in a diabetes patient. Now I would like to mention certain clinical studies. First, I would like to mention about the review article published in 2017, that is about the potential biochemical mechanism of lung injury in diabetes. This study has shown that the evidences shows that lungs are affected by microangiopathy in both type 1 and type 2 diabetes, and it leads to physiological and structural abnormality leading to reduced lung function. But despite all the researches, the pathogenic mechanism is still unclear. A lot of pathological pathogenesis has been postulated, but basically the oxidative stress and non-enzymatic protein glycosylation is supposed to be playing the key role. And there is hypothesis regarding the mitochondrial dysfunction also. So glycation and oxidative stress along with the other pathological mechanism lead to diabetic lung injury. What happens in the mitochondria? There is formation of ROS, and that lead to the changes in the membrane potentials, so that there is opening of the mitochondrial permeability transition pore, and once this open, this again lead to the further formation of the ROS. So a vicious cycle is being formed that eventually lead to cell death and lung dysfunction. If you go to the archive, the earliest study that I can find is almost 2 decades back. That is analysis of the pulmonary diffusion capacity in patient with type 2 diabetes mellitus. It has been done to assess the pulmonary ventilation and diffusion capacity in type 2 diabetes mellitus patient to determine if lungs are a target organ for chronic diabetic changes. Various parameters like HbA1c, urine albumin excretion, fundus examination, nerve conduction study for microangiopathy, all has been done. And the scoring has been done for the microangiopathy, and 1 point each for retinopathy, nephropathy, and neuropathy was given. And it has been found that DLCO is inversely correlated with microangiopathy score as well as age and the diabetic duration. So if more the duration of the diabetes or more the microangiopathy score, the DLCO is lower. It shows that the impaired diffusion capacity in type 2 diabetes mellitus suggests lung may be a target organ for chronic diabetic pathology. Another very interesting study was done by Shia and others in 2007. They have also shown that the microangiopathy affects lungs similar to other organs, but the symptoms remain subclinical because there is a vast physiological reserve of the lungs. But still in diabetes patient we must assess the pulmonary function because these subclinical symptoms may become debilitating under certain circumstances like chronic hypoxia, high altitude, cardiac or renal failure. So we need to assess the lung function as well. And it has some clinical relevance also because chronic inhaled insulin use may impact long-term lung function, as well as if there is pre-existing lung dysfunction, it may alter insulin absorption and bioavailability. Another study by Shia and et al. Was done, published in the 2008. It has very interesting findings. If we see the end inspiratory lung volume and end expiratory lung volume in patients having, irrespective of BMI, it is being decreased. Not only that, the DLCO and the vital capacity is also been decreased if the BMI is high. The another finding of that study was that if there is HbA1c 8 or more in male and female, it is associated not only with lower end inspiratory lung volume, but also the diffusion capacity is being decreased, measured at the 90% peak exercise. And similar finding is also being noted with the advent of microalbuminuria, neuropathy and retinopathy. So it is correlated with microalbuminuria, neuropathy and retinopathy and HbA1c. So they concluded that alveolar microvascular reserves are reduced in type 2 diabetes, reflecting restriction of lung volume, alveolar perfusion and capillary recruitment. And this reduction correlates with glycemic control and extrapulmonary microangiopathy and is aggravated by obesity. Another study that is being done in India and published in 2010, it is they did the spirometry and the diffusion study in patients with type 2 diabetes mellitus and their association with microvascular complication. Although this is a very small study done on the only 45 subjects, they divided the patient into 3 groups. Group A, type 2 diabetes mellitus with microangiopathy, Group B, type 2 diabetes mellitus without microangiopathy, and Group C were non-diabetic controls. And the patients were evaluated for nephropathy, retinopathy and neuropathy, and they have been tested for HbA1c, spirometry and diffusion capacity of the lung by using plethysmography. And there has been a strong correlation with the diffusion capacity and albuminuria and diffusion capacity and retinopathy. And it has been concluded that there is reduction in lung diffusion capacity in type 2 patients with microangiopathy. Another study from India is about the role of duration of diabetes on ventilatory capacity and expiratory flow rate in type 2 diabetes mellitus, and it has been published in 2012. The 50 type 2 patients were included and 50 healthy controls were taken. And the lung function parameters were recorded. And the result found that the lung parameters that mean FVC, FEV1, PEFR, mid-expiratory flow rate significantly lower in diabetics versus control, and lung function parameters showed significant negative correlation with the duration of diabetes. So longer the duration of diabetes, the chances of the reduction of the lung parameters are more. ये मूव नहीं कर रहा है. So all these evidences shows that studies demonstrate a significant inverse relationship between HbA1c and key pulmonary function parameters. Higher HbA1c values are consistently associated with lower diffusion capacity and restrictive spirometric pattern, reflecting worsening microangiopathy in the lung. And patient with HbA1c more than 8% shows a markedly higher prevalence of diffusion defects and reduced lung volumes. This has just been published few months ago. So the clinical message is as HbA1c rises, pulmonary function falls. And we need to have a tight glycemic control is essential, not only for the protection of the kidney and the nerve, but also for the lung. So in order to safeguard the lung, we will have to have a good diabetic control just like for the other organs. So lung is a silent target organ in diabetes, and early screening and evaluation is important so in order to safeguard the lung function. Pulmonary dysfunction correlates well with the glycemic control, and tight metabolic control protects the lungs too, like other organs like kidney and the nerves. Thank you.
Thank you, sir. Very nice presentation. Please take your seat.
Thank you.
Next topic is interesting cases with prolonged QT interval. To evaluate it, I would like to invite Dr. Professor A. N. Rai, sir, all of you know about him. He doesn't need any introduction. Thank you.
Good evening, chairpersons, August audience. I think this is the last topic. Everybody is physically, mentally exhausted. And this is a full participation. We require full participation because it's a case discussion. Actually, on the my scheduled topic was interesting cases, clinical cases, prolonged acute interval. But on the request, last minute request that it should be a diabetic case. My topic has been changed to ECG-based discussion on interesting diabetes cases. So the topic has been changed. Just when I came here, they requested me to, you should talk something in relation to diabetes. So I have changed my case presentation on interesting ECG-based discussion on interesting diabetes cases. अच्छा आ गया ये इससे ना elderly my case number 1 is elderly diabetic male presenting with a severe burning pain in chest with sweating and restlessness in 3 hours came to AIMS emergency for admission and treatment. Before he could be shifted to ICU, he had sudden fit with convulsion lasting for a few seconds. His pulse was feeble and BP was not recordable. ये क्या हो गया? हो गया. His ECG is given below. What is the diagnosis? छोड़ दो इसी से हो जाए. This patient has classical acute inferior ischemia, but this case has been not presented for inferior ischemia. This patient has something else. What else? There is no P wave. In complete heart block, there will be multiple P wave. You can see tall T wave in precardial leads. Diabetes patient and last, you see there is no P wave and tall T wave. Where it can occur? Hyperkalemia. Hyperkalemia. This patient has a diabetes. This patient may have cardiac disease, coronary artery disease, also kidney disease also. So this patient, clinically this patient has acute inferior ischemia and features of hyperkalemia. It's not mandatory. You can see that other features should also be taken. That is one of the criteria. But we cannot call it tall T wave for sure. We cannot call it. These are, you see, as I told you, you cannot get all characteristic features. But if you take all the total pictures together, absent of P wave, inferior infarction, you can say inferior infarction, absent of P wave, maybe do nodalism. But the T wave changes are there. So you may not get characteristics. If you correlate all the findings, absent of P wave, because in complete heart block there should be multiple P wave and relatively tall T wave. So this is a finding. This is the biochemical features. You can see blood sugar was 226, serum creatinine 2.80 and serum potassium was 6.2. And this is a echocardiography which confirmed acute inferior features of acute inferior ischemia. Renal valve. Patient was put on TPI and hyperkalemia was managed medically by giving IV calcium nebulization, IV glucose and insulin. In addition to dual antiplatelet and 80 mg of atorvastatin, he was thrombolized by reticulase. You can see the next ECG. He recovered in 24 hours. This is the biochemical finding of the treatment. You can see the serum potassium. It has come to 4. And the ECG is again T wave there, Q wave there, but the P wave has come out, sinus rhythm. So this patient, diabetic patient, had acute inferior ischemia and features of hyperkalemia. Because and the sudden cardiac arrest was due to hyperkalemia. He had fit. He had inferior ischemia, yes. There is inferior ischemia. ECG medial as a diabetes male presenting as severe chest pain in 3 hours. What is the diagnosis? Again, tall T wave. Yes, it's a classical pattern of the winter pattern. It was also called acute anterior wall MI. Yes, acute anterior wall MI. Should we, now this patient came after 3 hours. So angioplasty, tell me, should we thrombolyze or not? It came late, so this patient was thrombolyzed. And after the thrombolysis, this is a diametral ECG pattern in anterior, it is equivalent to anterior STEMI without obvious ST segment elevation. First reported by Deventer in 2008. Key diagnostic feature of Deventer pattern includes ST depression and peak T wave in the precardial leads. Deventer pattern is seen in 2% of acute LAD in occlusion. And this is after thrombolysis, you can see there is a QS pattern and T wave disappears. So acute anterior STEMI, anterior descending artery involvement, anteroseptal. Case 3, 35 years old diabetic male was admitted with history of weakness and giddiness since morning. On pulse 40 per minute, BP 160 by 100, ECG is given below. Again, this is a classical hyperkalemia. It is a classical hyperkalemia. Severe bradycardia, absent P wave, tall T wave. Investigation: blood sugar 300 mg, serum creatinine 315, serum potassium 6.5. Patient was managed conservatively by giving IV calcium and insulin, glucose. He was advised dialysis when he did not show improvement but refused. You see what happened? Normally with medical man, when patient recovers, the first case recovered. Here, patient did not recover. So he was advised dialysis. He refused. His ECG 6 hours later shows following features. What is this? What is this? Is it VT or is it something else? This is a classical sine wave. Yes, sine wave or sine wave, classical sine wave. And if you do not manage, patient is going to die. And after this, the patient relatives had agreed for dialysis, and patient was saved after dialysis. This sine wave was due to merger of white curious complex with white T wave, serum potassium 7 millicurie per liter. Patient was saved after he agreed for dialysis. And post dialysis, serum potassium 5 milli equivalent, and this is a post dialysis ECG. So to which the dialysis he was saved. Case 4, elderly diabetic male presenting with fits since 1 day. What is the diagnosis and management? ECG is given below. What this ECG is so black? What black? What heart block he has? This patient has no RBBV with LHV, but it is classical, not LHV, something else. No. This patient has LBB pattern in the limb leads and RBB pattern in precardial leads. There is no S wave in lead 1 and AVL. It is and this we call what we call. ऑलरेडी हम कर चुके थे, गलती से हमारी स्लाइड बढ़ गई थी. Masquerading mandibular block. This is actually it is a bivascular block, it is severe block. And this patient requires urgent pacing, otherwise he is going to become lethal block. It is called masquerading mandibular block. Yes, गलती से स्लाइड ही आ गया था. Masquerading mandibular block. So actually masquerading mandibular block is RBBV with left anterior block, and there is no S wave in lead 1, and normally RBB there should be right axis deviation, but there is no S wave. And it is of two types, standard type and precardial lead type. I think everybody tired, so I am leaving it. Case 5, I am finished with this. Mid is a diabetic lady presenting with sudden chest pain and palpitation, giddiness with sweating and restlessness since 1.5 hours. And you have she had seizure shock and with cold limbs with absent pulse and BP. ECG is given below. Classical VT. Patient has DC shock. And patient has acute anterior STEMI. And manage on the line of. Thank you very much. I will complete. Thank you very much.
Thank you, sir, for informative and excellent talk. So, with both the speakers were talked their talk were informative and excellent. So, Dr. Sanjay sir have given message that if the diabetic patient came with unexplained dyspnea, and we should also look to lung microangiopathy. We should think about that. We also we focused on micro and macrovascular complications, but we should also think about the lung disease in the diabetic patient. And Dr. A.N. Rai sir shown the various ECG presentation of hyperkalemia, how the diabetic patient presented, and how different hyperkalemia patient presented in the emergency. So thank you, sir. With these comments, I would like to conclude this session. Thank you.
I thank the speakers and the chairpersons and request them to move to the side stage for felicitation. We are drowning in information while starving for wisdom. The world henceforth will be run by synthesizers, people who are able to put together the right information at the right time, think critically about it, and make important choices wisely. With these words, I would like to conclude today's session and request all of you to move to hall number B on the 7th floor for the AGM meeting. I also have a small announcement to make. The Endocrine Society of India Bihar chapter is holding its annual conference on 21st and 22nd February in 2026. So those who are interested, kindly register and get in contact with Santosh sir for the same. Thank you to everyone for your patience hearing. Now let us move ahead to the AGM meeting, and within half an hour we will be reassembling in this hall to have our inaugural function. Thank you. Good evening, everyone. I welcome you all to the 8th annual conference of RSSDI BIHAR. After an exhilarating day of academic feast served by the organizing committee, now we have assembled here to conduct the inaugural ceremony. I am thankful to all of you for showing your patience and staying with us throughout the day. I would like to invite the dignitaries on the dais for the inaugural ceremony. First, I would like to invite the President-elect of National RSSDI, Dr. Sunil Suraj Prasad Gupta sir, and I would request Dr. S.C. Jha sir to accompany sir. Dr. S.V. Prasad, take care. Now I would request Professor Dr. B.B. Thakur sir, who is past president of API and past dean of ICP, to come to the stage, and I would request Dr. S.P. Prasad sir to accompany him. ठीक है, फिर ये कमलेश सर. ठीक है. Moving ahead, I would request Professor Dr. Kamlesh Tiwari sir, who is the current Dean of Indian College of Physicians and the Organizing Secretary of APCON 2026 and past President of API. I request Vijay sir to accompany him. Next, I would request Professor Dr. A.N. Rai, under whose visionary leadership he founded the CCDSI, the Clinical Cardio-Diabetic Society of India. ठीक है. Now I request Dr. B.K. Singh sir, who is the zonal member of East Zone of National RSSDI. I request Dr. Manish Prasad sir to accompany him. B.K. Singh sir नहीं है. नहीं. Supriyo Mukherjee sir को आपसे करवा देते हैं. I request Dr. Supriyo Mukherjee sir, who is chairman of RSSDI Bihar and organizing chairman of the 8th annual conference of RSSDI Bihar, to come to the stage. I request Dr. Shaibal Guha sir, who is the chairman-elect and the scientific chairman of the 8th annual conference of RSSDI Bihar, to come to the stage. I request Dr. Subhash Kumar, who is the chapter vice chairman and chairman reception committee, to come to the stage. Now I request our organizing secretary, Dr. Vijay Kumar, to come to the stage. I request Dr. Manish Kumar sir to garland our President-elect of National RSSDI, Dr. Sunil Suraj Prasad Gupta sir. Manish sir. I request Dr. Manish to felicitate Dr. B.B. Thakur, sir. I request Dr. S.B. Prasad, sir, to come on the stage to garland Professor Dr. Kamlesh Tiwari, sir. I request Dr. Shankar Kumar, sir, to come on the stage to garland Professor Dr. A.N. Rai, sir. I request Dr. Naveen to felicitate Dr. Supriyo Mukherjee, sir. ठीक है. Sir. I request Naveen sir to garland Dr. Shabal Guha, sir. I request Dr. Shwetab Verma to come on the stage and garland Dr. Subhash Kumar. I request Dr. Shwetab Verma to garland Dr. Vijay Kumar, sir. Any organization has its roots in the stalwarts who had the vision to form it, and they laid the seeds or they bowed the seeds for its beginning. This organization, this prestigious RSSDI BIHAR, we would like to honor the patrons, and first I would like to honor Dr. D.K. Srivastav sir. For this, I call Dr. Supriyo Mukherjee sir, Dr. Shabal Guha sir, and Dr. Vijay to garland Professor Dr. D.K. Srivastav sir. Moving ahead to our next patron, it would be an honor to garland Professor Dr. H.K. Singh sir. And last but not the least, the man who has taken Bihar to the international stage of academics, our third patron, Dr. Ajay Kumar. Okay. आप ही देना ना. Now we would like to garland Dr. Basant Kumar sir. Past President of RSSDI BIHAR. Now we would like to garland Dr. A.G. Unnikrishnan from Chelaram Diabetes Institute, Pune. Next, Dr. Alok Gupta. So, he is a guest speaker from Gorakhpur. Last but not the least, I would like to call Dr. V. Nagrath, a guest speaker from Devariya. अच्छा, ठीक है. I would like to call on stage Dr. B.K. Singh sir, who is a... ठीक है. I would request Dr. Shweta Verma to garland Dr. B.K. Singh sir. Now I would request the dignitaries on the dais to come forward for lamp lighting.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्ला
Now I would like to hand over the mic for the welcome address to Dr. Subhash Kumar, who is the chapter vice chairman and reception committee chairman.
Respected chief guest, Dr. Sunil Gupta, our chairman-elect national, esteemed dignitaries, respected patrons, Dr. D.K. Srivastava sir, H.K. Singh sir, Dr. Ajay sir, and all esteemed dignitaries on the dais, senior members of RSSDI, distinguished faculty, dear delegates, and my fellow colleagues. On behalf of reception committee, it is my great honor and privilege to extend a warm welcome to all of you to the RSSDI BIHAR annual conference. We are truly delighted to have such a distinguished gathering of clinicians, academicians, researchers, and young scholars under one roof, united by a shared commitment of advancing diabetes care to the public. Bihar has a rich tradition of learning and service, and it gives us immense pride to host this prestigious event in our city. Over these 2 days, the conference will provide an excellent platform for meaningful scientific exchange, evidence-based update, and thoughtful discussion on evolving changes and innovation in diabetology. I sincerely thank our national and regional faculty who have traveled from far and wide to share their expertise and experience. Your presence greatly enriched the academic strength of the conference and to the state. I also acknowledge the enthusiastic participants of our delegates who curiously and dedicated way truly propose to such meetings. I would like to express my heartfelt gratitude to the organizing committee, volunteers and support staff for their tireless effort in ensuring a smooth and pleasant experience to all our guests. As the reception committee, we have endeavored to make your stay comfortable and memorable, reflecting the warmth and hospitality of our state Bihar. I am confident that this conference will not only enhance our scientific knowledge, but also strengthen the professional bond and inspire us to deliver better, more equitable diabetes care to our patient as proposed by our chapter chair, Dr. Supriyo Mukherjee. Once again, I will warm welcome you all and wish you a highly rewarding and enjoyable conference. Thank you.
Thank you, sir. Now I would request our secretary, Dr. Vijay Kumar, to present the secretary's report.
Good evening, everyone. Respected distinguished guests on the dais, our national and state office bearers of RSSDI Bihar, our respected faculty delegates in the hall, and pharma people. It's a matter of great privilege and honor for me to invite you all on behalf of RSSDI Bihar in the holy city of Patna for this annual conference, and being the organizing secretary of the annual conference, I welcome you all for the scientific discussions throughout the day, today and tomorrow. As far as the secretary report is concerned, I have detailed the secretary report in the AGM just now, but to highlight the few major landmarks or achievements during past 1 year, we have got one seat in national RSSDI by our Honorable B.K. Singh sir being elected for national zonal member of RSSDI. Second landmark is that GST of RSSDI was not there, permanent GST, but we could manage to get the permanent GST few months back. Then third one is that RSSDI national conferences, we are usually, though in presence of our president-elect, I am happy to share that previously RSSDI was being ignored in national conferences by being given only 2 or 3 speakers hardly, but this year we could manage 10 to 15 speakers and almost 25 chairpersons in the national RSSDI. That is also a landmark. Then RSSDI has 2 annual conferences. One is the annual conference which has in Kochi, and another is RSSDI Research Retreat. So in 2026, the research retreat is going to be held at Guwahati, and after that, we have been allotted the RSSDI Research Retreat 2027 at Bodh Gaya. So a big round of applause for RSSDI Bihar. So we have major challenges. We have so small number of members of RSSDI Bihar. I would like to encourage our PG students and all the young researchers and primary physicians to be the part of RSSDI Bihar. Though in last 1 year we have managed to swell 222 new members we have inducted, and in last 10 days we have inducted about 22 members. Based on that we have offered them complimentary registration for this conference. They have become our life members. So congratulations to those newly inducted members also. So without taking much time, I again welcome you all and for your cooperation, blessings, coordination in last 1 year, and I hope that these cooperations and blessings will continue further to strengthen our RSSDI Bihar. So Jai RSSDI Bihar, Jai Bihar. Thank you.
Thank you, sir. Now I request our chapter chairman and organizing chairman of RSSDI Bihar 8th Annual Conference, Dr. Supriyo Mukherjee, sir, to enlighten us.
Thank you, Abhishek. Respected national leadership, our chief guest, Dr. Sunil Gupta, national president-elect, our guest of honor, my mentors, our esteemed patrons, senior mentors, past chairman of Bihar chapter, past and present chapter of Secretary Bihar chapter, past and present treasurers, distinguished guests on the dais and in audience, dear district coordinators, our esteemed RSSDI members, our most respected invited faculty, press personnel, both print and electronic, pharma industry, colleagues, friends, ladies and gentlemen. It is both an honor and a responsibility to address this august gathering. Your presence today enriches this forum and reinforces the shared vision that binds us as a professional fraternity. When I assumed the responsibility of chairman of RSSDI Bihar chapter, I was deeply conscious that the leadership must always be anchored in the purpose rather than the position. In this journey, I considered myself extremely fortunate to be supported by an exceptionally efficient and committed core team. Our chairman-elect, Dr. Shaival Guha, with his calm demeanor and insightful intellect, bring clarity to every discussion. Our secretary, Dr. Vijay Kumar, has been a pillar of strength, wise and hardworking, and open to constructive criticism, playing a crucial role in transforming ideas into action. Dr. Subhash Kumar's experience, wisdom, and composure has been a constant source of guidance, while Dr. Atul Kumar's ever-ready willingness to help us often resolve challenges even before they surfaced. Dr. Anand Shankar's contribution to RSSDI Bihar has been immense and rock solid, and Dr. Manish Kumar's keen sense of finance and meticulous planning has been ensured stability and transparency in all our initiatives. I personally learned from each of them, and if I missed any name, I sincerely apologize. At this juncture, I wish to place on record our deep sense of gratitude to Dr. C. Vasant Kumar Sir, past National President, Dr. Vijay Vishwanathan, Dr. President RSSDI, Dr. Anuj Maheshwari, President RSSDI, for their constant encouragement, thoughtful advice, and wholehearted support to Bihar chapter has been a source of strength and direction in our journey. From the outset, our team has chosen to function within a simple, robust framework, which was framed by me. That is a DARE philosophy. That is a delivery, advocacy, research, and equity. A philosophy that guided every steps of our journey. Delivery was the starting point, We streamlined membership to ensure by the meaningful engagement and decentralized academics by conducting meetings across medical colleges and districts, and by Zoom meets engaging national scholars, ensuring that learning reaches clinicians at the grassroots level where diabetes care is truly delivered. Our ECMEs have gathered praises from all over the nation. I thank our national president, Dr. Vijay Viswanathan, for the constant support. Advocacy followed naturally. Through inclusive academic forum, we constantly promoted ethical practice, academic integrity, and greater involvement of young clinicians while aligning our initiatives with the national version of RSSDI. I remain deeply grateful to our national president, Dr. Anuj Maheshwari, and our patron, Professor Dr. D.K. Srivastav sir, Professor Dr. H.K. Singh sir, and Dr. Ajay Kumar sir, whose guidance has always been very, very enabling. Research became a defining pillar of this tenure. We initiated research methodology seminars, encouraged scholarly outputs, contributed a dedicated book on diabetes. And for your information, once I became the scientific chair, we had a absolutely dedicated research methodology seminar in Sasaram Medical College, and at that time our organizing secretary was Dr. B.K. Singh. That he helped immensely in doing all these points. Thank you, sir. And finally, for the first time in our chapter's history, successfully we secured a research retreat schedule on 2027, reflecting Bihar's growing presence on national academic map. At the heart of all this effort lies equity. Built on the strong foundation led by our senior leaders, our responsibility was not to repress legacy, but to elevate it with empathy, inclusion, and fairness. None of this would have been possible without your participation, the blessings of our patrons and national leadership, and the tireless dedication of our team. As we move forward, let us continue to dare to deliver better care, advocate with wisdom, pursue meaningful research, and uphold equity with compassion. And I shouldn't forget, rather, to thank my wife, Dr. Shushmita Mukherjee, for her constant support. Thank you so very much.
Thank you, sir. Our chief guest has got some urgent work. It would be an honor to have his blessings. So I request our National RSSDI President-elect, Dr. Sunil Gupta, sir, to share his words of wisdom.
Respected Dr. B.B. Thakur sir, Dr. Srivastav, I was told that you are senior to him, so I have just come to know, sir. Thank you. Well, Dr. Kamlesh Tiwari sir, Dr. Rai, Dr. Supriyo, Dr. B.K. Singh, Dr. Subhash Kumar, Dr. Guha, Dr. Vijay Kumar, my own mentor and teacher, Dr. Vasant Kumar, and Dr. Ajay Kumar, who again is like my elder brother since almost 25-30 years companionship, and he's coming to Nagpur almost every year. Dr. Unni Krishnan, very close friend of mine from Maharashtra. Dr. Jha and many other here whom I know personally. Dr. Nagraj, who was there with us last week at Kanpur. First of all, let me congratulate RSSDI Bihar chapter for all the achievements you have done. Just wonderful job. Let's give a big hand for the whole team. And it's not just the mentorship, it's not just the leadership, but the ground level worker who's so much hardworking and focused, he could do it. I could see some of the pictures of your rural village undertaking also, and there's something other than that is planned in the month of February. So there are 2 more projects which are going to come in future. What is more important is making membership, having village adopted, doing some conferences like this. I feel we have to have the consistency on these in future. And also see to it that what is the outcome of what the project we have done. Especially when you adopt a village, I'll be very much interested in knowing that in last 6 months or 3 months, what have we done. So you have to have a system that whether we have gone to that village again, how many people are going, how many patients are being seen, how many education programs we have taken. If you have this data available, that will be encouraging and that can guide the whole country. That this is how the village projects is being run, this all is being done. If you don't go, if you don't see, once we just take a picture and come, it will become like a Rotary Club and the, not Rotary, the Lions Club or other clubs, you know, where they go and take the pictures. So we are not supposed to be doing this. So we have to be very, very serious on these notes. That's first message from my side. Second is I feel research retreat is another wonderful thing, and I invite all of you. In February are supposed to be those who are interested in research, RSS on behalf of RSSDI and Dr. Vijay Vishwanathan, because research retreat is under his leadership. So I invite all of you for the research retreat. But before I forget, I also invite you for the national conference of RSSDI, which is scheduled from 19th to 22nd November at Bangalore. And today is the day when we are declaring the venue and the date. So I got an opportunity at the Bihar platform or podium. I can declare this officially that we have this meeting. And throughout the nation, it has been declared today evening from Bangalore. So that is one very important thing which I wanted to share with you. I request our president and Dr. Vijay Kumar to show that flyer tomorrow also, in maybe in between the sessions, and invite everyone so that people can get that flyer is already there with you. RSSDI has a name itself, says that we believe on research, education, guiding the whole members. Now we have almost 13,000 members. We are almost second in the list in the world of diabetologists and endocrinologists, next to American Diabetes Association. But despite that, still I feel we have a lot of things to do. We have our family physicians still. I feel even if we have all people from the allopathy background in Bihar, if we say we have say 5,000 people or 3,000 people, still how many of them they come to the conferences like this or Bangalore RSSDI or National RSSDI or National API? Very few. And even if we have 800 registration, we will find only 200 people or 100 people in the hall. That is one of the biggest challenge, not only to the Bihar chapter, but maybe Maharashtra chapter. Maybe I was talking to Dr. Vasant Kumar sir, Sunil, ये सब किस्सा तेलंगाना में भी ऐसा ही है, except some few of the states in south where you get little good attendance. So I feel we have to have some good strategies to keep this family physician into a rope and get them involved more often. Rural health care is already being taken care by most of you. But I feel we still have to have two important projects which is there in my mind as a national president-elect, which I'll be taking over from 1st of January. One is to reaching to unreached people like rural, ultra-rural, and even those who are urban people but are not at all getting attached to, despite being there in the system and the practice. Because diabetology is not being seen only by endocrinologists and diabetologists and physicians, but also seen by many of the family physicians, which need to be upgraded. And RSSDI guidelines will be coming very soon. The next one, textbook is going to be launched in RSSDI retreat. So we will have a good amount of academic material available for us. Second is, we still have paucity of educators in our country. At this moment of time, all over India, if you see, dietitians are the only group which are getting themselves, they are becoming a certified diabetes educator and trying to be there in most of the corporate. They will be there in Chelaram with Unni, they will be there with Dr. Vasant Kumar, they will be with me, maybe people sitting 10-15 dietitian in 10-15 clinics. Rest of the clinics are still without educators. So now we have to create educators so that we can bridge the gap between the patient, the person with diabetes, and a clinician who's treating them. For which I have a vision that why not nurses should be trained as educator, why not pharmacists should be trained as educator. I was discussing with sir. Sir, we have to have these two important projects which I'll be declaring today again. I'm already declared in one of the meetings. So I'll need your help. Someone asked me, Supriyo asked me, sir, aap batao kya kaam karna hai? Someone from Dr. Manish, he asked me, sir, you tell me what is to be done. There's another person who told me from last meeting, Dhanbad, na, which place? He said that, sir, we want to do something with you. I said, everything is doable, everything we will do it. And I'll need you for all these projects. We are planning to have multi-centric trials also. Good research work, epidemiological research. We have already done hypertension and diabetic foot, and we have done 1 day 1 million tests. Similarly, we will be going ahead under the leadership of Dr. Anuj Maheshwari as well as mine in next 2 years. And next subsequent presidents will also be proactive on these lines. So creating a good registry, we have in mind about type 1 diabetes and gestational diabetes, creating diabetes educators, reaching to people who have not been reached till now, and of course upgrading our membership people and making them realize that you are the member of it. What you rightly said, sometimes Bihar was not getting enough place, now it started it. So that's why I'm trying to go to all smaller states which have not been represented many of the times in the earlier days. That's why I was as more interested. Rather than you calling me, I was more interested. I have let AOCO from Delhi, and so today morning, and I'll go back, and tomorrow again I'll be there because I'm the key person there in a key organizer. So I feel these are some of the important projects which I'll need you. I should really congratulate you for involving young generation, for involving all senior people. It's very rare to see very senior people at 8 o'clock in the night in an inauguration program. I feel you deserve a round of applause for this. In most of the meeting you will get 1 or 2 people, but we have practically everyone. So that means you have the blessings of all seniors, which is going to be asset for the Bihar chapter. Once again, thank you very much for your patience listening. And I, as a president-elect of RSSDI, I promise you that you will never feel anything of what you have felt earlier about RSSDI. As far as headquarters is concerned, I'll always be one phone call away from you. Whatever, I will also commit mistake. I'll prepare scientific program and someone will say, sir, mere ko nahi bulaya, sir, mere ko nahi bulaya. This is going to be there, I know. So next year you will not call me because I have not called you. So that also can happen. But then we will try our best. Dr. B.K. Singh is there in the EC. He will putting his hand here and will say, Sunil, isko bulana hai, to mere ko bulana padega. So something like this will certainly happen. Subhash Kumar is also a very active person here in the RSSDI headquarter and other people. So with this, I stop here and thank you very much and congratulations once again. Thank you.
Thank you, sir. Thank you, sir, for your kind words and support promised. So, we would like to inform that we are first time in RSSDI Bihar. Now we have compiled all the papers or all the lectures of the authors or of the speakers and compiled in a book, that is Diabetes Update, and we are going to publish the Diabetes Update first time, and now onwards it will be published. So may I request our distinguished guest to unveil the book. Thank you, sir, for coming and blessing RSSDI Bihar. Thank you again. So now the next event is change of caller. Our new chairman-elect is Dr. Sewal Guha, and the outgoing chairman is Dr. Supriyo Mukherjee. So may I request them to come forward for caller change? Of course, Sewal sir will take charge from 1st of April, but this is a ceremonial thing that caller change should be there during inauguration. Now may I request the incoming chairman or chairman-elect or the new chairman from April 1st to kindly share his vision and roadmap for next 1 year for RSSDI Bihar. So over to Sewal Guha sir.
सेरेमोनियल होगा, ये ऐसे ही रहेंगे। हम तो नहीं जानते हैं सर। कुर्सी चेंज हो गया।
Respected guests of honor, Professor B.V. Thakur sir, Professor Kamlesh Tiwari sir, and Professor N. Rai sir, my respected patrons and my teachers, Professor Dr. D.K. Srivastava, Professor Dr. H.K. Singh and Dr. Ajay Kumar sir, seniors in the audience and dear friends. It's a proud privilege that I have been selected for this post, and it is with deep humility, immense gratitude and profound sense of responsibility that I stand before you today as the newly elected chairman of this organization. First and foremost, I would like to thank the members of the association for reposing their trust in me. I am deeply conscious that this honor is not merely a recognition but a commitment to serve, to lead with integrity, and to uphold the values on which the organization has been built. I would like to place on record my sincere appreciation for our outgoing chairman, Dr. Supriyo Mukherjee. Under his leadership, our state chapter has grown not only in numbers, but also in academic stature, visibility, and relevance. The high standards of scientific programs, outreach activities, and organization discipline that we witness today are a result of his vision and the tireless efforts of our vibrant core committee, especially my friends Dr. Subhash, Dr. Atul, Dr. Vijay, Dr. Shwetab, Dr. Naveen, to name a few. I also take this opportunity to acknowledge our senior members and past chairpersons whose vision, wisdom, and perseverance laid the foundation of our organization. We stand on the shoulder of giants, and it is our duty to carry forward their legacy with the same dedication and ethical commitment. I would also take this opportunity to thank my better half, Lopamudra, for tolerating my tantrums and my regular Zoom meetings continuing past midnight for the last couple of months, which were a regular feature these days. We know that diabetes today is no longer just a clinical condition. It is a public health emergency, a socio-economic challenge, as well as a family disease. And India continues to be at the epicenter of this global epidemic, and Bihar is no exception. At the same time, we are also witnessing an explosion of knowledge, newer drugs, newer devices, continuous glucose monitoring, insulin pumps, artificial intelligence, precision medicine, and what not. The challenge before us is not just to keep pace with advancements, but to translate science into meaningful, affordable, and accessible care for our patients. In this context, the role of our state chapter becomes critically important. Our organization must serve as a strong academic platform, a bridge between knowledge, evidence, and practice, and a mentor for young clinicians. I firmly believe that our focus should be on 4 core pillars: academic excellence, research activities, capacity building, and community engagement and outreach. Scientific meetings like today's are the lifeblood of our organization. We must continue to promote evidence-based medicine, encourage interactive learning, provide a platform and for original research and case discussions, and ensure that our programs address both urban and rural practice realities. I strongly feel that the future academic activities should increasingly include guideline-based updates with local relevance, practical problem-solving sessions, and multidisciplinary collaboration with our other colleagues like cardiologists, nephrologists, obstetricians, and primary care physicians. No organization can thrive without nurturing its younger members. Our postgraduate students, the early career diabetologists and family physicians, are the future torchbearers of diabetes care in our state. So we must encourage their participation in leadership roles, provide structure, mentorship programs, facilitate research methodology workshops, and support them in presenting and publishing scientific work which they are doing. An organization that invests in its youth is an organization that actually secures its future. At a time when medicine is becoming increasingly technology driven, we must at the same time remind ourselves that diabetes care is fundamentally human care. So let us reaffirm our commitment to ethical practice, rational use of investigations and therapies, patient education and shared decision making, and compassionate individualized care. No algorithm can replace empathy in medical science, and no device can substitute a reassuring conversation with a patient. Our responsibility does not end within the wall of our clinics. As a professional body, we need to actively engage in public awareness programs, science screening camps, school and workplace education, and advocacy for policy support in diabetes prevention and care. And thankfully, our RSDI as an organization is doing all of these. Dear colleagues, the strength of this organization lies in its unity. Differences of opinion are natural when multiple minds are at work. But our shared goal, which is improving diabetes care, must always unite us. Let us work together with mutual respect, transparency, and open communication. As a chairman, let me assure you that I will strive to be accessible, inclusive, and receptive to ideas from all sections of our membership. The journey ahead is definitely challenging, but I am sure it will be immensely rewarding. With the guidance of our seniors, the energy of our younger members, and the collective wisdom of this august body, I am confident that our state chapter will scale greater heights in the coming years. So let us move forward together with our knowledge in our minds, compassion in our hearts, and service as a guiding principle. With these words, I again welcome you to this conference to enjoy the academia, to interact, and to enjoy our hospitality. Thank you. Jai Hind, Jai RSDI.
Thank you, sir, for sharing a vision which will not only strengthen the organization, but also encourage the postgraduates to become members and contribute to this august organization. Now I request our East Zone member of National RSSDI, Dr. B.K. Singh, sir, to share a few words with us.
Thank you, Abhijit. First of all, My pranam to our patron, Dr. D.K. Srivastava sir, Dr. H.K. Singh sir, Dr. Ajay Kumar, and three stalwarts of API and CCDSI, Dr. B.V. Thakur sir, Dr. Kamlesh Tiwari sir, and Dr. A.N. Rai sir. मैं चाहता हूं कि सबसे पहले इन लोगों के लिए जोरदार तालियां बजाइए। जो नाश्ता भी कर रहे हैं वो भी जोरदार तालियां जरा बजाइए। एक बार सर कहना शेयर करना चाहूँगा कि कुछ महिलाओं ने मैं उन पर कमेंट किया कि आप तालियां बहुत ज़्यादा बजवाते हैं। लेकिन तालियां बजाने से लोगों का मन प्रसन्न हो जाता है और डायबिटीज़ का ग्लूकोज तो डेफिनेटली घटेगा। जी सर, फिर से तालियां बजाइए मेरे लिए कम से कम। डॉक्टर सुप्रियो, डॉक्टर शैवाल गुहा, डॉक्टर विजय, सहयोग से डॉक्टर राजय जी नहीं है, अभी चले गए, बट इनके लिए एक शेर है। जिन्होंने सपना देखा था, अजय जी ने पहली बार जब इसी शहर में RSSDI का फॉर्मेशन की नींव रखी थी, तो उस समय एक सपना देखा था कि जब हौसला कर लिया ऊंची उड़ान का, जब हौसला कर लिया ऊंची उड़ान का, फिर देखना फिजूल है कद आसमान का। उस कड़ी में, लेकिन तालियां किसी ने नहीं बजाई। हाँ, थैंक यू सर, थैंक यू सर। तो मैं अपने पास्ट प्रेसिडेंट डॉक्टर हेमशंकर शर्मा जी का, डॉक्टर अजय कुमार, डॉक्टर संतोष कुमार सिंह, डॉक्टर अजय कुमार सिन्हा और सभी को बहुत बहुत धन्यवाद देता हूँ। मेरे लिए ज़्यादा कुछ कहने के लिए है नहीं, बट जैसा सुनील गुप्ता जी ने कहा कि मैं आपके और सेंट्रल RSSDI के बीच का एक कड़ी हूँ और मैं कोशिश करूँगा कि वो सारी इच्छाएं जो भी आपने मेरे लिए देखी होगी या सोचते होंगे, मैं उसमें खरा उतरूं। सिर्फ इसी के लिए मैं प्रयत्न करूँगा और मैं चाहूँगा कि आप लोगों का जो सहयोग बराबर मिलता रहा है वो हमें मिलता रहे। इसी आशा के साथ, इसी शुभकामनाओं के साथ आपका बहुत बहुत धन्यवाद। आप लोग का फिर से आभार व्यक्त करता हूँ। बहुत बहुत धन्यवाद।
Thank you, sir. It is indeed a privilege and honor to have our very own at the national stage of RSSDI. Now, moving ahead, I would like to call Professor Dr. A.N. Rai, who is the founder president of CCDSI, and the guest of honor.
Thank you, Abhijit. Dignity on the dais, off the dais, dear colleagues, outset I would like to thank the Panache committee, especially Dr. B.K. Singh and the immediate past chairman, Dr. Supriya Mukherjee, Dr. Shaival Guha, the chairman, though they will take charge in the first week of April, and Dr. Vijay, organizing secretary. I think every conference, even if you are old, you learn something. Medicine is such a thing that every day there is a new development. And even if you are 10, you always come to know certain new things, which is going to benefit your patients and society. Eventually, ultimately, our aim is to benefit the society. By attending a conference, we come to know new things which we can use in our patients. I must congratulate for excellent scientific program. And tomorrow also I expect we are going to have similar program. With these few words, once again I thank the organizing committee for giving me opportunity. Thank you very much.
Thank you so much, sir. Now I request Dr. Kamlesh Tiwari, sir, who is Dean of ICP and the Organizing Secretary for APCON 2026 and past President of API. He is also our guest of honor to give his blessings.
Thank you. Respected Dr. Thakur, Dr. Rai, dignitaries of the dais and dignitaries of the dais. I am very much thankful to the organizing team who has invited me here as a guest of honor. The organizing team, the name I saw is Supriya Mukherjee, Vijay Kumar and Sahwal Guha, and incidentally all three are my close students. So I became very glad. I think they have done their job marvelously. Organization is very good, scientific program is very good, and on the whole this conference is going to be a successful. Nothing much I can say about that. Thank you very much.
Thank you, sir. Now I request Professor Dr. B.B. Thakur, sir, who is the past President of API and past Dean of ICP and a guest of honor, to give his words of blessings.
Good evening, friends. I have a lot to say, but you see, Dr. Tiwari said there are 3 students of him who are sitting on the right side. I will add, I have 4 students directly taught, 1 sitting on the left side. That is Dr. Tiwari. I am privileged to be his teacher in 1970-71 at RMCH. So friends, we have been listening about diabetes. 110 million, then pre-diabetic, 15 million, 15 million a year, 13 to 15, 150 yaar, 130 million. Pre-diabetic, 130 million yaar, 110 million, 130 to 150 million. That is pre-diabetic case. That is what we say. But I have certain questions to put to you people. Is that food that is served tonight is conducive to diabetes? No, sir. It will not be conducive to diabetes. Maybe very intelligently you knew what I am going to tell, so you might have got it. So all the dignitaries are sitting on the dais. Vijay, very good student, very good organizer. Shaibal, one of our top students. Supriyo, Shaibal, Dr. Tiwari. Morning shows the day I could know in 1971 only that he will surpass me, and that he has done. N. Rai sir is close to me for last 35 years. Although he is 1 year junior to me, but he became professor earlier than me by his sheer luck. And I had some help in that, which I have never told to him. BK is a very good organizer, very good friend, very good junior, like a student. Subhas is a great person. And all the delegates are so great because without you, the conference cannot be a success. And then the glittering ladies are making it so beautiful. One of them is my wife also. And those who are eating, I will advise them to know that they are not eating what they should not eat. So friends, I have to tell you something. Do we have time to eradicate, to control, to prevent diabetes? No, we don't. We all doctors are in the number game. अरे आज मैंने 60 मरीज देख लिया, आज मैंने 70 देखा है बॉस. And are we doing what we should do? So diabetes is coming to this state only because of, I will say, us. We have not done our duties. And we are not doing our duties. For God's sake, change that behavior. It is because of medical, it is because of social, it is because of systematic reasons that this is the state of affair. Friends, I had a lot to tell you, but I will just conclude in few sentences that my friend Dr. Supriyo and Sabal both have said nothing less than empathy, compassion, partnership, है ना? Not parenting with the patients. We have been parenting during our young age, but now the days has changed. It is time that we should make him a partner. You just believe it or not, I always try to emphasize on my patient, I am useless, you are the main person. God has sent number one, your attendant has brought him here, 2, you are the third, I am the fourth. Third is better than fourth. 3 comes earlier, I tell them. I say, your earlier doctors have not succeeded only because of one thing, that they thought they are the healers. They will cure you. I tell you, I cannot. If you wish, you can walk away. You have to be a doctor. I mean, doctor नहीं बोलते हैं. You have to take care of your health. And all of you, many of you might be knowing that future doctor, it is said, the future doctor will not write drugs. Then what will he do? How will he treat? He will treat his patients by lifestyle medicine, of which we talk a lot. Lifestyle medicine, lifestyle disease. So friends, kindly change, kindly be empathetic, do have compassion, individualize your therapy, and don't go on a step ladder therapy, stepwise therapy. छोटी सी गोली दे देंगे डायबिटीज का, भाई इसको तो हो ना जाए कुछ. So assess, and you may go for the double dose, 2 drugs from very beginning, considering the level of blood sugar, etc., etc. And if we emphasize about the lifestyle medicine, that many of you might be knowing that it is to inform, encourage, educate the persons, the individuals, to the country, community, etc., etc., to take charge of their health. Friends, we have been listening that we go to the rural place. Do you agree that the teaching that has been done for the last will be done in the last today and tomorrow is going to be translated into the reduction of the cases of diabetes? I am pretty sure no. Those who need the education are in the villages, are in the towns. So please take care of all these aspects. When I was a dean, I had gone for a survey, physicians' health survey, and startling facts came out about the health of doctors. And 2 days back, I again read an article in one of the papers that the doctors are the most ill doctors. Diabetes, hypertension, heart disease, obesity. And if you make a survey of obesity in this hall also, a lot of people will be obese and they would be eating a lot there. So friends, choose a diet which is conducive to your health. Manas sannad karmanandad, vachas sannad karmanandad ना करो यार. जो बोलो सो करो और जो करो सो लोग से कराओ. गांधी जी यही कहते थे कि जब करते नहीं हैं तो हम कहें क्यों, एडवाइस क्यों करें. And it's not the last. I thank and I congratulate the volunteers who have been helpful in organizing everything. Then the pharma people, and most importantly, the master of ceremony. You have wonderfully done. You have wonderfully conducted. My blessings to most of you, or I will say, since Dr. D.K. Srivastava has gone, now I can say my blessings to all of you. Because all are younger than me. I am privileged to be here. I am privileged to have been invited by my students. Thanks a lot. God bless all of us.
In the age of investigative medicine, it is indeed a proud privilege that we got to hear from three senior skilled clinicians of our state, Dr. B.B. Thakur, Dr. Kamlesh Tiwari, and Dr. A.N. Rai sir, who used to diagnose diseases without much reliance on investigations. I doubt our children will get to hear from purely clinical clinicians who diagnose diseases without much reliance on investigations. So thank you, sir. Now, moving ahead, I would like to hand over the mic to Vijay, sir.
Before we conclude the award session, every year RSSDI Bihar, usually based on the recommendation of Credential Committee and recommendation of chapter chairman, usually the RSSDI Bihar is giving Chairman Appreciation Award. So this year the award goes to two important members of RSSDI Bihar. First is Dr. Atul Kumar. He is not here, so may I request in his absence Dr. Sanjay sir to kindly receive the Chairman Appreciation Award. This award is based on the contribution of Dr. Atul Kumar towards the organization and to overcome the financial glitch of RSSDI Bihar. He is the member finance committee. So big round of applause for Atul Kumar sir, and Dr. Sanjay sir will receive the award from our guests of honors. So a big round of applause for Atul sir. Now the second award, actually there was a hypertension campaign planned by RSSDI National. That is a 1 month long campaign, and most of the states, they were filling the data, all the members, they were filling the data of hypertension in diabetes patients, and Bihar was also contesting in the hypertension challenge. That was a 1 month long campaign, and up to 28th day we were standing on 5th or 6th, but in last 2 days we have done tremendous work, and at the last Bihar stood first in the hypertension challenge among all the states, and we have almost surpassed Tamil Nadu, Andhra and all the states who are veteran in this field. We have surpassed that, and the contribution and the major contributor of that challenge was not only from Bihar, from whole of the country. The major contributor was Dr. Naveen Kumar from Darbhanga. He is the EC member also. So may I request our guests of honor to felicitate Dr. Naveen Kumar with this Chairman Appreciation Award, and a big round of applause for Dr. Naveen Kumar.
Great.
उसको बुलाइए श्रोता। हाँ जी, वोट ऑफ ठीक कराइए।
Thank you, sir. Now moving ahead to the last agenda of the inaugural ceremony, I would request the Joint Secretary, Dr. Shwetab Verma, to give his vote of thanks.
Good evening, everyone. Distinguished guests, learned faculties, and dear colleagues. As we conclude the first day of the academic feast at Hotel Panache, it is my distinct honor to deliver the vote of thanks for the 8th annual conference of the RSSDI BIHAR chapter 2026. Over the 2 days, December 20th and 21st, you will approve that you have lived our theme, that is equity first, innovation always, and research forever, through every debate, oration, and discussion. Our deepest gratitude goes to our visionary patrons, Dr. D.K. Srivastava sir, Dr. H.K. Singh sir, and Dr. Ajay Kumar sir, whose wisdom continues to light our path. We are grateful to the vision and mentorship of Dr. B.K. Singh sir, whose leadership at the national level continues to inspire us. We are equally indebted to our chairman, Dr. Supriyo Mukherjee sir, Chairman-elect Dr. Sehwal Guha sir, and Vice Chairman Dr. Subhas Kumar sir for their unwavering leadership and steady hand in steering this chapter towards new heights. A special word of appreciation for our organizing secretary Dr. Vijay Kumar sir, along with Finance Committee Chairman Dr. Atul Kumar sir, Chapter Treasurer Dr. Manish Kumar Prasad sir, whose meticulous planning transformed a complex vision into this seamless academic extravaganza. As an event of this scale is impossible without the rock-solid partnership of the pharmaceutical industry, we extend our sincere thanks to all the partners from the pharma industry for their steadfast commitment to advancing diabetes care in Bihar. A big applaud for the pharma industry. We also owe a debt of gratitude to the members of the media for their vital role in spreading our message of diabetes awareness to the masses. The soul of this conference, however, remains its scientific rigor. To our eminent speakers and chairpersons, thank you for sharing the latest in precision medicine and metabolic care. And to our delegates who traveled from across the state, your presence and participation had made this event very truly successful. As we look towards the 2026 calendar and beyond, we do so with a renewed sense of hope. I am sure we will leave the venue more productive, more connected, and more committed to our mission, carrying with us a renewed spirit of collaboration. We look toward the future with the hope that our upcoming events will be even more productive and transformative for the people we serve. Thank you all for all being the heartbeat of RSSDI Bihar. Thank you once again.
Now we conclude and invite all of the guests for dinner. So before we disperse, sorry, my apology. Before we disperse, we should stand for national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Please proceed for the dinner.